Leading High Performance Health Organization, LIHO in short, as the first name goes, it's about leadership, and it's about leadership in healthcare. The approach we have taken is a responsible leadership, but we are saying leadership is not a noun, it's not what you are. Leadership is a verb, it's what you do. The approach we take in LIHO is you as a leader create the atmosphere for people to solve their problem. You as a leader, if the problems were easy, they would already have been solved. So by the time you're coming in to address a problem, we recognize that it is a difficult problem. And difficult problems require learning. They require a new way of thinking and a new way of doing things. This is called the adaptive leadership approach. And the LIHO program is based on that philosophy.
My name is Dr. Willie Sakwale. I'm a medical doctor by profession. Currently, I'm a special advisor to Kenya's End Malaria Council, and I also serve as the chairman of the COVID vaccine task force. Now, one of the things is I reflect back to the time when I started my career in medical profession as a medical officer. 2 to 3 years after I graduated, I was made to be in charge of the district. We called them then district medical officers of health. And that position had a lot of requirements. All of a sudden, without any training, one was responsible for financial resources, human resources, day-to-day management of health facilities. And definitely these are skills that one did not have. And we did a lot of learning on the work, and it wasn't easy. The learning curve was very steep. And then got to the Ministry of Health, where I was in charge of programs, starting with the malaria program, but I also managed all the infectious disease control programs like HIV, TB, and malaria. And these particular programs definitely require a lot of leadership and management skills. So that is why I made a purpose to enroll to the LIHO program, so that I could enhance my skills in not only leadership, but also management.
After we've taught you about leadership, then we go further and situate your leadership practice. So we start broadly by looking at the global scenario. What happens in the rest of the world, and how does it impact your clinic or your hospital or your dispensary or your pharmacy? From there, we look at the global players. We look at WHO and other United Nations organizations. We look at CDC. We look at the global organizations and how they impact you, and how can you collaborate with them in addressing your local leadership issues in your organization. From there, we come narrower and we look at your industry, your local environment. How are you in relationship to the government, county government and central government? How is that impacting you? How are your competitors impacting you? How are your collaborators impacting you? Then from the local environment, we bring it down to the institution. So we look at how do you manage your institution? And lastly, from the institution, we bring it down to the individual. How do you manage the individual? So if you look at it, would have taken you from how do you manage the individual in the institution, in the Kenyan environment, in the global environment, with this adaptive leadership approach.
The experience with LIHO was exciting. It was eye-opening. I learned a lot, starting from learning myself and my leadership style, and learning to interact with other people and their leadership style, and just that understanding of everyone brings their strength to the table, and none is less than the other. And it was through those case scenarios and through sharing with my classmates and the networks that I created in that class that was the most exciting for me.
I view this program as one that really tries to define leadership and management in a very practical way. The course is in such a way that you get case studies that help you to think outside the box, case studies that really try to bring out true situations. And then from there, you go back to your place of work and you go through a mentorship. You are now trained just based on where you are working. some of the concepts that you learn in class then are deployed there.
My current role is a global role. I oversee safety and quality education and training, strategy and direction for our programs in over 70 countries. My team is based in New York. I sit in Kenya. The course prepared me with that confidence of I have the tools that I need to do this job. And it helped me overcome the imposter syndrome much faster than I would have had I not been prepared with some of the facets that I have. I keep going back and referring to the notes that I have from the course. I keep going back and calling some of the classmates that I had and asking, how would you handle this, and just learn from them. So in addition to just being optimized in my leadership, I have a network of peers that I can rely on for guidance when I'm stuck.
The LEHO program is leading high-performance healthcare organizations. So it's not just hospital, it's any health organization. So it will target public hospitals, it will target private hospitals, it will target faith-based organizations, non-governmental organizations. In fact, the usual class is a mixture of doctors, nurses, pharmacists, people working with the UN, people working in the NGO. So it's a very nice mix that enriches the class.
I think a lot of people get into boards because they have a certain expertise. But I think when you do a program like this, it gives you a good oversight of what the ideal situation should be. It will probably bust a lot of myths that people have thought about boards. It will also challenge you to really ask yourself, am I being the best that I can be on that board? It's one of those that challenges your effectiveness on a board.
This is one of the best programs, as far as I could gather from our members, going through to understand what is required to become an effective director. We covered corporate governance, we also went through financials, and we also went through the key behaviors that are required for an effective director.
I think for me this is one of the programs I would say very powerful. I think it's a program that anyone sitting on a board should attend. And I think for me it was very effective in 3 ways. Firstly, I think the content and the way the course is conducted. A lot of the richness of the program comes through the interaction within the team. And I think having a diverse group of people sitting on private sector boards, people sitting on public sector boards, I think that brings a lot. That coupled with the facilitators, it was evident that all the facilitators are definitely experts. All of them have hands-on experience in working in boards. So I think that also comes through. Thirdly, the network, because programs like this is not just about learning, but also about networking, so that you can learn from others and you just build your own network of contacts to use in the future. So I think those are the 3 levels that I really enjoyed the course on.
There's a lot of information that I've gathered from this training that I believe if I apply back in the farm, we are really going to have a lot of positive things.
The case studies, they bring in the practical aspect, what is happening, and some of the cases, they sounded real, and we could quickly relate it to what is happening in the society. The finances which I have learned, basically, they have been quite very minimal. But coming to this board, this board training, then basically we were taken through the key areas which you need to watch as the board. Yeah, you will be given a statement by the management. Yeah, you look at the positives and you look at the big numbers and you say, wow, we are making profits. But again, what we were told yesterday was that the profit is not the end thing. Basically, there are certain areas which if you look at them, then basically they'll be able to tell you whether you are sound or not sound.
This program is so effective. It is needed in our countries, because for us, we have the responsibility of changing Kenya, changing East Africa, and changing Africa. And it can only change when the directors understand their roles that is required for them to become very effective.
I've been about 7 months, 8 months now in my role, and I report actually to the board chair. And this is the first time that I'm actually doing this kind of reporting line where you actually report into a board. So for me, I think, doing this course was very, very timely, because it has helped me to understand the board more. And by understanding the board more, and we place a lot of emphasis on the role that the chair does play in the board, will help me and has given me insights to know how best to manage the board. And also, as a sitting-in member of a board, how more can I be effective other than just coming to represent management. I think there is a more powerful role I can play as management sitting within the board.
One of the key plans that we have in the business is to improve our overall governance system. And governance begins with management and ends with the board. And we did find that we had a gap in terms of understanding of what governance is among senior management team, and how senior management team can improve to make it easier for the board to govern us. So we thought there was need that we look for training, and we do feel that it's been a great training, and we shall be able to improve on how we engage and interact with the board, and in that course, improve the overall governance of the business.
I was really impressed with Strathmore and the setup. I thought the delivery and the participation was really good. I enjoyed the interactive way that the different topics were handled with the different presenters. Each one of them presented in a different way, but I think achieved what we really came here for. So from Amref Flying Doctor's point of view, I thought it was, from a value add point of view, ticked all the boxes.
For us to be here as a team in a very easy setup helped us to, to relate and to see everybody in their natural setting. For me, that's a plus. And Strathmore just offered the best thing. I mean, you went overboard. I was wondering, with these virtual meetings, will this come through? But you did a good job. The 2 days that we did it virtually, you gave us the best. It was quality, we learned. And then the in-house one was excellent.
In as much as the board usually has an oversight role, management has a very great role to play. So preparing for board papers, preparing, board etiquette, those are some of the subjects we learned in the second module. But even before that, just getting to understand who I am. I remember we did Clarity 4D profile, and you know, those color presentations of who I am really just made me understand who I am, you know, just understand more about myself, and most importantly about the team that I work in. So that synergy, and you know, you understand that we have different personalities, the way we lead, the way we manage is very different, but you know, there's a way we can meet halfway.
There's a lot of mystery behind board and board leadership. It demystified that. It gave me an opportunity to see from where they are seated, how I'm able to make a difference in how I deliver, how I communicate to them and make their work easier. Just to know time management, effectiveness, the flow makes a whole lot of a difference.
Strathmore, you know, Strathmore is a powerhouse in education and training. And we didn't have to think too hard about where to go. But also through referrals, through other people who've taken this course of send their teams here for training, and the feedback that we got, that it was comprehensive, it was detailed, and it was productive, and that they've seen changes in their teams after they attended the course. So that's the main reason why. And as an old boy of Strathmore, there has been a lot of changes here, and really, really incredible, and very proud to see what Strathmore is today, you know, from a small Strathmore College.
Good morning. Good morning, ladies and gentlemen. Good morning once again. Apologies for the slight delay in starting our proceedings. Nelson is my name. I'll be your host for today's event. I'd like to really appreciate you for keeping time and being here. We are expecting the Cabinet Secretary for Health, who will join us shortly. So a few housekeeping rules. The washrooms are towards my left and right. The gents towards my left, ladies towards my right. As you go up the building, they keep interchanging. So welcome today as we discuss. It's the annual Healthcare Summit, and this year's theme is healthcare financing, and we have lined up a series of panel discussions, a series of talks in line with healthcare financing. I hope you're excited to learn about this and you're ready to join in. I hope you are. I can't hear smiles. You're too quiet. Is it too cold or something? All right, no problem. We have insightful discussions going ahead, and we'll like to really appreciate you. At this point, I'd also like to appreciate our sponsors for this particular event. We have Farm Access Group, we have Illumina, we have ThinkWell Global, we have NHIF, who is our sponsor for this particular event. So at this point, I'd like to welcome a gentleman who has extensive experience. He has done over 100 publication abstracts in the international peer-reviewed journals in the broad base of clinical pharmacology, drug quality, and policy. He holds a PhD in pharmacokinetics from the University of Liverpool, UK, and a Bachelor of Pharmacy and MSc in Informatics from the University of Nairobi. He has been a member of the Technical Advisory Committee of GSK on anti-malarial drug resistance and a member of editorial board of malaria. Over the years, he has taught concepts of drug supply management to over 200 healthcare managers from Kenya, Uganda, Tanzania, Sudan, Malawi, Namibia, Ghana. He was the lead editor for the comprehensive treatment formula for HIV, AIDS, malaria, TB in Eastern and Central Africa. He currently is a professor of health system research and director, Institute of Healthcare Management at Strathmore University Business School. A round of applause to Professor Gilbert Kolkaro to give us the welcome remarks.
I was wondering who that was, eh? Good morning. How many of you don't know me? How many don't know me? Oh, then you are born in the 70s, no problem. So my name is Kokwaro. I'm your senior host. I came here 2014 after leaving University of Nairobi. I was a full professor at University of Nairobi several centuries ago. I'm now into health systems. So a very warm welcome to all of you, those of you from academia, industry, Ministry of Health, sponsors, and I hope there are some people also joining us from the diaspora. Are there people online? Anyway, welcome all. Yes. Welcome, welcome everybody. So I won't take too much time. I'll just give a few introductory remarks. With your permission, it will not take much. A few slides just to set the space. Can we have the first slide, please? Yep. Next slide. The slide is not very clear, but I think those of you who are not used to health systems, this will help you so that you participate rather than attending a workshop. There's a difference between just attending. I want the youngsters to pay particular attention. So this one summarizes the general structure of the health systems. Just look at stream A. I'll show you, if you allow me. Stream A. This is where things begin and that is where things go wrong. Most of the time, without us knowing. That is the pillar of the health system. Anything else depends there. So that's really where we talk of governance, leadership and governance, policies, financial policies, and more importantly, look at A3, alignment of the health systems to the needs of the people you want to serve. Period. If you don't align those, the rest of the things is academically interesting, but practically irrelevant and boring. We get it? Yes. Next slide. Now, if you want to get, if you're a policymaker, you're a lecturer, you're running your own institution, this is the slide you need in life. I'll summarize it for you and pay attention. Function determines structure, and structure determines resources. That's it. Determines structure, and structure determines resources. Whether you are at the Ministry of Health or you are running your own facility or you are in the county, that is the question. If you may recall, we have had cases of, I'm not referring to any particular institution, of facilities put up, and then things go wrong. And then we set parliamentary committee to probe. Usually what happens is a structure is put up and we try to look for the function. Are we surprised if things go wrong? No, this is the thing. Function determines structure. Structure determines resources, including financial resources. Now the function is determined based on the population. It should be aligned to the needs of the population you want to serve, whether it is national, county, global, that's what it is. Once you do that, then you can now go to resource. And look at the box of resources. One of the problems we have there is inefficient use of available resources. And I hope some of the talking points here will not just be about finances. Finances, funds is not the problem in Africa. You'll be surprised how much money we have. It's how we use it that's the problem. So efficient use of available resources, including human resource for health. Those are some of the challenges. I hope these will be some of the talking points. And once you do those and align them, then you can now go back and say, look at the outcomes and outputs. Otherwise, it doesn't work. So I hope, next slide. Next slide, please. For those of you who come from Kenya, we also did what we call devolution. Most of my introductory will be focused on D. Now, devolution has got its own challenges. From the centralized system, where it was more of top-bottom, you can see it from the left-hand side of the slide, to the right-hand side, the devolved system, where, in fact, the foundation should be there, at the bottom. Strong policies, strong sets of standards, and strong oversight. That's what it's supposed to do. If that is put in there, then the devolved system can work. Again, some lessons to learn. That is the other D. Let's move to the next D through the slide. I think sometimes we forget that we are now undergoing a transition, a donor transition to be more specific. We transition from a low-income country to lower middle-income country. It's going to pose challenges. Let's just say it. That's the next D. It's going to pose challenges because some of the areas in the health sector where donors were giving us support, obviously are going to be transitioned to be supported through domestic financing. And we are struggling there, and we are going to struggle. As you see in the next slide, please. That slide is not very clear, but if you look at donor dependency ratio, any figure that is greater than 0.25 means that we are donor dependent. Those figures are 0.6, 1.1, 1.1. It means we need to arrange how to fill those gaps as we are weaned off from a lower middle income country. I hope this will be talking points. Lastly, last slide, please. That's just show the way we are dependent on. This one, donor dependency is also related to something called donor concentration, where a few donors finance or support more than 80% of our health programs. And that slide actually summarizes. Again, we are going to be weaned there. You can't discuss health financing if that is not the background. Otherwise, it is misaligned. Okay, last slide, if any. Now, this is another way of looking at health systems. And in the context, we have mentioned it, but it is not probably focused enough. According to that slide, the health system has got two arms. The upper arm, the light yellow, is the preventive, promotive, rehabilitative arm of the health system. If you can allow me to explain to you, this is important, and this is where we are also struggling. We are struggling. Unless you invest in that upper arm, the lower arm collapses. And what does it mean? That throughout life, occasionally we fall sick. And if we do, we should come to this light blue arm, which is the curative arm of the health system. Hopefully, it is well resourced so that the diagnosis, treatment, and recovery can then help us to go back. What is the current situation in Kenya? Especially, some of us died there and never come back, especially the children and expectant mothers. Now, it is unsustainable if you are sitting in that part of the health system and waiting. People will come until the health system collapses. So the message is that we need also, as we talk of health financing, to make sure that promotive, preventive, and rehabilitative health are supported. Those are the center of gravity of universal health coverage. And if you do that, then in the unlikely event that you need to go to the illness bit, you are sure of a functioning bit. I hope that is now clear. Again, as we go, these are talking points, but it's a simplified way so that we don't just talk about financing. We need to put it within the context. Ladies and gentlemen, I think with those few remarks, can I now welcome Anastasia to take from me? I hope my lecture, there's no cut, so nothing to worry. Anastasia, karibu sana.
Thank you, Prof. Thank you, Prof. Once upon a time, I almost became a student of Professor at the School of Pharmacy. Luckily, that time he was a student elsewhere. By the time he came back, I was already a graduate pharmacist. Thank you for those remarks. Good morning, everybody. Thank you for being here. We really, really appreciate your time for supporting us with this initiative of Strathmore Kenya Healthcare Federation and supported by the Kenya National Health Insurance Fund. So I just want to give you a bit of genesis of how this came about. Where's Dr. Mulongo? Dr. Mulongo, you're in the house? Yes. Maybe you can stand for people to see you. In 2020, in the midst of COVID, NHIF was not reimbursing for COVID. Private sector was not reimbursing for patients who have COVID. It was a nightmare. And then KHF was mandated by our members and other partners to really look at how can you have a conversation between the payers and providers. So Dr. Mulongo was kind enough to provide his subject matter expertise on that. And we started off with the private sector, both the payers and providers, to really look at how can we, what are the issues and what are the recommendations in terms of what needs to be done. And he produced a very excellent policy brief, which we carried forward on a phase 2. And this phase 2, the first phase was funded by CIFF through AMREF. The second phase was funded by, so the second phase we got WHO on board. I don't know whether Mr. Brendan is here. Brendan? SPAC. Do you have the SPAC team around? And ThinkWell. And in this second one, we were challenged by the partners that health financing is not just about private sector. We have to bring on board everyone else. In the first phase, we also have faith-based, but we didn't have public sector. And that's how we reached out to COG, we reached out to the Ministry of Health, they gave us a letter of support. And we reached out to NHIF, and since then the conversations have just been very enriching. So we've been able to come up with the second phase with a policy brief, and it will be presented in a few. The policy brief will be presented as part of this session so that we can see what are the things that came out from there and what do we need to do about them. Now, collaboration between Strathmore and the Kenya Healthcare Federation. Prof may have told you that we have a whole lineup of activities, and I know Dr. Ben Goy, when he comes, he'll tell you what is lined up for next year. We literally want to have a conversation about topical issues every 2 months, and then it will culminate into the end of, into a major event. The major event will be in May, which will be similar to what we did this year, basically showcasing the stuff we have on, on the health sector around innovation, investment, and so on and so forth, like we did in May this year. Now, the reason I'm telling you this is because this is the last of a series for the year, and we shall be engaging a lot of you during the course of this, and would like you to give us input in what is it that we need to talk about, or what should inform our conversation as a partnership, and of course open up to more partners to come on board, and especially the unions and the professional associations and societies to be part of the conversation and shape, co-create the stuff that we're going to talk about. Back to the agenda of the day, we are delighted to inform you that the Cabinet Secretary, Honorable Susan Wafula, has confirmed she'll be coming. She'll be slightly late. We're also expecting the NHIF CEO. Again, he is confirmed he'll be coming. He'll be slightly late. But I'm glad to let you know that the context-setting subject matter expert, Professor Edwin Barasa, is around. So without further ado, I want to welcome Dr. Barasa, Professor Barasa, so that he can take it on from here, set up the context as we wait for the chief guest to come. Once the chief guest arrives, we will just go into the opening ceremony. Karibu sana, Prof. You have slides.
So good morning, everyone. As Dr. Nyerita just mentioned, my name is Edwin Barasa. I work for Kemri Wellcome Trust. I'm a health economist and a health financing expert. So my role, as I understand it today, is to essentially set the scene. I've looked at the program that's been laid out over the next 2 days, and it looks like it provides for ample opportunity to deep dive into the issues, into the context and into the issues around health financing in the country. So my role is really just to provide a little bit of context that you can use as you go forward. And the way that I will do this is to talk through a couple of slides that span your health financing functions. So talk a little bit about revenue mobilization, how it looks like in Kenya, what are some of the challenges that the country faces, to give you an idea of what do you need to be thinking about when you're thinking about solutions and the way forward. We'll talk about pooling, how does it look like in the country, and also talk about purchasing and a little bit of PFM. So if someone could put the slides up. So whenever we talk about, unfortunately, the slides don't look that clear for some reason. The resolution is not that strong. So whenever we think about revenue mobilization, the idea is how do we mobilize additional resources for the health sector? But before you even think about the health sector, you have to think about the country as a whole and ask yourself, what is the fiscal space in the country from which you're going to be able to mobilize additional resources to the health sector? And there are several indicators, there are several ways to assess a country's fiscal space. What I have in front there is essentially just a snapshot of indicators. So we have 3 indicators there. We have, the country's expenditure to GDP ratio, tax to GDP ratio, and debt to GDP ratio. And what we see in the country is that your expenditure to GDP ratio and tax to GDP ratio is below 15%. And the rule of thumb essentially tells you that when those 2 indicators are below 15%, then it means you have a significant or substantial fiscal constraint. So that is the environment that sets a context for our discussions around mobilizing additional resources for the health sector. And then, of course, the whole idea of our debt issue in the country is something that all of us are familiar with, which places additional constraint. So overall, as a country, we have a fiscal constraint, and we have to think about how do we maneuver within that. Next slide. So that is overall. But then when we look at, we know that our country is, our governance arrangement is devolved, and so we have resources at the national level and resources at the county level, and we know that especially the health function is substantially devolved, and so county governments have the responsibility to provide health care. When you look at where funds come from, we see that on-source revenues, you look at government revenues, on-source revenues contribute very little to the overall resource envelope within the country. So that's essentially, the plot that the blue plot that you have at the bottom there. So they contribute very little to the overall resource envelope that the country has, which means that in as much as overall, overall as a country, we have a fiscal constraint, but secondly, counties face substantial constraints, and yet they have the responsibility to deliver healthcare services. So that's, the country as a whole. Next slide. But despite that, what we have seen over the past couple of years is that the health financing landscape has been characterized by an increase in total health expenditure. So over the about 10 years, we've had an increase in total health expenditure, and we've also had an increase in government expenditure on health. So overall, expenditures in health have increased, but government expenditure on health has also increased substantially. Now, there are many benchmarks out there. One of the benchmarks that's used to assess the sufficiency of government health spending is government spending as a percentage of GDP. The other one is, of course, their budget target. And what we see is that we've moved from 7.8% to about 11%. We are not yet there, but we have made substantial improvements over the past couple of years, which is a good thing. And what we also see is that counties have continuously, or rather increased their contribution. So the red there is, on the left, the red part of the bar charts represent county contributions to the health sector. And what we see is that counties have substantially increased their contribution to the health sector. So it means that despite the fiscal constraint that we have as a country, there is a sense in which the country over the past 10 years has increasingly prioritized the health sector, which is a good thing. But despite that, we still have challenges with out-of-pocket payments. There's still, the benchmark target is usually below 15%. We are still at about 20%. And we still have a challenge with donor dependence. Our reliance on donor funding has reduced over time, but it still represents a substantial contribution to our health expenditure. And these are things that still have to be tackled. How do we reduce out-of-pocket expenditures, and how do we reduce donor dependence? And I think I had Professor Kokwaro talking about donor dependence in more depth. Next slide. And again, I think Prof. Kokwaro talked about this. Again, it's a background where we still rely on donor contributions. Donors contribute substantially to our health sector. We know that as a lower middle income country, we are now eligible to donor transition, which is going to place an additional fiscal constraint. Now, it's easy to look at 17% donor contribution and to say, overall we are able to manage that. But then when you disaggregate that and start looking at specific areas, then you realize that, when you're looking at, areas such as immunization, family planning, TB, malaria, HIV, nutrition, and so on, government expenditure is less than 30%, which means that as we prepare for donor transition, there are certain priority areas that are going to be under increasingly, increasing stress, fiscal stress in terms of the need to mobilize additional resources. And examples of this include, for instance, primary healthcare financing, where for the past couple of years, over 10 years, the health sector has benefited a lot from donor support, from Danida, and from the World Bank. But we also know that these donors have indicated an intention to transition out of that support. And so the question then is, what does that mean for primary healthcare service provision at the county level when one of the main sources of funding is transitioning? So these are some of the sort of fiscal challenges with regards to revenue mobilization that we have to think about as a country. Next slide. There are many ways to mobilize resources to the health sector. One of the ways to think about mobilizing resources for the health sector is to do what we call efficiency gains, which is essentially to look at the resources that are available within the sector and ask ourselves, how can we spend it better? How can we unlock more resources? How can we get more out of the money that we are spending in the health sector? And when we analyze the efficiency of the health sector in Kenya, we find that on average, the mean efficiency is about 70%, which means that on average, the Kenyan health system can mobilize 30% additional resources, barely, simply by thinking about spending in a better way. Or rather, they can, extract more outcomes or outputs from the health sector with the existing resources. Now, 70 is an average. When you think about the variation across the counties, we find counties that spend, whose efficiency is as low as 43%, which essentially means that they have the potential to unlock 60% more outcomes or 60% more resources if they improve efficiencies. So even as we think about mobilizing resources, we have to think about what can we do with the resources that are available in the health sector for us to be able to get more from it. Next slide. So, and again, as we think about mobilizing resources to provide coverage to Kenyans, we have to remember how, the Kenyan population is structured. Essentially, within any population, you have a formal sector, we have an informal sector, and then we have the poor. That's an oversimplification, but essentially that's what you have in a country. Next slide. Next slide. And what we see in Kenya is that the Kenyan population is characterized by a high level of informality, so about 80% of the population is informal. What it means is that they have unpredictable, unreliable, unstable incomes. They rely on daily wages or business opportunities that come here and there. That's 80%. 36% of the population, based on the last assessment, there are indications that this number is a bit higher now, 36% of the population lives below the poverty line. And then we have, your about 20% that is in the formal sector, people like most of us here who get a salary so we have predictable, reliable incomes. It is therefore not a coincidence that when you think about health insurance in the country, you have about 19% of the population covered, and you have about 80 to 81% of the population that is not covered. Next slide. So when you think about sort of the mechanisms, and again, this is an oversimplification, when you think about the mechanisms that have been used to cover the Kenyan population, we have your supply side mechanism. So we have, free primary healthcare services in health centers and dispensaries in the public sector. We have co-sharing arrangements in hospitals, and in the private sector, of course, people pay out of pocket, and also, we have health insurance that covers that. And then on the insurance side of things, you have the formal sector that has mandatory insurance. You have the informal sector that, on paper, based on the latest, latest amendment to the NHIF Act, on paper is mandatory, but in practice, we know, is voluntary. And then you have the poor, who are not able to pay, and there are efforts to provide coverage to this part of the population using subsidies. So previously, and I think still continuing, we had the health insurance subsidy for the poor, and now the UHC scale-up plan is essentially, you can simplify it as providing subsidies for the poor. So this is how things are structured. And the challenge here is that then you have to think about what is the proportion of the population that's poor. It's 36%, 36 to 40%. So if you're going to provide subsidies, you have to target the 36 to 40%. So what does that translate to in terms of additional resources that you need to mobilize? When you think about the informal sector, what is the most effective way to extract contributions from them? We know that it is not possible, it's quite problematic and difficult to extract contributions from them in a voluntary way. Next slide. Why is that the case? Because, as I mentioned, this particular subpopulation has unreliable, unpredictable, unstable incomes. And so the only way to get, or rather the default way to get contributions from them is to beg them every month to make a contribution. And when you do that, what happens is that you spend a lot of money trying to get them to make contributions. So it's inefficient. You're spending a lot of money on billboards, spending a lot of money on marketing campaigns because you have to keep convincing them to make contributions. You have a high rate of attrition. Why? Because they have to remember every month to pay, and they also sometimes don't have incomes, and so they are not going to be able to meet their monthly payments. And then you have adverse selection, and this is simple human behavior. A lot of the people that in the informal sector that enroll with the NHIF are people that need care. So if you are getting a bit old, you enroll to the NHIF. If you're planning to have a baby, you enroll to the NHIF. If there's a scheduled surgery, you enroll to the NHIF. If you get a chronic disease, you enroll to the NHIF. So you end up with a pool that is essentially has higher need as opposed to the general population. So that's adverse selection. And all that contributes to the challenges that we face as a country trying to scale up the NHIF as a vehicle for UHC. Next slide. So then you end up with this situation where coverage, NHIF coverage over many years has remained lower or below 20%. I know there are many numbers out there, but these are the numbers that are represented by nationally representative surveys. Over the past many years, we've not been able to achieve NHIF coverage of more than 20% for the reasons that we've talked about. The other implication is an equity implication, in the sense that even when you look at the 20% that are covered by the NHIF, 43% of those are those that come from the upper quintile, so the richer part of the population. While the poorer part of the population that should be benefiting from these public mechanisms only extract about 2% from the NHIF. So one, coverage is quite low. Second, is highly inequitable. And third, it's quite unsustainable. So when you look at what we call the loss ratio, so in 2019, when we looked at these, when we were doing the NHIF reforms, assessments, and we did a sub-analysis of the informal sector and the formal sector. We found that the loss ratio among the formal sector, which is a smaller part of the sub-population, is about 69%. What does that mean? It means that for every 100 shillings that someone from the formal sector contributes, they get, NHIF pays about 70 shillings or 69 shillings. So it's sustainable. While for the informal sector, for every 100 shillings that the NHIF, someone from the informal sector contributes, the NHIF pays 277 shillings. So almost 3 times. So it means that that particular segment of the population is not sustainable. Now the challenge then is, as it is now, when you look at NHIF coverage, the majority of people that are covered are in the formal sector. So that's fine from a sustainability perspective, but it still presents a strain to the fund. But as you scale up, we've already maximized the number of formal sector people we can include in the pool, which means whenever we talk about increasing NHIF coverage, in essence, that translates to getting more informal sector people on board. And so we'll get to a point where informal sector people are more than formal sector people. And yet, informal sector people extract 3 times what they contribute compared to the formal sector, which essentially mathematically it means that the fund becomes completely unsustainable. So that is a problem that we face because of the fact that we have an informal sector, a large informal sector, and we are relying on voluntary contributions. Next slide. So those were thoughts around mobilizing revenues for the health sector. When you think about pooling arrangements, the ideal, when you think about pooling arrangements, is to have fewer larger pools that are equitable in terms of the population that is represented. But what we see in the country is that, next slide. What we see in the country is that we have, please go back. We have fragmented pooling arrangements. So we have several pools, and what we see there are the large pools that we all know. We have the National Ministry of Health, we have NHIF, we have several private insurers, several community-based health insurers, you have your 47 county governments, and you have your sort of corporate covers and so on. But even within these pools, so again, in 2019, when we assessed the NHIF's situation, we found that the NHIF had over 80 schemes within it. So you have many pools overall, but even within one pool, such as the NHIF, we had many schemes within it. And we know that even in counties, you still have fragmentations. So we had about 80 schemes within the NHIF, which presents a lot of fragmentation. And when we looked at them, quite a number of them were actually unsustainable, were small and unsustainable. Next slide. Next slide, please. Another thing that contributes to fragmentation of our pools is the manner in which the country is supported by donors. So we have substantial donor funding, as we've talked about, but then when we look at the nature of that donor funding, it is mostly unpooled, mostly fragmented, and mostly out of, off budget. So only about 15% of donor funding is on budget. The rest of the funds are off budget, managed directly by donors, which presents a lot of challenge in terms of consolidating, consolidating resources, thinking about how you plan and prioritize and so on. It compromises all of that in a country. So that's a challenge to pooling. Next slide. With regards to purchasing, once again, we have fragmented purchasing arrangements. We have several, several purchasers, and within those purchasers, we have several benefit packages and so on and so forth. Next slide. Next slide. There are several purchasing issues that can be discussed, and I'm sure in the course of the day, you will get to discuss quite a number of them. I just want to point out a couple here that stand out for me and a few other people. One is the fact that, one of the things about purchasing is thinking about what you want to purchase. What are you actually offering Kenyans? And what you see is that we have multiple benefit packages that are not harmonized. We have multiple benefit packages that are not harmonized. And what that means, again, is that it introduces inefficiencies within the system, but it also introduces inequities within the system. So it introduces inefficiencies, but also inequities within the system. We have to ask ourselves, how do we develop our benefit packages? To what extent are those processes inclusive? To what extent are they systematic? How predictable are they? Do we know how the next benefit package will be developed? To what extent are they evidence-based? And is the evidence and criteria that's being used to develop them aligned to the health system goals that the country aspires to? This is something that we need to ask ourselves. We need to ask ourselves, what services are prioritized within the benefit packages? Is it higher level care, as we see, or do we want to move towards prioritizing primary health care in our benefit packages? Because we know that that's more cost effective, it's more equitable, it will reach most people. But are our benefit packages structured that way? The other thing to think about are provider payment methods. To what extent are our provider payment methods informed by evidence, costing evidence? So whatever payment is being made out, does it actually cover the cost of that service? And second, whatever payment is being paid out, is it aligned to the resources that have been mobilized? I like using the example of a situation I've never been able to understand, where the NHIF collects 6,000 shillings per annum for a household. 6,000 shillings per annum for a household. That's the amount of money it has to cover a household. A household has, on average, 5 individuals. So the moment NHIF collects 6,000 shillings from you, assuming you're in the informal sector, it promises you, your spouse, and your 3 children that it will provide inpatient, outpatient, and specialized services. That's what the NHIF says. Inpatient services, outpatient services, and specialized services. Now, how does the NHIF pay for it? It pays for outpatient services using capitation. How much is capitation? 1,200 per head, not per household, per individual. So the NHIF is required then to pay 1,600 times 5 individuals in your household, which is 6,000. So the moment the NHIF pays for your outpatient, which it needs to pay upfront, then it's gone broke. So when you need inpatient care, where does NHIF get money to pay for that? When you need specialized services, what are specialized services? Surgeries, maternity, cancer, all of those. How does the NHIF pay for it? Then, of course, NHIF needs to also pay for electricity, cleaners, rent, and so on. So administrative costs, which, as I understand, is now below 15%, somewhere between 10 and 15%. Where will the NHIF get that? So the math just doesn't add up. So as we think about our provider payment mechanisms, we have to ensure that they cover the cost of care, but we also have to ensure that they are aligned to the resources that are available. So those are some of the things you have to think about when you think about your provider payment methods. And then you also have to think about how do you structure your provider payment methods to optimize for efficiency or to incentivize efficiency. We have provider payment methods that are open-ended. What it means is that for as long as someone keeps making claims, then they keep getting paid. So per diem, number of days. Case-based, number of deliveries, number of surgeries, and so on and so forth. So they're all open-ended. Now, best practice tells us that we need to transition these provider payment mechanisms to become blended, to introduce some closed-endedness, so that in as much as you're claiming, there's a limit to what you can claim unless there's justification for additional claim. So introducing controls to our provider payment mechanisms so that we can be able to control for over-provision and fraud is something we need to think about with regard to purchasing. Then, of course, one of the biggest problems we have is issues of funding flows. So how do we get funds to actually get to facilities, and how do you ensure that facility managers have the capacity to problem solve? If the ambulance doesn't have fuel, they can purchase fuel. If a bulb blows, they can replace it, and so on. So provider autonomy in terms of operations and finance is an important thing. It's still a challenge in the country that we need to think about, and it is linked to PFM and purchasing. So these are just a few issues around purchasing that I wanted to highlight. Next slide. When it comes to budget performance, what we see, Of course, there's, when you hear perceptions and you talk to people, there's a sense in which we still have a challenge. You still have delays, you still have execution issues and so on. But when you look at the numbers, on average, budget performance has improved over time. So budget execution at both the national and the county level has improved over time, which is a good thing. And it's something we need to continue to move towards, because how budgets work affect outcomes of a health system. Next slide. So I'm going to leave you with a few thoughts. With regard to revenue mobilization, we really have to focus on tax funds, because as you said, voluntary contributions have a challenge. But again, we are fiscally constrained, so we have to think about how can you explore efficiency gains as a way to mobilize additional resources for the health sector. When it comes to pooling, we really have to think about consolidating government funds, because there's a lot of fragmentation with the funds, with the funds that are spent by government. So we need to think about how do we consolidate, government health expenditure. And we also have to think about consolidating donor funds. How do we do that? How do we pool donor funds so that we are able to achieve much more with these funds? And I'm sure there are many other pooling reforms that we can think about. If you look at the HEFREP report, it will talk about consolidating schemes and many other things, but I wanted to highlight those two. With regards to purchasing and PFM, some of the things to think about is benefit package reforms. How can we have a more systematic and evidence-based way to develop benefit packages that are actually sustainable and are responsible to population health needs? And one of the things that the country needs to think about, and the country is on this particular trajectory, is adapting health technology assessment as a mechanism, as a tool, as a system of developing benefit packages. We have to think about provider payment reforms. There are many things we can do there, but as I mentioned earlier, we have to improve the evidence-based for these provider payment mechanisms, and we have to introduce blended, closed-ended provider payment mechanisms. Then, of course, there are ongoing initiatives to provide healthcare facilities with autonomy. We have to scale that. We have to make sure that we scale it to the country level, rather than having fragmentation across the country where some counties have autonomy and some counties do not have autonomy. So thank you very much. I hope you have a great summit over the next 2 days.
Thank you so much. Thank you so much, Edwin, for the insightful words. I'll take a few comments, and I'll start with online. We had one comment from, I'd like to appreciate those who have dialed in online. So we have one comment from online. It means that capitation is totally unsustainable as currently designed. Most likely there are not many dependents and not all are capitated. So a question has come up from online. We do not have a HTA organization in Kenya. This is critical to guide benefits package. Can we form one as intended? So I don't know if Dr. Nyalita or Professor Edwin, you could take it up. Also, the guests who are with us physically, please have one or two questions. I'll be coming around with the mic in a minute.
So I think that there are two questions. One is around capitation and whether it's unsustainable. So the idea is not that a provider payment mechanism is unsustainable. The idea is that we have to design it in a way that makes it sustainable. So a couple of things. One, it has to be based on evidence. Because a provider payment mechanism is meant, number one, to pay health facilities to cover for their cost of care, but number two, to also send signals to healthcare providers that will incentivize, positive, or rather, desired health goals. So it's supposed to incentivize equity, incentivize efficiency, incentivize quality. So one, we have to refine and improve the evidence-based for capitation. So I know the NHI, for instance, is thinking about or in the process of risk adjusting its capitation mechanism, which is a good thing. So we have to do that. And then second, we have to introduce controls to our provider payment mechanisms to curb, undesired health provider behavior. Why? Because any provider payment mechanism that doesn't have controls is likely to lead to fraud, over-provision, and so on. So that's with regard to capitation. The other question was around health technology assessment. Yes, we do not have a health technology assessment organization, but the Ministry of Health has prioritized health technology assessment as a reform. There's a health technology assessment technical working group led by the Ministry of Health, and there's a health technology assessment strategy for the Ministry of Health that's currently in development. So we need to support that process and ensure that once a strategy is developed, it's actually implemented.
Thank you so much. A few comments from the crowd.
Thank you very much. My name is Dr. Wasuna Wino from Farm Access. Thanks very much for the insights. Now, just a few comments and maybe a question. About NHIF, we have indicated that it is financially unsustainable. And yet, we have seen NHIF reporting surpluses. So is that an economy in terms of reporting surpluses? I think every year the surplus is growing, and we are saying that it's unsustainable. So where is the problem? And then the issue about fragmented pooling arrangements. Now, one question is, do we virtually pool at the national level or at the county level? And you have seen instances where if we pool at the county level, this money goes to CRF. And when it goes to CRF, it is not brought back to the health. So what should we actually do? And then at the national level, we know many of the small schemes are politically motivated, whether it's Linda Mama, Eduafia, you know, these are small segments which are meant to please various constituencies. So what are we supposed to do from a governance perspective? Then the donor of budget support. We know that many partners are not giving money directly because of the governance issues, because of transparency and because of accountability. So what is it that, as a country, we really need to do to enhance governance? And I think that also touches on those who manage our resources, which is really very, very important. I think I'll leave that for now and add more later.
Thank you.
Thanks. Quite, great comments and observations. I will attempt to answer them, and I will leave all of you over the next two days to delve into a number of them. But the most interesting one for me is the NHIF. On the one hand, you're saying the NHIF is unsustainable, but then on the other, it reports surpluses. Why is that the case? The jury is out on that, but I will give you ideas. So my theory is that the NHIF is able to make surpluses because of quote-unquote inefficiencies. So, inefficiency is supposed to be a bad thing, right? But sometimes it can save your backside. So what do I mean by this? One, as I mentioned, the idea is that if NHIF collects 6,000 from you, it needs to pay 1,200 per individual in your household to a health facility. That's how capitation works. Capitation works when you pay the facility beforehand, not after the facility has spent on the patient. Now, in practice, what happens? In practice, out of your 5 individuals in your household, probably you're the only one that is actually registered as a beneficiary in someone's, in the principal member's card. Second, even when they are registered, the NHIF requires that you are registered in a facility that provides outpatient care for you. In practice, a number of us in this room have not registered to facilities. So because of that, the NHIF doesn't get to pay the 6,000, because it can only pay the 6,000 if you are all registered in a facility and you're all registered as beneficiaries in the principal member's card. Is that an ideal situation? It is not. Why? Because we know of many instances where your loved one falls sick, you get to a facility, and oops, you're not included in there. You've not been registered yet. So you can miss out on care. So it's not an ideal thing. It's a process in efficiency, but it's a process in efficiency that saves NHIF the requirement to actually pay out what facilities are entitled for covering you as a member. So that's one. And then the other, I mean, we have many providers out here, seated here, who will raise their hand and complain about delays in payment. I think you started by, Dr. Nyalita talked about that earlier. So you have instances where, payments are delayed and, claims processing and things like that. So all of those process inefficiencies lead to a situation where, at the end of a financial year, you actually have money that is unspent. But that is just one reason. I'm sure there are other reasons. Fragmented pooling arrangements. Again, the jury is out on what's ideal. What I will say, one of the interesting things you've said is, should we pool at a national level or at a county level? And then later you talked about the politics of pooling, and I think that's an important point, that these issues are not just technical. We have to find solutions that meet technical requirements but are also politically feasible. I think it's quite challenging to suggest national level pooling in a context that is devolved. I think that will be a very clean, a technically clean solution that will not have any political head start. So we have to think about, within that context, how do we balance the advantages and disadvantages of having pooling at both levels? Because when you have pooling at both levels, it introduces fragmentation. You have 47 pools, you have several pools at the national level and so on. But there are technical ways of going around that. We say that the ideal is one big, large pool. But the ideal is rarely achieved. So when you have several pools, what do? There are still things you can do. You can ensure that the population that is represented in the pool, the representation within pools is equitable. You can ensure that there are mechanisms for risk equalization so that pools are able to benefit from each other and so on. You can curtail, cross-subsidy in the wrong direction, which is what happens at the national level, where the national scheme for the common mwananchi cross-subsidizes the enhanced schemes, because the enhanced schemes become unsustainable. And so rich people are benefiting from poor people, so you can ensure that those things don't happen. So politically feasible ways of doing it, rather than just thinking about the technical aspect. Donor off-budget. So you're right in the sense that the reason there's off-budget support, donors sort of prefer off-budget support is because of governance concerns. But I don't think that's the only reason. I think there's also a need for control. There are also incentives around control. There are also incentives about ensuring that I can attribute. I can say, this is my money, this is how I spent my money, this is where it went, and so on. So there's governance, but there's also just the need to continue having these parallel mechanisms where a donor can say, this is exclusively my project and my outcomes. And the issue around governance, there are two ways to look at it. One is to say, there are governance challenges, so we will not fund on budget. Or two is to say, let's face the governance challenges and let's try and resolve them. Because there are donors who fund on budget. And they introduce governance requirements and so on. But I will let you talk about governance for the next 2 days.
Thank you so much, Prof.
One question was not answered. Huh? So in terms of governance, there are about 1,500 to 3,000 boards and health-related committees across Africa. We had an initiative of trying to train those through AU. It never worked. But we have now focused. We have come back home. So we have developed a curriculum to try and address that particular issue. Remember Stream A that I told you there? So who are these people in the committees? I've had the privilege of doing some training around some counties. So they are retired teachers, bishops, a few politicians, as a mixed bag. Not very bad, but they're completely not supported. not supported. So moving forward, Anastasia and I are suggesting, so without that, Professor Wasuna, without that, I told you column A, the rest of the things, I think really, I don't know, we like spending most of our life doing hard work rather than working hard. Without equipping those people with the barest knowledge about how to run board, even just board meetings. Most of them are not meetings, they're political rallies. They are not meetings. And you go this total they have no clue what a health system is like. I did some training in some prominent African countries that have done it, where one of the board members was the vice chair of their national airline. And he asked me, what do you think you are going to teach me? And I told him the airline is not health. Health is more complicated. Allow me a few weeks just to tell you. So moving forward, I think we need to formalize the training of all these committees. They're not bad. It's not bad to be a priest. It's not bad to be a teacher. I'm also a teacher. But when you want to be a board, whether you are a political appointee or no, you know you're going to a different, and you need to understand the health system. Those are the people who take decisions. So I think formalized training, but we shall need your support of the Ministry of Health to take this one. We have the material. Even last Friday, we were working on the final stages of the curriculum. It will be a staged, really supportive, making sure that these people are not intimidated by things, but they have been found, they are board members, the people making the decision. So that's one area we need to invest in. Training. It is not exposing ignorance, it's actually supporting them. I think we are working on that, and we shall need all your support. In fact, I'll put you as one of the people to train.
Thank you so much, Prof. You could see the discussions are getting lively as we continue. I'd like to appreciate those who are also dialing in online. Also those who are dialing in from the basement of this building at Oak Room, feel free to ask questions. I don't know whether the tech team has one online question. Somebody who wanted to... As we get ready, we are going to the NHIF session, and I presume the Rose from NHIF, you're ready to make your presentation, and Dr. Kamunyo will come and do an overview of the same. Rose, are you with us? All right. So as we get the questions ready, I'll welcome Rose to come on stage, give us a presentation on NHIF, then we'll have a wrap-up with Dr. Kamunyo. A round of applause to Professor Edwin Baraza for the delightful opening session.
Okay, my name is Rose Nahungu. I'm a legal officer at NHIF, and I'll be doing a presentation on the main changes on NHIF. And after I'm done, then there'll be a brief on the overview of the NHIF. And I think then your questions will be addressed then. I'll ask the presenters to just go to open the PowerPoint presentation called the National Health Insurance Fund Revised Act. Okay, even as they find that presentation, I think I'll start by giving a brief on the areas that have been addressed generally by the NHIF Act. The NHIF Act has addressed 6 main areas. That is the NHIF name, UHC. We have also addressed the NHIF mandates, coverage of the people in the society we consider vulnerable, and We have also addressed some of the issues that are faced by our contributors. And lastly, we have also addressed the issue of governance. I don't know whether the technical team has been able to locate the presentation. Just a minute. Okay, then we are good to go. We'll go to the next slide, the next one. So I'll start with the NHIF name change. So we changed our name from National Hospital Insurance Fund to National Health Insurance Fund. And this, in effect, basically increased our mandates. As you know, previously, we used to only contract hospitals. But when we embrace the name change, that is the next slide, to health, it extended our mandate, and now we are able to contract even pharmacies, we are able to contract laboratories, which we were not able to do. So that is one of the main changes that we had in the NHIF Act. In the next slide, this one now addresses the issue of governance. What we did when we amended the Act, we introduced representation from the Council of Governors, which was not there, so they can be able to bring to the board the issues experienced at county level. We also introduced new cabinet, 2 appointees by the cabinet secretary. And it's important to note that the NHIF requires that these 2 appointees by the cabinet secretary should not be public officers. So the board, therefore, consists of the chairman, we have the PS, Ministry of Health, we have the PS Treasury, we have a representative from the Kenya Medical Association, we have a representative from the Federation of Kenya Employers, and we have a representative from KOTU. And as I had said earlier, 2 representatives from the Council of Governors and 2 cabinet secretaries appointees. And then we have our CEO. Now, the NHIF Act introduced a very important aspect when it comes to the objective of the board. As you know, the board is obligated to receive contributions to determine things like the benefits that you'll be accessing. The main change with the new NHIF Act is the issue of UHC. It's obligated now the NHIF board to facilitate the attainment of UHC. This was not there before, and this is a new addition of the Act. So just an overview, on top of regulating contributions payable to the fund, receiving these contributions, making payments to healthcare providers, among other things, now the board is now obligated to facilitate UHC. Another key change is when it comes to public participation. They have now made it compulsory for the board to effectively effect the provisions of this act, that is in the next slide. The board is mandated now to ensure public participation in any decisions that they make, including revisions of contributions and even benefits. And this is very key to ensure that there is buy-in from all our stakeholders. Next slide. So, as you know, the Act also made it compulsory for everyone who is above the age of 18 years to register as a member of NHIF. And the word here is register, not pay, because there was a lot of misunderstanding here where people thought that it means everyone above 18 must pay, but we all know that we are going through different challenges. So you find that the Act requires you to register as a member of NHIF. And the proviso is you are not supposed to be a beneficiary. If you have been registered as a beneficiary, then there's no need for you to register as a member. By a beneficiary, we simply mean a dependent. For example, you're above 18 and you're in school, or even you're above 18 and you're completely disabled. You know that the Act allows a member to cover 100% anyone who's physically disabled and wholly dependent on them. So this covers, it ensures we are all in that basket of NHIF. Next slide. So who has the mandate? Who is supposed to pay contributions to the fund? So there are 4 groups of people. We have you and me on an individual basis. That is, if you're self-employed, you are expected to pay contribution, provided you're above age of 18 years and you're earning. Then we have the national governments, they're supposed to pay contributions. We have the county governments, and then we have employers who are supposed to submit contributions of their employees to NHIF. Next slide. Now, the Act also introduced new contributions. As you know, before, we had the standard contributions that were payable by employers on behalf of their employees. These were paid by people who are fully employed. Then we had special contributions paid by the self-employed people, the mama mboga, the boda guy, or even somebody running their own shop. The NHIF Act introduced other contributions. Most important was the matching contribution, which was supposed to be paid by the employer, much like the pension. Because before, the standard contribution is actually paid by the employee from their salary. But the matching was supposed to be paid by the employer. So though you top up, just like pension, you pay maybe 50% and the employer pays 50%. And then we have the special contribution. In addition to what was paid by the self-employed, the Act introduced another special contribution. This was supposed to be contributions paid by the government on behalf of people who've been identified as vulnerable in the society. These are people who can't be able to sustain themselves, the poor, the orphans, yeah. And then there was the third new contribution, that is the voluntary contribution. This now is the contribution that is paid by unemployed persons. So you are unemployed, but you have a source of income, you're above 18, you're not working, but you still are able to pay for yourself, then you fall under the bracket of voluntary contribution. So one of there was, of course, the question of matching contribution. What happens, the question was whether all employees must pay this matching contribution. The Act has provided a leeway. If you are an employer and you're able to get another cover for your employees that is equal to or better than what NHIF pays, then you're exempted from paying this matching contribution. So the idea is to ensure that all employees are able to, are covered at all times, either by NHIF or your employer has really covered you in terms of you have a better cover for yourself. Next slide. So when it comes to benefits, the Act has several provisions on this, and one key important one is that it provides now that we can now review the benefits and the contributions payable to NHIF every 2 years. Initially, it used to be done when necessary, but now the Act has locked it into a specific timeline. So every 2 years, the fund will review the benefits and the contributions. When it comes to the benefits payable, as I mentioned before, that is an obligation of the board. It has also made it mandatory for NHIF to cover emergency services, and it has ensured or obligated the fund to ensure that it does not withdraw benefits for any member who is accessing chronic illness. So that was never there before. These two actually were never there before in the Act, and they were introduced with the revision of the Act this year. It's also important to know, other than what is here, NHIF has a provision on enhanced benefit schemes. so that it addressed the issue. The question was if you're an individual, probably, or an organization, and you want a better cover than what we offer everyone, then how is that addressed? So you have the Act making provision for that now we can provide an enhanced benefit cover. Next slide. So there used to be cases where, in fact, it's not used to be, I think it is a common case, where every time you register for your private insurer, they always ask for NHIF cover. And this was because when you become sick, they will make you pay through your NHIF cover first, and then your private cover, and then kicks in. So the Act sought to change that by providing that the private insurer, if a member has two, NHIF cover and a private insurer, a private cover, then your private cover will be utilized first before the NHIF cover. And this also, in a way, ensures that we are able to sustain the fund. So that was never there before. It used to be an issue of negotiations and requests, but now it is in the law. Next slide. The NHIF has also introduced the issue of a centralized healthcare provider management system. This is basically where we will be able to keep all our data, where we are supposed to make payments through this system. Members are supposed to be able to access information on request through this system. So the board is now mandated to set up a system that will ensure all our stakeholders can easily access information about their benefits, about their covers, and the healthcare providers can also be paid through this system. That is also a new addition to the NHIF Act. When it comes to the next slide, please. So when it comes to empanelment, the Act has required that every time we carry out empanelment and contracting, we must involve the necessary bodies. And then it also provides the manner in which we contract empaneled healthcare providers. It also now provides, which never used to be there, the process of revocation. And what is important here is now the healthcare providers have a leeway to appeal. Should they be revoked and they feel that it is unfair, they can appeal that decision based on the NHIF Act, and they can even go further and appeal that decision up to the High Court. And this is also provided by the NHIF Act. So this is a major change that never used to be there, and it ensures protection of healthcare providers. It also, of course, goes further and provides that if you are revoked and you're a hospital, then the board is mandated to publish that it has revoked your contract or your empanelment to the NHIF. So when it comes to inspection, this used to be there, it has only been strengthened. We have inspectors who are given the power to come and inspect maybe a facility, to come inspect an area of employment, and they might request the necessary documents to ensure compliance to our NHIF Act, or in the case of healthcare providers, they ensure compliance to the NHIF contracts. So when it comes to investments, currently we are limited to invest in two areas only. We can invest in a reputable bank or in government treasuries as provided by National Treasury, as approved by National Treasury. The difference here, the major difference here is before we had been empowered by the old Act, we could buy equipment, we could buy ambulances for facilities. But with the new changes, that was removed. So now we only have these two areas of investment. In case, and the proviso is, we only invest surplus. So it is not an obligation. It's only in the event that there is surplus, then we can invest. But it's not like an obligation. So when it comes to offenses, that is the next slide. Next slide. Next one. Yeah, when it comes to offenses and penalties, we have introduced many offenses. We have reviewed our penalties so that they are more deterrent. Some of the offenses that we have addressed includes in case of delay of remittance. We have the standard contribution. That is if an employer fails to pay your contributions on time, then the Act basically provides that they are supposed to pay that contribution and the rate of that contribution based on the interest that will be provided by Central Bank of Kenya at the time. This is basically just to encourage employers to remit, to make contributions on time. Next slide. Then for the self-employed, we have, if you're self-employed and you have paid late, we only require you to pay that contribution that you have not paid and a penalty of 10%. The change here is, it's really, because the idea here was to encourage, to help you, to deter you from paying late, but also to encourage you to continue paying. So it was felt it would be good to reduce the penalty greatly to an amount that our members can pay. Let's go to the next. Okay, now when it comes to, next slide. When it comes to other offenses, it includes if you make a false statement in order to maybe make a different form of contributions. For example, if you're self-employed and then you lie you're employed so that you can pay much less than what you are expected, then the Act has made that an offense. The next slide. Another offense is if you make a false statement so that you can obtain a benefit. This includes situations where we have found people presenting their sisters as their wives or their cousins as their husbands so that these people can benefit from their cards. That is now an offense that is captured in the Act. Then we have impersonations where you take the details of somebody who's not there, and then you use that information to benefit. That is also now an offense under the Act. Then we have the obstructions of our inspectors. I had mentioned that our inspectors basically are now empowered to inspect and to confirm compliance. Where there is an obstruction, that one is an offense. That is, if you refuse to give them the information that they are requesting for, it becomes an offense. Also importantly to note that if these inspectors also make a false report about the areas that they have visited, then they have also committed an offense and they are liable actually under the Act. And that is a brief summary, very brief, of the changes in NHIF Act. Thank you.
So much for those insightful comments. We had one burning question from a member who had from the previous panel. So we'll have that, then we'll have Walter's question, then we proceed.
Thank you so much. My name is Agnes Munywa, and I'm an Associate Director, Results for Development, and I work with Oludare Leonora on Spark. And I had a question to Edwin in his previous presentation, and then one to Ruth. So to Edwin, you presented a very nice representation of where we are right now. It's obvious that the fiscal space is constrained, and so we need to do more with what we have. And you presented a very interesting slide on efficiency in counties, and you gave an average of 70% with a range between, I think, 43 to 90%. So I don't know if there are any county representatives here. I think it would be very important to hear, noting that the biggest pool of funding is still the government budget and most of that goes to the counties, then how best do we improve the efficiency? And if you could also just explain what you meant by efficiency and how best, if we're making recommendations to counties, how they can use their resources better to maximize the value we get from our limited health resources. To Ruth, thank you for also a very insightful presentation on NHIF and what's happening. When I think of NHIF, there are two things. There's the resource mobilization, and then there's the purchasing. And when I look back to the HEFREC panel, they gave us very concise recommendations on how to improve the purchasing. I didn't see much there. But in the resource mobilization part of it, you gave very elaborate mechanisms that are being introduced. And my question is, what are we foreseeing in terms of, going back to Edwin's presentation on the fact that you have already probably maxed out the formal sector and you need to bring in more of the informal sector? What's your strategy to make sure you get them not as voluntary, but bringing that mandate of mandatory contributions to the NHIF? And then I think I've heard in the past the issue of penalties, and if these punitive penalties deter more than encourage people to register. So just your thoughts from NHIF, what is being done to improve or to increase this enrollment? And then I think later when we have an MOH representative, how we're reducing the fragmentation and drawing in more resources, because if we look at different country experience, contributory mechanisms for resource mobilization through contributory social health insurance may not have worked as well. And so what are we doing to draw in more government funding to subsidize, as was also presented earlier? Thank you.
Thank you so much. So I think Edwin is not here, but we'll take the question for Ruth. Ruth, you are still with us. You can give us a few insights. Or what we'll do, we'll take the question, then we proceed. We'll ask it when the Kamunye will be here. He'll also address the question. So, Walter?
All right. Thanks, and good morning. Thanks for those comments and updates that you've given on NHIF. Probably just two questions or two comments. Kamunye comes. So one, on the mandatory changes on everyone above the age of 18 years to be registered, what are your thoughts, or are there discussions on having this integrated with the national ID registration process? Because if it is already mandated that it's at 18 years of age, then why not make it seamless? Discussions are there, just to think about that. Secondly, on engagement between the fund and general stakeholders. As the new act is being implemented, there have been observations made based on what we have on the act, what we have in the contracts being drawn. So there are a couple of conflicts, and I can mention probably one or two, but there are quite a number. One, you have emergency care being mandated as a requirement for providers to offer. But when you come to the contract, you find that providers are being told to pay for the emergency referrals at their cost, to put that at their cost, not at the fund's cost. That's a conflict between what you have and the mandate. Where you have, for example, you mentioned private, the fact loss. What happens if the beneficiary doesn't disclose, because there's no central repository of data for everyone to know that Walter has, say, an insurance cover with UAP, NHIF. These are the benefits from these two insurers. So is there how do we have either a central repository so that everyone, for a provider, for the providers to be able to seamlessly offer these services to the providers, and doesn't come back later that when the full claim was claimed by, say, to NHIF, and then the provider is told there's fraud because this provider had private insurance. And I could go on and on, but the overall question I'm just trying to raise is, how frequent is NHIF mandated? Because when it's left broadly, it may happen once a year, but how often is it mandated to engage with stakeholders, providers, so that they can update whatever challenges are being faced with the implementation of these legislation vis-a-vis what is being contracted. Thank you.
Thank you so much, Walter. One question from... I hope you are keeping the questions so that we'll deal with them much later.
Good morning, everyone. My name is Dr. Lucas Nyabero, and I serve the Pharmaceutical Society of Kenya as the CEO. My question is, when you talk about funding or financing of healthcare, there is contribution and there's expenditure. So you either increase the contribution or reduce the expenditure. Medication utilization and there's some relevant costs that come if you give someone the wrong medication. There is harm that can happen, organ damage, among other things. And then there is a cost that is going to be incurred to take care of that. When I looked at some of the changes that have been done, it was not clear how the fund is going to be managing the utilization, the appropriate utilization of medications, and to ensure that patients get what they appropriately deserve to avoid harm for inappropriate dispensing and stuff like that. So that's my question. The question is, how does the fund intend to manage that? And I saw when you looked at the new board, it was clear that I did not see any presentation from the drug experts. The medication experts they are not included in the new board. There is KMA, but I didn't see anybody from the pharma side.
Thank you so much. Lucas, one more question.
Thank you, Ruth, for your presentation. My name is Gorin Juguna. I'm a student at Strathmore. Just a clarification. Among the updates were the additional contributions that NHIF has introduced. And I was particularly interested in the matching contribution to the employers. So you are referring to it as was supposed to be. So is it something that has been abandoned, or it's not yet implemented, or it's just a suggestion? Thank you.
Good morning, all. My name is Steve Mulupi. I'm a health systems and policy researcher with interest in public financing. My questions, thank you for the presentations, and I think I have 2 or 3 main questions. The first one is about regulation, and this is about the relationship between NHIF and the public providers, and the relationship between NHIF and private providers. Where on the side of private providers, NHIF might have some incentives to kind of shape certain behaviors and outcomes. It is not very clear what sort of incentives do you have to ensure that public providers perform at a certain level and achieve certain outcomes. And I say this because NHIF and these public providers are both within the public, under the public institutions. The second question is about consumer protection on the side of the people who have enrolled in NHIF. And we get so many questions about patients who've gone to a health facility that does not have drugs that are actually covered by NHIF. So how is this consumer protected? Because they've already paid for this service, they did not get the drugs in the public facility, and probably they've had to buy these drugs from a private retailer at out of pocket. And the last question is about capitation. And the challenge I see is that in terms of portability of benefits, so people can only choose certain facilities, and there could be some bottlenecks in terms of referrals where a patient has been referred to a certain facility, but they cannot actually access services. So how is NHIF addressing those challenges? Thank you.
Thank you so much. We have one, the lady who will respond to the question on Edwin.
Good morning, everyone. My name is Anita Musiega. I am a researcher and health economist at Cambridge Wellcome Trust. I was part of the efficiency work, so may I take the question on behalf of Professor Baraza? The work also involved a regression analysis that identified causes of inefficiency. So some of the causes of inefficiency we identified are PFM issues, that is public financial management issues, HRH, human resource for health issues, corruption issues, and coordination between the government, national government, the county government, and development partners. So just to answer, how can counties improve efficiency? By improving all of those and other aspects, and we've published a lot of work on that, and I've developed policy briefs, so I guess as a package at the end of this, we'll be able to provide more information on that, on how specifically to improve public financial management issues, including how budgets are formulated, executed, and monitored and evaluated. So thank you very much. That's it.
Thank you so much. The questions are becoming quite many, so I'll take two last questions. Then we'll answer the questions on NHIF at another point as well. Then we'll go for a short tea break. So we'll get two questions, one from here and one from the front.
Thank you so much. Yeah, my name is James McCormick, an epidemiologist by profession. So my question goes to NHIF. And I've already seen that you have more than 80 schemes. But if you look at these schemes, most people, they are not aware of those schemes. So the question is, how is NHIF in terms of advocacy, in terms of mobilizing the people who are going to be registered so that they are aware of these schemes? And again, on the same note, we have in other counties, especially those remote counties, you only have one branch. If I look at these other insurance companies or firms, they go even up to Penumbra areas to register their members. But NHIF, they are just within towns, and they are waiting for members to come and register. So do you have a resource envelope where you can be able to access those remote areas so that you can have more members registered as you work out on other modalities of increasing your enrollment? Thank you so much.
Thank you so much.
Thank you. I'll go straight to the point now. The first question is, who is NHIF accountable to in terms of governance? And if we say Minister of Health, we know that NHIF is more resource heavy than Minister of Health, so there's no way that the Minister of Health is really going to govern. Now, we find that NHIF is a jack of all trades. It is doing inspection, empowerment, resource mobilization, contracting, mention it. And the HEFREB report clearly states that NHIF should focus on purchasing, strategic purchasing. So what are our regulations saying about that? And I've not heard anything in the reforms relating to quality, quality improvement. It's more focused on resource mobilization, penalties, inspection. So what are we actually doing on this side? Because we need to balance both the demand and supply side. Number two, the reforms to me do not really align to the Kwanzaa manifesto, which is very important because we are going to be with the Kwanzaa government for some time. Now, one is the issue about fully publicly financed PHC. We have a national fund for chronic and catastrophic care, affordable, flexible, premium funding. And we can go on and on. So one issue is that how is it really aligned to the current government? Because if it is not, you are not going to get support on that specific side. Now, I saw that one of your mandate is to facilitate attainment of UHC. So my question is if we look at the status where we are now, what is the current financing gap? And if we went for mandatory contributions, would we really solve that specific issue? And then lastly, we are talking about matching contribution by employers. Now, the government is also an employer, which means that if these other guys are going to top up, then the government is also going to top up. And the question is that top up for civil servants already budgeted for if you look at the MTF cycle? Thank you.
Thank you so much. One final question, then we'll go for break.
Okay, thank you very much. My name is Ibrahim Abdul Mohamed. I was the immediate former CC Health and CC Finance for Jia County. I've been working closely with NHIF for some time, especially the CEO and his team. As you are aware that the bulk of the clients and customers for the NHIF are from the county government, close to around 90%, I believe so. Now, the funds for the county governments come from National Treasury. And you are aware that the cash flow is a challenge from the National Treasury to the county government, especially during the new financial years, July, August, September. We have got the dry spell. And NHIF here comes with regulations saying that they have penalties. Wajir County was paying around 400 million shillings to NHIF for the comprehensive cover for the staffs. And again, we are told 9th of every month, we are supposed to pay this 1,700 shillings for each staff, for each employee. And now for the staff to access the medical cover is that they must pay for the 1,700 shillings. Otherwise, that account is suspended for that month. And yeah, now we have a problem with the cash flow from National Treasury. And again, we pay 400 million shillings for the staffs. And again, you access to the facility is paid on 1,700 shillings for that month. And the staffs are, they don't have salary for 3 months. They can't access the medical cover. So based now on the new regulation that you came with, are you still giving maybe a lower hand to the county government staffs, or still you stand by your situation? Thank you very much.
Thank you so much. So, you see the questions are coming in thick and fast. So I'd request us to go for a short sugar level tea break. So we'll have tea outside here at the atrium. We have a 15-minute break. We'll be here by 11 exactly, when we'll start the next panel. Then we'll also engage on all the questions that have not been answered. So tea is served outside. It's served outside. We'll be back here by 11. For those who have joined in online, please keep waiting. We'll be back at 11. I'd also like to appreciate our sponsors. That's Farm Access Group, Illumina, Thinkwell Global, NHIF, who will also be here with us to engage as we continue in the next proceeding. So let's proceed outside for tea, then come back immediately at 11. Thank you.
The days to what it is now. That are attending Strathmore, the number of courses on offer, the investment in terms of infrastructure, in terms of the faculty. It is just amazing to be back here, and a very nice learning environment, actually. So very impressive to see what's happening here, and I'm sure this is going to continue into the future, and the quality can only get better.
The program was very insightful. For speaking personally, someone who was looking to develop himself, improve himself, and learn more about the entire board and governance aspect of business growth, it was very, very instrumental in just gaining that knowledge and shedding light on a topic that I personally did not understand too well.
Remember, boards, their mandate is just oversight, governance. They're not involved in day-to-day. But you find in many organizations where people clash between what's the role of management and what's the role of the board. So these programs actually brings it out clearly.
Most of the participants who come to try and learn how to make presentations to the board, prepare good papers. The relevance is to ensure that there is good governance. And for you to have good governance, it means that the board members have to have the right papers, the right information, not too much, not too little, but very strategic information that they can then use to make those strategic decisions.
We've actually established 2 boards for Synergetic Energy Partners and for Drillmatic. Due to the transition, we opted against a board of directors, but we opted to go with an advisory board, which is valuable advice we got from Kellen, who was and who has been quite instrumental in just providing guidance and insights even post board readiness program. Yeah, so something about the SBS teaching faculty, really stands out. So it would be amiss if I didn't mention that as well. So she's really guided us. We set up the 2 advisory boards, each with a 1-term duration from January this year to December, and we are planning to utilize that as our platform for onboarding either senior executives or board members as we move forward. Yeah? In terms of creating the framework for that, we've maintained the same framework you'd have for a board of directors, just with fewer powers with the advisory board. So everything that we learned, we are basically applying in the advisory board.
I'm a member of the group board here, and also represent the group in the subsidiaries. So it was really an eye-opener for me, having gone through this program, because there are things that actually we learned there, and I can see today how well we have been able to deal with them. For example, alignment, which is very, very key in the board. Many times we all have brilliant ideas, but the problem is to get everyone to sort of having the same thought process or going the same journey with the same idea. And I think that is what really has helped me in terms of managing those boards. Because as a management, one of the key things is to ensure that you align to your board. The second thing, and perhaps I may have said it, is trying to shift the boards from being operational to being more strategic. And this is much more driven by what we sort of learned in this program. It's trying to make sure that management know their space. The board also knows their space. And this is what I can say we have really achieved since I attended this training.
It's a fantastic program. We even have a board simulation session that's proved to be a good highlight, because when we do that, people can practice what it is to be in the boardroom, how to make presentations, the kind of questions to ask, the kind of board papers to expect, and they're able to critically look at those papers or even request for the relevant information.
The grant management program has been quite insightful for me as an M&E advisor, and especially now understanding the nexus between what we do in the M&E work together with the obligations that come with the grant agreement.
We've interacted with so many different people from different organizations, and our lecturers were very engaging. So we've definitely had a lot from them, and just interacting with the culture in Strathmore. You know, I was here 10 years ago, and so I've come back again, so the culture is still as it was.
Just besides the program, there's nothing that beats physical interaction. So we've been doing a lot of online, etc. But the fact that this course was delivered physically has really been refreshing, meeting new people, networking. But above that, the content has been great. I am not a grants person, but I'm leaving feeling like I can actually talk to my boss and say, well, let me manage this grant.
This program, one, we have experienced faculty who are industry players in grants management, with experience in project management, project planning. We have people who currently practice compliance and supporting different operations, both emergency and development programs. Then the program has also been structured in a way that responds to current emerging issues in the grant management space. Some of the areas that this program addresses are in compliance, proposal writing and fundraising, monitoring and evaluation and reporting. We look at finance and budgeting. Then we look at other grants operations like closeout and so forth and so on.
The benefits, I would say the content, and me, I'm a people's person. So aside from the content, I have made new friendships that I hope we can cultivate and make something out of it. So that's really key for me, yeah.
The composition of the attendance to the training is very essential because you have an opportunity to share experiences from different backgrounds and organizations in the discussion. For myself, I have no prior experience working with grants from the US government, and these have been some of the discussions we've been having in the training.
As a finance person, I always have interest in grants and compliance and risk. And so this program has just widened my knowledge on grant management, on the compliance aspect, and also on the risk aspect. Because once we receive these grants, we sub-grant them to other partnership organizations. And so just ensuring that the donors get their value for money and that we are able to report well to the donors. Something else that I gained from the 1 week experience is just making financial reports easy for program people. Because you know, for finance people, we easily understand numbers. But for programs people, you know, you have to explain, go beyond the numbers. So just making that easy by using charts, diagrams, analyses, you know, using a language that's easy for the programs people and also for the donors and other stakeholders.
We concluded the session looking at the pitfalls that come about with grant management, and especially to look at how do we effectively report on grant efficiency, looking at the triple constraint. That has been quite insightful, and it's something that I'm looking forward to implement in the next cycle of reporting when I'm back to the office.
You want to learn grants management and get to interact with people who have been out there in the field and are still out there in the field, actually working as lecturers here at Strathmore. I think it is a plus. You ask them actual issues that you are facing, and you can get real feedback.
This program is for you. You want to improve your way of working, you want to increase your funding portfolio, then come join us at Strathmore Business School for the experience.
Hi, my name is Amisa Rashid. I'm a mental health advocate and the founder and executive director of Nuvisha Foundation. and I'm also a student. Nivishe comes from a Kiswahili word which means to clothe you. So we clothe you holistically, mentally, physically, emotionally, psychologically, and spiritually, with the main aim of using or building community resilience using community-based mental health approaches, trauma-informed program for social cohesion. So our headquarters, as you've seen, we are in Kibra, because we tend to focus mental health at the community level, because most of the time we tend to forget the people at the grassroots levels who go through a lot of challenges, and yet they don't have the resources or information or knowledge about mental health. So that is why we are here. So one of the main programs that we do is community radio talk show. So we partner with Pamoja FM, which is a community radio talk show every Saturday, to talk about, to just inform, educate, engage the locals on matters mental health. And our program is one of the popular programs at Pamoja FM, where we have a lot of listeners tuning in, and it has led to people actually coming to seek more and more information about mental health at our offices. We also have one of our signature programs. Some of our counselors are trained to offer counseling services in sign language, so that when they're offering counseling services, the impact will just be the same as somebody who is physically challenged and somebody who is not, because we're trying to offer the resources. Another one of our important programs is that we have our mental health clubs. We work with all the institutions here. So our model is unique for our mental health club in that it involves the whole school entirely. So we come have mental health session with the students. We make sure we have mental health session with teachers, and mental health session with the administration, and also mental health session with the parents. And also one of the things that we tend to focus more on is empowerment, which we try to integrate it with working with different groups, because in Kibra we realize that there are a lot of community-based or NGOs or non-profits, a lot of them. A lot of people have been asking, Kibra, there's a lot of NGOs. Why is the rate of poverty still the same? Why aren't we moving on? I personally believe that we need to start approaching things from the attitude of taking care of our mental health first. Because if you start taking care of our mental health, you do the introspection, the reflection, you realize that maybe there's something which is stopping me. I may have all the resources available, but what am I doing with those resources to make sure that I'm moving forward? Maybe I have imposter syndrome, which is stopping me from taking opportunities, and the opportunities are there. So which is going back to your mental health. So how can I make sure that I'm using the resources to do that? So that is in a nutshell what we do at Nivishe Foundation. One of the key achievements is that majority of the people they don't know us per se, but they know Nivishe Foundation talks about mental health. Anywhere you go around, you'll find that people, mental health, they tell you it's Nivishe Foundation. Since 2019, that is, we've actually been able to work with 10,000 youth and 5,000 plus women. And then we've been able to work with 200 people with disabilities, hearing challenges specifically, who have been able to come to our to gain services from us. I'm a product of mentorship and enter also people. So for me, if I didn't have this support system of women whereby if I feel bad, if I need encouragement, if I need any sort of support, I know that I can go back to them and they'll offer like a shoulder to lean on, or they'll hold the space for me, I wouldn't be here today. So whichever place you are, make sure there is always somebody willing to hold your hand and walk with you. So identify that person and let them be part of the journey and allow them to walk the journey with you. Yeah. Wow, I think MPPM has been one of the best decisions that I've ever made. For instance, this semester has been particularly interesting for me because we have learned strategic management. Strategic management basically it just highlights how me as a leader can come and run my organization. It is practical to the extent that whatever I learn at the classroom level, I know I'll come to implement it back to my organization. I would recommend it specifically at Strathmore because I think Strathmore is student focused to the extent that you feel like you're learning it. It has been made so easy. You enjoy learning at Strathmore.
That is a win-win for you. and what will happen?
My name is Caroline Mwangi. I am the HR Director for Schneider Electric East Africa. So East Africa comprises of Kenya, Uganda, Tanzania, and Ethiopia, but we support like 10 countries in the greater East African region from Kenya. It's been an interesting one. So actually my background is in IT, so I have a Bachelor's of Science, bachelor's degree in IT, a BSc in IT, but I have never worked in IT. So I think my 8-year-old is better in IT than I am, I kid you not. So I moved to people. I am just so passionate about people. I love impacting people. I love having conversations with people. And my first ever job was a PA to an amazing gentleman, Mr. Moyes, in motor sector. So he did not have a HR department. And I told him I'll put together a HR department for him. So I went to the internet and I Googled. I approached people on LinkedIn. I got mentors who guided me and told me what HR is all about. And I put together a HR department, a personnel department then, because it was basically putting together files, making sure we have basic policies. And when Mr. Moyes saw the passion that I had, he sponsored me to IPM, which is now IHRM, to go and do my national diploma in HR. So from there, I have gone on to do an MBA. I'm a certified coach as well, organ assessing coach. So it's an area that I have really invested in myself in growing because I'm passionate about it. There's so many achievements that I can think about because it's been quite a number of years, maybe over 17 years. That makes me sound very old. But there's so many achievements. But notable, when I worked in the logistics company, we had a challenge getting early careers in the system. So we introduced what was known and still continues today as a management trainee program. And we were recruiting from East Africa. So we had recruitment drives, go to all of the universities across East Africa doing recruitment drives. And I'm very proud today because most, like 80% of the young people who joined that program today, it was a 2-year program, today are leaders in their own areas, in different areas, and they are managers. And today when we meet, I'm very proud to see that that's the first program we ever did, and today they're making a change in society. The second one, I'll speak about a recent achievement. So it's a work in progress, it's an ongoing achievement. So Schneider acquired family-owned business 6 years ago. And we never really went through a proper culture transformation process, which is very important if you're merging companies. So we embarked on a culture transformation journey, and I can tell you in terms of engagement, in terms of collaboration, in terms of even employer branding, we have moved so much in the last maybe 12 months. We are not where we were. So that is a notable achievement for me because it has really transformed the organization. One of our KPIs as an organization as well, we call ourselves the most local international company. So wherever we have presence, we want it to be a local multinational. So we have managed to localize our country leadership. Our general manager today is a local, and on top of that, a lady leader. So for me, again, that's a big achievement. So one is be a lifelong learner. Never stop learning. Never stop wanting to better yourself. There's also reading books. You see people saying they have read 52 books, and I used to wonder, how do you do that when you read everything else that you're doing? But you come to realize every problem that exists, somebody has written about it. So how are you going to know what solutions are out there if you're not reading? How are you going to know how to better yourself if you're not reading? So one is be a lifelong learner. Read, 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 read. Two would be give a hand up, mentor other people, because I'm sure it took quite a number of people to get you to where you are. So as a leader, be willing to always give a hand up to other ladies. Never shy away from claiming your achievements. That's something that I don't know whether it's nurture. In our context, we're taught to be modest, so we don't want to scream about what we have achieved. Do not shy away from claiming your achievements, because if you don't, promotions and things will just bypass you, because there are people who are better at verbalizing what they have done, and you could actually be doing more. But the fact that you're not talking about it, nobody knows what you're doing. So do not be scared to verbalize, to claim your achievements. Another one that I would want to add is asking for help. So as ladies sometimes, and especially sometimes, you might find yourself in a very male-dominated environment. You feel the pressure to want to prove that you know what you're doing. Ask for help. And I keep telling people when I'm having meetings or when I'm interacting with people, there's no foolish question. Because you ask, that's how you get to learn. If you don't ask, you'll never get to know. I think for me, SMLP, the journey was very interesting. It was unlike many others because we were the first pandemic cohort. So we were doing it different. And I think it was different and challenging and good at the same time because the world was also shifting in the ways, new ways of working and all that. So it taught us resilience. We had to be very resilient. And it also taught us to be very patient with ourselves and with others, because the first 3 modules we had to do them virtually. It did not help my case because I was the class president. That meant I had to work extra hard to make sure that people were connecting, people were talking, people were communicating, people were showing up in class. And all said and done, we have managed to get I personally have managed to get very good networks from my cohort and good friendships. There are people I know I can call today and they'll pick up the phone, and I met them in SMLP. And a lot of the things that I am applying today at work are from SMLP program. Why I'm running the current program that I'm running at work is because I chose to run with it as my SMLP project. So it sort of held me accountable. I could not procrastinate. It needed to run, it needed to move, so I needed to align with the stakeholders. I needed to get support. I needed to get the sponsorship of the senior leadership. And that, all the confidence to do all that came from SMLP.
Frank Mola is my name. I've been with MasterCard for the last 5 years now. I enjoy dancing, so I'm a dancer. I'm a Rumba dance instructor. But outside of that, Frank is a certified negotiator by Strathmore Business School and by Harvard. There's one thing that I've always believed in, right? And that is going to tie into my journey and mainly why Strathmore became one of the pillars and anchors of a business school, which I felt is going to be part of my career growth and my professional path, is 10-10-10. So 10-10-10 is whereby I believe I need to sit back and ask myself, whatever I do in the next, for example, what I do now, what is the impact in the next 10 seconds, in the next 10 minutes, in the next 10 hours, in the next 10 days, in the next 10 weeks, in the next 10 months, in the next 10 years. So by the time I was coming to do the master negotiator with Strathmore, I did my 10-10-10, and I told myself, in the next, the 10-10-10s that I've mentioned, where will I be? So when I work backwards, because I can see the future and I'm bringing it now, then it gives me the motivation to be able to say, let me enroll, let me get, if it's a loan or whatever it is, so that I can do this, because I've seen where this is going to take me. And in everything I've done henceforth, from the time I discovered 10-10-10 rule, it's always made a lot of things easier for me. In our day-to-day lives, you can apply 10-10-10 in any action you want to do. You want to be a CEO? Do your 10-10-10 now and ask yourself, what is it that you need to do in the next 10 years for you to become that CEO? So you have to start practicing it now. The Senior Management Leadership Program was 2 years ago, and the reason I enrolled for Senior Management Leadership Program is because while at MasterCard, I was among the few individuals who were selected to join a program called Future Leadership Program. And I started learning a lot about leadership. I started learning a lot of people. I started appreciating that there is something called servant leadership, right? And I said, hey, this is not enough. The Future Leadership Program is not enough. That's when I also came back and I checked Strathmore and asked myself, is there anything linked to the Future Leadership Program? And then I saw the SMLP program, which was running for a whole year.
And the moment I completed the course, I could see myself performing way better, because the beauty is the fact that you're doing the course and you're applying it instantly. So I could apply all the different leadership styles. I remember doing something called a mirror exercise, my friends. Oh, that was an eye-opener. That was an eye-opener. You know, the way you see yourself is not the way somebody else sees you. Singapore was really nice. I really enjoyed Singapore because it brought the unit together. You know, when you start the program, you come and then you go, because you still have to work at the same time. But now Singapore, you connect with these guys real time, because you're spending the whole time, breakfast, you're in the same apartment block, you have to be in groups. So you get to know people now. Oh, this is so and so, this is how they are. And you know, you interact more. Outside of just career-wise and professional-wise, you realize leadership is practiced in each and every place, right? Be it in the family setting. You come, I'll tell you, like, for me, in my house, what happens is we have dinner at 7:30, without fail. Whether I don't know which call, whether I don't know I'm where, but at 7:30, as long as I've not traveled, I have to be in the house. And everybody has their own responsibility. There's somebody who sets the table, there's somebody who... And the beauty of that is, from SMLP, when I link it to the family setting, is where now you come and find each and every day, we have somebody who is a leader. My last child, he's a chairman today on the table, so he's the one who asks us, Daddy, how was your day? And he's the one controlling the table, right? And nobody can interrupt him. So every day there's a chairperson who controls the table, and we have to listen. My parting shot would be, success is not a destination, it's a journey. And all of us have different journeys, all of us have different paths. Some people take longer to get to certain places, some people take shorter time. So everybody has their own path. And as you grow into the leadership, you have to keep on learning, you have to keep on developing yourself. You have to keep on being in the game and just getting the trends. But as you go up, try as much as you can to mentor as many people as you can. Try as much as you can and to bring so many people up as you can, because remember, you cannot be a successful leader if there's no one you've brought up. I cannot claim and say, today Frank Mola is a managing director, but how many other people have I mentored? Success is only measured by how many people you've brought up. So to the heads of departments, to the CEOs, to, you name it where you are. To me, the question here is, how many people have you influenced? Because leadership is all about influence. So who are these people who sit back and say, Frank, you've impacted my life or influenced my life in a certain way? It's not just about the title, but it's about who you are as a person.
Leading High Performance Health Organization, LIHO in short, as the first name goes, it's about leadership, and it's about leadership in healthcare. The approach we have taken is a responsible leadership. But we are saying leadership is not a noun, it's not what you are. Leadership is a verb, it's what you do. The approach we take in LIHO is you as a leader create the atmosphere for people to solve their problem. You as a leader, if the problems were easy, they would already have been solved. So by the time you're coming in to address a problem, we recognize that it is a difficult problem. And difficult problems require learning. They require a new way of thinking and a new way of doing things. This is called the adaptive leadership approach. And the LIHO program is based on that philosophy.
My name is Dr. Willie Sakwale. I'm a medical doctor by profession. Currently, I'm a special advisor to Kenya's End Malaria Council, and I also serve as the chairman of the COVID vaccine task force. Now, one of the things is I reflect back to the time when I started my career in medical profession as a medical officer. 2 to 3 years after I graduated, I was made to be in charge of the district. We called them then District Medical Officers of Health. And that position had a lot of requirements. All of a sudden, without any training, one was responsible for financial resources, human resources, day-to-day management of health facilities. And definitely these are skills that one did not have. And we did a lot of learning on the work, and it wasn't easy, the learning.
Good morning once again. Good morning once again. You don't sound as if you've taken enough tea. Eh? Good morning once again. So I'd like to appreciate you for your patience so far. I'd also like to appreciate our sponsors once more, Farmer Access Group, Illumina, ThinkWell Global, NHIF, distinguished healthcare leaders, guests, panelists, and colleagues. I really appreciate you for being here with us and for your engaging conversations. Those who have dialed in online, we really appreciate you, as well as those who have dialed in from our classroom in Oak Room. Feel free to ask questions as we proceed. So at this point, I'm going into the next panel discussion, but before that, we'll have a spotlight address by a lady who is a seasoned government stakeholder relations to enable the adoption of genomics technology in Africa. She has worked as a senior director of policy and advocacy, and she has led strategic design and implementation of advocacy activities across Lavi's overall Africa portfolio, as well as key aspects of policy advocacy, ranging from policy analysis to advocating for evidence-informed policy change. She led research preparedness in Africa to ensure gender balance, recruitment, retention in the clinical area. So a round of applause to Yolanda Moyo to give the spotlight address. Karibu.
Good morning, everyone. Thank you so much for coming today. It's a pleasure to have you all here. As the program director has said, my name is Yolanda Moyo. I'm from Illumina. I'm based in Johannesburg. And my role is government affairs at Illumina, and my portfolio is the Africa region. So today's session on genomics is one that we've been looking forward to because we want to expand this technology in Africa. So I'll say a little bit about Illumina and really give a brief introductory session and hand over to our panel moderator. So Illumina is a global genomics company which is based in San Diego, California. We have another headquarters in Cambridge, UK for the EMEA region. We're a mission-driven company, and we're committed to delivering sustainable long-term value by addressing the most significant health, social, and governance issues globally. At Illumina, we believe that attaining UHC is something that's going to depend on strong cross-sector partnerships and innovative health financing models. Partnerships and collaborative approaches accelerate adoption of scientific tools and innovations by mobilizing expertise, resources, and ensuring shared accountability in the implementation of UHC. National governments cannot do it alone. So we saw during the COVID-19 pandemic that genomics emerged as an essential public health tool for tracking the global spread of SARS-CoV-2. So genomics provided the evidence of when and where an outbreak began. It allowed us to monitor important changes in the virus as it continued to circulate. It provided crucial information to aid in identifying diagnostic and therapeutic targets. But despite being available in many facilities in developed countries, access to next-generation sequencing technologies remains a challenge in low- and middle-income countries. Public-private partnerships are very, very important. And at Illumina, we have engaged in a partnership with the Africa CDC in an initiative called the Africa Pathogen Genomics Initiative, PGI. This initiative is led by the CDC in collaboration with Illumina, Microsoft, Bill and Melinda Gates Foundation, and other partners. And we're helping to close the access gap through this initiative. And Africa PGI is guiding the establishment of a cross-continental laboratory network for pathogen genomic sequencing. The program has led to more than fourfold of in-country pathogen sequencing capacities across 52 countries in Africa. But we know that the utility of genomics goes well beyond pathogen surveillance. This cutting-edge technology has the potential to address some of the most pressing issues of our time, from food security to climate action. In West Africa, for example, in the Yam Belt, researchers are using genomics to sequence, and to tackle food security by studying yam varieties to improve agricultural productivity. So genomics provides insights to researchers to help protect the species from climate change, disease, and other risks. Despite the great strides made recently, much more needs to be done to ensure equitable access and to establish a sustainable genomics ecosystem. Strategies to maximize the benefits of genomics should encourage good data management and sharing, utility of genomics data, and forge national and international cooperation to support UHC. No one should be left behind. Researchers, policymakers, industry partners, public health experts, and civil society groups all need to work together to accelerate access to life-saving health technologies as we look forward to UHC, SDGs, and the post-2030 agenda, as well as Agenda 2063, the Africa we want. Genomics should be at the core of advancing and meeting these targets as a science of the future. So thank you so much, colleagues. Without further ado, I will call upon our moderator for the panel section, Dr. Rono, to take us to the next part of the program. Thank you.
Sure. Good morning. It's such a pleasure to be here again, and thanks to all of you for making time to speak and to join us on this important topic. I've a singular privilege to host a very illustrious panel to help us really put apart the genomics discussion and really ask the question, how do we leverage on that to improve healthcare for Kenyans? So I would want to call to the podium, to the front, the panel that we have today. I'll start with Dr. Damaris Matoke, who is Deputy Director of the Biotechnology Research Program at KEMRI. We're really privileged to have you this morning. Thank you very much for coming. I'll call upon Dr. Lucas Nyabero, who is the CEO of the Pharmaceutical Society of Kenya. And I'll also call Mr. John Paul Omolo, who is a Senior Advocacy and Policy Officer at PATH. And it's really a pleasure to have you on the panel as well. We're expecting the CEO of NHIF to join us, so as soon as he comes, I would invite him to the panel. But before we start, I'll ask each of my panelists to just speak for a minute about what they do and in relation to genomics and healthcare before we go into the actual question. So probably start with the far end. Thanks.
So thank you, Dr. Rono. So my role is government affairs, and when we talk about genomics, it's really important that we have an enabling policy environment. It's not good enough to have excellent researchers working in isolation of the policymakers. It's really, really important that everyone works together collaboratively and national governments put in policies and enabling legal frameworks to enable genomics. So my role is really a tough one because I know it's not easy to ask governments to put in policies and also to invest in the same policies and make sure that our researchers really are working within a framework that enables the science of genomics. So thank you.
I'm Damaris Matoke Mweha, as they said. I work at KEMRI, where I head the biotechnology research program. I'm a molecular biologist by training, so I've been working on looking at the genes for a while for malaria and other diseases, but courtesy of COVID, we've invested heavily on sequencing work and also trying to identify the various strains that are there. So our capacity is more of generating data that can inform policy as far as genomes are concerned. And this is not specific just only for infectious diseases, but also we look at other non-communicable diseases. We are going into cancer genomics. We are going into looking at diabetes and the role the genome plays as far as management of the cases are concerned. So for us, we generate data that informs policies and advises as far as the treatment regimes are concerned. And also we've seen, even looking at malaria, whereby the diagnostic kits that we have are not able to detect effectively the kind of parasites that we have that are circulating in the country, where we have what we call as HRP2 deletions. So what do these mutations mean as far as case management is concerned? So that's one of the works that we're doing, looking at the genetics, mutations, and their contributions to diagnosis, treatment, and also management of cases. Thank you.
Well, I have to follow that. So my name is Dr. Lucas Nyabero. I am a drug dealer, no, I'm a pharmacist by profession. And as regards to pharmacogenetics, for me, genomics, pharmacogenetics, is about personalization of care. Right dose, right drug, right indication, right patient, right time. I also serve the pharmacist as the CEO of Pharmaceutical Society of Kenya, where we are trying to make sure that every patient gets effective medication, efficiently, quality, safe, and affordable at all times. How is this connected to pharmacogenetics or genomics? Is the personalization of care is actually a big thing that we're not looking at. There are medications that I can take, and they will help, but my brother will not have any, will not get the effect. Actually, it may be deleterious to my brother. And I give you a perfect example. Cholesterol medication, there's simvastatin, there's atorvastatin. There are people with atorvastatin, they'll get rhabdomyolysis, the breaking down of muscles. And that has to be treated. So the cost of treating diseases that are caused by wrong medications, that's what I was trying to suggest to NHIF. You need to be able to make sure that the patient being treated, the treatment that is being allocated, does not cause a bigger problem that you have to then deal with. And personalization of care, I know we'll hear investment costs and everything else. Yes, the initial investment, Illumina will tell you, it's expensive. But think about it this way, the tail of that investment. How many years, how many people? If you get 100,000 people who are on genomics and then you're getting the right treatment to them, how much will you save? So let's think about not how much we're investing now, but how much are we going to save in the long run? How many illnesses are we, how many people sitting in hospital today are there because they took the wrong medication? Do we know that? We don't, because we don't look at that.
Thanks, John Paul.
Great. It's afternoon or it's morning. It's still morning. Good morning. It's a pleasure. My name is John Paul Omolo. I work for PATH as a senior policy and advocacy officer. PATH is a global institution, non-state, and our main work is to ensure that the most marginalized populations can access the highest quality of care. Within PATH, I'm responsible for advocacy work for 3 main portfolios of work: regulation of medical products across Africa, local manufacturing, and an ecosystem that strengthens health research and development. And for the sake of the conversation today, where we're talking about genomics, there are two interlinking areas: research and development, as well as manufacturing, and this specifically looking at local. And when I'll be speaking local, might mean Kenya, but I specifically mean Africa. And this is where we see that linkage, that Africa has not been involved a lot, and I'll speak to it in my presentation, in doing the actual clinical research. And it's because of several other things, historical injustices, and we know that, and there's always that fear. But I think it is important that we realize why genomics is really important if we have to advance our research and development. Take note, I'm talking about research and development, not just research. When we are doing the research for the sake of making products available, and those products, as my brother Lucas has mentioned, needs to be person-centered. So at the end of the day, we need to ensure that the research that is being done is person-centered and is able to really address, and policies needs to be in place. Our governments must put their mouth where it belongs, where it matters. And I think the issue of policy is key. I think previous presenters did indicate that government, the public sector cannot do it alone. It is important that we catalyze this process through the private sector and make sure that at the long term, there's a very clear roadmap of how governments are able to invest in this so that we are able to host, we are able to control and take leadership of our genetics. And I speak more to this. Thank you.
Sure. Thanks again. As you can see, the panel is quite diverse in terms of their background, and mine is really to moderate the conversation. My name is Dr. Rono. I'm from ENK Consulting Firm, which is a strategy advisory firm working in a couple of African countries now. So I'll start with Dr. Lucas. I think you're quite modest in your introduction. You didn't mention that you've worked in pharmacogenomics in other parts of the world where genomics have actually been applied a lot more in health. If you were to reflect on your experience both in the US and in Kenya, in simple terms, what do we need to do to get there in terms of, is it infrastructure, is it human resources, is it policy? How do we get to leverage on the genome to improve patient care, improve access to care? How do we get there?
Money. I think
I was hoping you would not say that fast, but carry on.
I think it's the investment. And I'll give you a very good example that happened about a month ago. So somebody very close to me had to go through surgery. Prior to us, when we were in the US, we actually did the genomics. I have my own pharmacogenetic profile, so I know I can't use morphine. If I was to be going for surgery, I'll tell the doctor morphine doesn't work because of a mutation, COMT gene mutation. So I will tell them use something else because I will not be my pain will not sufficiently be managed. So somebody very close to me had to go through surgery. I mentioned this to the anesthesiologist and I gave them the report. And he went through the report and changed his whole plan. Post-op, during the operation, and pre-op, during operation and post. Changed what drugs they were going to use, changed how they were going to give it, the doses, and at what intervals, based on the report. Now think about it this way. If he had gone by his plan and the medication didn't work, they would have been adding doses. If you add a dose, you're pushing somebody close to adverse effects, or worse still, you're pushing an organ or two towards a place where they shouldn't go. So he changed this, and sure, the outcomes were much better. And not only that, even the outpatient meds were different. And the outcomes bears the benefit of it. So what I'm trying to suggest is, yes, the initial investment is going to be big. But this idea of thinking about today, in everything we do, what is it for us now? Let's just change that a little bit and think about what is in it for us tomorrow, next year, and on. That is including how we manage our healthcare, how we manage our politics, how we manage our education. Don't think about today. Today has already happened. You're sick already. how do we make sure that you don't get sicker by getting the wrong medication? And that's what I was saying with NHIF. There are two things. There is contribution, how you get the money in, and there's expenditure, how you spend it. Now, if you spend it to deal with a liver failure because somebody used medication they shouldn't have used, you've just tripled what you're going to spend on this patient, and that is going to have a long tail also. So pharmacogenetics is just personalization of that care. So you get the right medication. It's the most efficient, effective, safe, quality, and of course it's going to be affordable because you're going to use only what you need. Same thing with chemotherapy, same thing with vascular disease, same thing with pain management, same thing to diabetes medications. It affects the whole gamut of illnesses that you do. So we're talking about financing, healthcare financing. There is another way of financing. By reducing the expenditure, you get extra money on the other side.
Thanks, Lucas. You talked about investments, and probably that's a good segue to bring Dr. Damaris into the conversation. Damaris, you spent quite a couple of years as an advocate for investments for R&D. The question of investments keeps coming up. The question of health finance keeps coming up. From where you sit, how do we go about that? How do we get that investment into the genomic space? I think the return is probably there, but how do we get that initial investment? Thanks.
Yeah, I think research is one of the areas I could say that is extremely neglected as far as financing is concerned. We know in Kenya the budget allocated to R&D is about 0.8% of the country's GDP. So you find that of these, 1% is what is given to health research. And then for me, it's usually like, are we serious about healthcare? Are we serious about how we are going to get solutions and innovative solutions of managing cases and ensuring that people do not get either treatment or diagnosed wrongly because we don't have real-time, can I call them gadgets that are customized to our population. So for me is we need to be able to come out of donor-driven research because that's what we are doing in most of the research institutions where we are. You find that we get funding from out there. So the government promised to put around 1% of the financing towards research, which it has not honored to date. So if this can be done, then it will boost on the amount that goes to health research, and therefore expediting or pushing us towards the idea or the part of detecting, because we need to detect effectively. Whether if you're sick of a certain disease, if someone is unwell, be it you're having a terminal illness, it needs to be detected. What state is this? We need to get innovations that can pick specifically our population. If we borrow from what we've seen from COVID, we realized that, we couldn't even send our samples out there for them to be analyzed, because that's what we've been doing for a long time as far as genomics is concerned. We collect our samples here because most of the diseases are endemic in Africa, and we send them out there. This happens not only in Kenya, but other sub-Saharan African countries. That story needs to change, because then when you get pandemics such as COVID, you realize every country is fighting for their own. Then you find if you have not invested both in infrastructure, you've not invested in human resource, you've not invested in even utilization of the data. Because you find when data is generated from the platforms that we have, be it the Illumina platforms, data is so huge, people cannot even synthesize and tell us the story, what it means to the layman down there. So therefore, for me, is that investment, both ways of infrastructure, human resource, and also utilization of that data from just being raw, telling you that we have these strains, then what? This policymaker needs to pick it from there and use it to give us solutions that are important to our health. Thank you.
Sure. Thanks, Damaris. You mentioned something that makes me want to bring John Paul to the conversation, because John Paul, you wear many hats, and in some circles you've been called a donor. So, but the question I have for you really is about, we've worked together for a couple of years around raising investments for R&D or genomics. We've got some successes, but we are not at 100%. What are the use cases do you think we need to put on the table? What other avenues do we need to look at? Is it pharmaceutical manufacturing? What else do we need to leverage on to really bring home the message that, there's actually an investment case here for genomics?
Thank you so much, Dr. Rono. And I'll speak to this as an advocacy person, not advocate, advocacy person, because I think a number of times when we speak about what is required to either policy or decision makers, we talk about the issue from our point of view, not necessarily looking at it from their point of view, so they're not able to fit within the context and drive that agenda. And we have done quite a lot of work on investments on health R&D. Over the last week and up to yesterday, we were talking around manufacturing in Ghana, and we came back, and there are certain things that I would like to speak to if you allow. And one of the key things is, what is the value proposition for genomics in all that we're talking about? How are we packaging that value proposition? And most importantly, the cost of inaction, the cost of not doing what is right as we move forward. Africa in itself has only contributed to about 2 to 3% of the genomics work. And when I'm talking about genomics, not the pathogen, but human genomics. And we all know that at the end of the day, when research and development is being done, that is what goes into product. What we are saying, some of the products does not necessarily fit the context. So the African gene pool, which is one of the widest, has not been used in research and development. But do our policy and decision makers understand this? Do they even see the value? Are they able to start appreciating the value of genomics in health, the illness, and treatment that are there? We need to really appreciate and create real strong policy briefs and create forums where we are able to entice and make policymakers understand why sometimes when we talk about the quality of care, and I think Professor Kokwaro, being that he was teaching, talked about when we want to measure quality of care, we start with safety being the first thing. Safety is very key, and sometimes the safety is not like you've gotten the wrong medication. You've gotten the right medication, but the active ingredients in it might not be good for you. So we need to drive policy agendas and research that is within our gene pool. And of course, we know that the next big growth in the industry, in the globe, is within the pharmaceutical. And that requires R&D. That requires that we lead with policies that are really aligned. And we need to make sure that our industries and the people within Africa are part and parcel of this. So to answer your question, I think the first thing is we must be able to talk to our policymakers, show the value proposition from both the health and the economic point of view. Sometimes health points of view can easily be brushed off. But when you speak to the Ministry of Finance and we talk to them about the value of genomics, do you know that a single person's genetic data costs about 1,900 USD? And when you mix that data, genetic data, with clinical data, it goes to about 6,400. If we are talking about the next phase issue of big data, our Ministry of Health can take advantage of that in a big way and just invest in genomics, and with that, we can sell that as a country to all our pharma industries. I know the farmers are here. But again, it's going to be the big thing, because if government does not take control, someone is going to do it, they are going to host it somewhere outside, and we will have to buy it, because it is coming. It is not a matter of if, it's just when.
Sure, thanks John Paul. I knew you were going to drag our pharmacists into this conversation. I hope you'll have a chance to respond once we open the plenary for questions. But before we do that, Yolanda, you've been involved in working around the continent on government affairs, supporting governments on policy development. And John Paul talked about, we're going to have the right policies in place to attract the investment. How, from where you sit, how best do we do that? And what how can Illumina support this process given your thought leadership on genetics as well?
Thank you, Dr. Rono. I think there's the first place to start is education and awareness, because I think there's a lot of gaps in terms of just knowledge. What is genomics, and how exactly does this bring value, or what are the benefits of investing in genomics? I think there is really where we start. Once that is well understood, then I think bringing all partners together, all stakeholders together, because there's a lot that is being done, but it's being done in sort of fragmented, ways where people are just doing activities in isolation. They're not coming together and really, because the government, they want solutions. I mean, if you go to them with problems, without a solution, then you really are not going to win. So I think bringing together all stakeholders, private sector, public sector researchers, everybody put their heads together and say, look, this is the problem that the government has, and this is a solution that we propose, and let's work together. So I think really that is the best approach. Thank you.
Sure, thanks for that. I'd want to invite the audience to raise their questions and weigh in on this conversation. But just to mention one thing, we were privileged to work for Gavi, the Global Vaccine Initiative, and one of the things that came up was that, okay, there's an Ebola outbreak in Uganda. How do we support the country to respond? And then, there are stockpiles of Ebola vaccines that have been created over years, but then it turned out that the stockpile that was created was not for variants that are prevalent in Uganda or DRC, because the R&D was based on, Ebola variants from somewhere else. So the country has to wait a little longer before, new vaccines are put out. So I think that brings it home in terms of the urgency. But I'd like to pause here, invite the audience for questions and comments. And it's really a free conversation. So we've got a hand up here. Let me come to you. Either way.
Okay, thank you very much. Once again, my name is Ibrahim, former CEC Health, Wajir County. Thank you, panelists, for this great discussion. Just a quick one, although I also have a health background. Based on the indicators from the late 80s, 90s up to date, I think we are doing very well in terms of reducing the communicable diseases. But now our NCDs, that is non-communicable diseases, especially hypertension, diabetes, and cancers, are actually emerging. And I think maybe Africa and Kenya, by extension, maybe the population might go down from 49 million, maybe by quarter, and maybe by 2029. So my issue is, you being the researchers, what are you doing about it? Because based on the, don't say maybe lifestyle diseases, no. We know lifestyle, yes, but we understand that we have got a lot of GMOs food in the market. So maybe what's your take on that? That's one. Number two, Africans and Kenya by extension, we have got, we are good in writing policies, policy documents and guidelines, especially in the health sector. In health, by the time maybe a guideline is already released to the facilities and the health sector, and before even it's been implemented, another one already has come. So we have also a problem with the policy implementation. So what plans do you have also for that? Thank you very much.
Hello, my name is Dr. Anne Musuva from ThinkWell. Thank you very much for the really interesting panel. My question goes to probably Dr. Lucas and Yolanda. Are there studies that show from other parts of the world how investing in all this, genome mapping and so on has saved on healthcare costs, especially costs in the, on drugs and commodities and so on? Thank you.
Thank you so much for the insightful conversations. Reflecting on the work I did during my doctoral training that aimed to look at how the Kenyan public health system is responding to chronic non-communicable diseases. We look at chronic lung diseases, and some of the issues we explored through the lens of asthma. And one of the striking findings from this study is that there's a lot of stigma on asthma, and part of the complication is coming out of conversations about issues to do with the hereditary factors. So a patient is told they have asthma, they protest and say it's not in the family. Your child has asthma, I don't have asthma, how could my child possibly be having asthma? And this complicates the entire process of treatment plans, and the person-centered care that your aims are, your studies, your presentations are all focusing at. So my question is, even as much as you are looking at enhancing person-centered care through probably efficiencies in terms of diagnostics and treatment plans, what sort of harms do you see coming out of this in terms of unintended consequences and profiling of people based on their genetic profiles? And you also have implications in terms of probably accessing insurance, accessing employment based on genetic data. So what sort of harms do you see, and what mechanisms are you thinking could safeguard the publics from some of these problems? Thank you.
Thanks. Maybe we have the panel respond to that round of questions, and then we can see how we're doing on time. I think, Lucas, you wanted to speak right from the start. Maybe you can just carry on.
I'll just do a quick one. Absolutely right. Where I was, what they did, there was a law that was enacted that said you cannot offer or deny insurance based on genetic information. Because this is, again, thinking about tomorrow. The system there knew that the information is going to be important for ongoing healthcare policy. So what they did, they cauterized that quickly so that any data, so make it easy for data to come in. So that's on that. As regards to the hereditary issue, I think that's a cultural thing. When we used to want to get married, you'd be told, hey, wana kifafa, what is happening on the other side. That's something that is that's cultural, that we need to deal with. To the question about the effect on healthcare. So we don't do this here, but there are some jurisdictions that do the economic cost of, I know this one for sure, economic cost of medication, not medical errors, medication errors. And it shows what that means is if you take a wrong medication and you don't go to work, there was work that you should have done that day that you can't do, and you took the wrong medication. And in the US, it's between $20 to $40 billion a year. If you extrapolate and use just straight to the US, to Kenya, it's about $3 to $6 billion US dollars of economic output that is lost a year. The total cost of healthcare, I think from this morning we learned out in Kenya, is about $6 billion. So are we suggesting, and this is something to think about, are we suggesting if we use our medications correctly, we will generate enough economic activity to pay for healthcare, medication use? Lastly, you were asking about the NCDs and GMOs. I won't touch GMO, it's political, that's clear. And then as regards to policies and how quickly we implement them, I think that is something that we need to think about again tomorrow. How do we make things that are long-lasting? If you make a policy for today, tomorrow it's obsolete. We have to think beyond today. That's the thing that we are not doing. Even NCDs is that we are not thinking beyond today. When I eat the way I eat, when I do the things I do, it's for now to feel good now. What will happen tomorrow, the day after tomorrow? So we have to also take responsibility as a people to be healthy. Thank you.
Damaris, carry on.
Yeah, I just want to do quick feedback on some of the questions, especially the first one on what we are doing as far as involvement of these diseases, cancers, diabetes. At Cambry, there's a lot of research going on at the moment, only that the impact of research is usually felt way later, because even the data, you find that you're doing a study in a small population. Like for cancers, we are doing profiling families, whereby we are going to communities, identifying where a case of, let's say, there are 5 cancers, that's prostate cancer, breast cancer, ovarian cancer, stomach cancer, and I think there's one, nasopharyngeal, the one for the throat and nose, etc. So we are trying to profile in families where a case is reported, then you screen the entire family genetically to see whether they have markers that can predict or that can tell us they are likely to have this disease later on. And that helps us in a way that then you can inform whether they need to start continuous screening or immediately or wait later. And also you're able to tell what they can start doing as far as prevention is concerned. And that's in a small scale because it's being done in specific communities, it's a pilot study. So we believe if this data provides us with useful information, it can be scaled up to other populations. And this is done also for diabetes. So I believe genetically will grow. I think it's in small scale at the moment. And as far as issues of the question he asked on asthma and other stigma related, for cancer specifically, we put in counseling in a way that if you identify to have these markers, you need to be told what next. Because does it mean that it's a death sentence to you? So the component of counseling that comes in, and also education, because community are now told that really having these markers doesn't mean. It's likely that all of us have markers for certain cancers, because yes, cancers is increasing. Why is it increasing? Is it because we are doing a lot of screening at the moment that we were not doing previously? So this, or is it because people have changed the way we were eating before and what we are doing, or are we predisposed to more things that are causing or are bringing this cancer? So there is some research going on. So I believe that as we go by, we'll get data that will be useful for informed decision making.
Yolanda and then John Paul, and then we can take a few more questions.
Okay, thank you. I just wanted to respond to the question about data and the return on investment in genomics and whether we have that data. You know, I think there's been a few papers that were published, but really it's been done mostly in Europe and in the US. We don't really have that data for the African context, and that's something that Illumina is looking to actually start doing, to see how we can have this data, because it's not only going to be a tool for us to talk to our governments about, but it also gives us really a clear picture of what would happen in, or what the investment case is in Africa. And I think looking at the African context, it is so different to Europe and the US, because if you think about it, one person who is employed and working has got a lot more dependence. And if that person is not able to work for whatever reason, whether it's, you know, it's because they've been given wrong treatment, or, you know, it impacts on so many other people that they are dependent on this person. And as we're talking about UHC, the tech space is already so small. So if you look at the impact of people not working economically on the tech space, it's also something that we can put into that economic you know, data to see what the investment case would be for Africa.
Sure. Thanks, Yolanda. John Paul?
Yeah, just a quick one, and thanks. Two things. I think the question around policy development and implementation, that's been my bread and butter, developing policies but moving them towards implementation together with Yolanda when she was still at PATH. So technically this is the way PATH has structured the process. I do a lot of policies both at country and the continental level, and many a times the best thing that we do is, I think in the morning, Prof, when he was speaking, he said functions inform structures, right? Those structures then inform financing. And I think that is exactly what we need to do, because what we do is at the end, for the policies we've developed, we make sure that we follow it through to the point that they're financed, and we get engaged in the financing conversations, including both at county and national level, and make sure that there's financial allocation in the things that are included in the policies. It might start from a very small amount of money, but at least it will walk us the journey towards the full implementation. And we hope that counties are able to adapt this, but at national level, which has the responsibility for policy formulation, they are able to link closely the policy process all the way to the finances that are attached to it. The other thing that I want to mention very quickly, and I hope that, as government, we are going to take the topic of genomics really, really seriously. Because we know that right now every continent is speaking about having some work in Africa. You've heard of Africa, Asia, Africa, US, Africa, UK. We need to have Africa Summit. Because as we speak right now, everybody's planning for themselves with Africa in mind. And one of the biggest places would be this area of genomics. We must take control of our data. Our governments have been caught up in reacting to recurrent costs, and then we forget. I'm not saying they are not in the room, but I hope we have good number of government representatives here who are able to drive this process forward. We can work, the team here, so that governments, African governments, can take this forward. Otherwise, the historical injustices that we have seen around genomics in Africa might repeat themselves, but it will be too far off that we are not able to withdraw and take control of it. Thank you.
Thanks, John Paul.
We'll take two questions online as well as 2 questions from our audience who are downstairs. So the first question online is from Dr. Lorraine Mugambi. In response to genomic profiling and its integration to big data, to whom does this data belong? Does this belong to the patient, the government, or institutions? This must be addressed. That's question 1. Question 2, how supportive are the pharmaceutical giants for implementation of pharmacogenomics? That's from Kamau. And finally, can any panelists comment on the role of the company 54Gene on the prospects for precision medicine in Africa? Thank you. So I'll get 2 questions from our colleagues who are downstairs. If the tech team could put them on. Naomi, if you're there with me. So I think you take those 3 questions, then we'll take the online audience that is downstairs.
Okay. Open house. Anyone wants to take any of the questions?
I think I'll start with the pharma and PGX, or pharmacogenetics, also sometimes known as PGX. So right now, it's a catch-22. When you're selling a drug, you're selling it to everybody. It is known that the perfect candidate for any medication is a Caucasian male between the age of 18 and 35. Why? Because that's where most studies are done. They are the people who are the most subjects of studies. And why? Because they're in college and they're looking for extra money, so they participate in studies. I mean, among other things. So generally, a lot of the meds have to be, should I say, extrapolated? And sometimes we don't do a very good job because we don't have all the data to do that. That's why it's very important what John Paul was saying about having our own genome. Now, there are some companies that are really liking that because then now they can target and sell more. But on the other hand too, and I'm not talking for them, they have not paid me, some of them will worry that their market will shrink because they probably would be products that cannot be sold in Africa because the African genome does not respond to it. And right now, we're just taking them because any drug that is 65% effective is put in the market. The 35, it's not effective too. We have side effects, diarrhea, blah, 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 and other things. So are they for it? I hope they will be, because then they can make products that are targeted to us and to make sure that they are not being deleterious to us, they are being beneficial, and they are not costing us more than they should. So that's about that one. As for the data thing, it's a big issue. We need to really come up with a policy. Again, thinking about tomorrow. What's a policy about how we're going to deal with this data once it comes out? I believe that the patients who contribute should benefit from it. If you contribute towards a study that is going to give genomic information, you should benefit for that, and we should include that in any study that we do.
Maybe I can add into what Lucas is saying as far as especially who the data belongs to. For me, it's the way we take a sample from a patient. Whatever results we get from that sample, the patient has the right to know what it means. So this data, he's the client, he's the customer, needs to be aware. But as far as ownership is concerned, he's also a co-owner of this data when it's utilized. And that's why when we're being a researcher, when we're doing research, we consent that you tell us whether we'll use your data as far as whatever decision comes out of this. Can it be utilized for further research, just in case we found that your sample has this? So in the process also, the data belongs to the country, the government, and that's why I'm saying that, as my colleagues have said, if we are able to put in processes where this data is stored and owned in the country, that will help us a lot. Because what we've done for a while, I know we've been sending samples and many samples for genomics analysis out of the country. And we've lost a whole lot, because you'll send for the sample to be tested just for malaria. But there's a whole lot that can be done for that sample. So if we have platforms here that our samples are processed within, the data is generated within, we have the rights and we know who we are sharing with. Because the moment it's out there, you don't know who has access to it and who's using it. And that's why you find that what comes out, be it treatment, be it the vaccines, be it how cases are managed, we are buying that, despite our samples being used to provide. And there is no benefit or even acknowledgement that that was done using African samples or samples that were collected from somewhere in Kenya. So if governments can put in place servers, I think that's the most important, because genomic data is huge. So we need those databases within, and we need to monitor closely, especially when we put the data out there in the cloud. We don't know whose cloud, who has the right, who has gone in there. So if governments can put those in place and ensure that by the time person B has access, we know. And therefore, if they come up with a product, also our country, our innovators, our people who have generated that are acknowledged adequately, and also we are either buying it at a subsidy. Thank you.
Can I just say quick things around who owns the data? I think at the end of the day, we are property of government. That's why when you are caught almost committing suicide, you are jailed for attempted murder, for wanting to take away a taxpayer's life, right? Yourself. So, but that's whatever I'm coming to is the government must put in strong data governance and management structures. I love what happened during COVID-19, especially for Kenya. Government had the responsibility of developing the system, and they owned the system. And there was a very good working relation between Ministry of Health, ICT, and so. And I think that is the direction we need to take. The private sector, the non-state, and all the other players should support government to own this data and build a very strong system around it. At the end of the day, the buck stops with government, but it is co-owned with the patient, as we said. Thanks.
Maybe to add on to that, John Paul, that I think we, as Africa, really need to create harmonized policies for data sharing. Because I think one of the challenges is that there's so much disparity, what each country does, and then it also inhibits research because of the, some of the data sharing policies. So I think if we can look within Africa to Africa, how can we harmonize and streamline the data sharing policies or data ownership policies, so that not only does it protect the patient's data, but it allows us to share that data in a responsible way to advance research.
One more thing. I think Dr. Matoke just talked about the government spending about 0.8. I think the NRF was supposed to be up to 2% of GDP. So here are my thoughts. I want you to think through this. Whoever finances research, who finances the research? And then the next question is, who owns the collector? Because if you're financed by the researcher, or whoever it is, who owns you? Who the person who's doing the research? If they own you, if they paid you, who owns the data you collect? Is it you or them, right? And then if they own it, what will they do with it? You can't control that because you are just a collector, right? So that's why the 2% of GDP for research is absolutely paramount, so that we control, we run our own research, and we own our own data, and we use our own data. And then we can put whatever it is on it. And that's why companies that come here, we love other companies, I know that. They come and then we collect data, and the data, we see it somewhere else being used for something else, as Dr. Matoke was saying. It has happened, and it's happening. The only way we stop is who owns the collector of that data.
Thank you. I'm not sure how we are doing about it with time-wise, but Damaris, you wanted to say one more point.
I just wanted to add that, courtesy of COVID, we learned that now people have moved from asking for the samples. What they're asking is for data. Or we are providing you this platform. And they're investing heavily as far as storage of that data is concerned. But if you think about it, you're losing a whole lot. So government should step up.
There's one question that has not been answered on precision medicine.
Sure.
I don't know, quickly. But I think the world is moving toward precision medicine, all through for cancers and all the other health conditions. It is very important, and that's why this topic is really top of the game right now. On point, of course, we are late, but at least we can do something today and not wait for tomorrow. So as we are moving towards genomics, genomics should get us towards precision medicine, where when you are able, when you get treatment, it's treatment that you are 100% sure is going to treat you, the condition you're suffering from, and it's not shooting in the dark. It is an important thing. We are glad Gene 54 is doing it from Nigeria. We are hoping other African governments or governments can do this, or private sector players with governments can do this, but from a harmonized point of view, so that we can maximize on the efficiencies that this comes with within the African continent. Thank you.
And I think to add to that is, I talked about somebody who's very close to me who went through care using precision. That's precision medicine. That's what it means, where you get what works for you, and it works for you, not just what works for 10,000 people, but what works for you as an individual. And that's why your genome is very important, to make sure we target therapies to you.
Thank you so much. So we'll have one question from the audience downstairs, then we'll wrap it up, and I'll have one question from online, which is, generating evidence and presenting it to the ministry is great, but as mentioned earlier, much of the implementation is politically driven. As a point of reflection, how aligned is this topic of genomics, precision medicine aligned to the Kenya Kwanza health agenda? Give Kenya Kwanza's focus on PHC. What are the potential points of synergy? So we can get a question from the audience downstairs.
Okay. Good afternoon. My name is Samantha Ware. I'm part of the group that have been shunned downstairs for not being early birds. My question is really about improving efficiencies on the health expenditure side. How do we manage the health-seeking habits that we have? Like during COVID, we saw private insurers making money because people are not going to hospital for coughs and colds, right? So we spend a lot of money on people who are not really sick, right? We know colds don't have cures, it's just managing symptoms. So as we go towards UHC, how do we improve kind of the efficiency spent on the spending side with regard to that? And in the same line of thought, what do we need to be prioritizing when it comes to preventative care from a genomics point of view?
Sure. Thanks. I think
Yes,
John
we
Paul
take
will
those two.
take the first question, and then
Next question.
Carry on, John Paul.
My name is Makambito. I'm a researcher, and I'll start my question by giving a famous quote from one of the most foremost African leaders, Julius Nyerere, who made a quote saying that for Africa to catch up with the West, they must run when the West is walking. And which was answered by a Times magazine reporter who said that Africa is talking about running to catch up with the West, while they have not even known the basic, because before you run, you have to crawl, then walk, then run. You have not even known how to crawl. And this is my question. My question comes like this. Digital cards has nowadays become compulsory in most of the developing countries and the developed world, because it's easy to track the medical issues. Most of this diagnosis happen because somebody goes to a doctor diagnoses the wrong thing. This person has been suffering from a specific problem for quite a long time, and before it's discovered, it's too late. What is the government doing as a policy to make sure that digital actually health records is made compulsory, so that it's very easy to track somebody's health behavior or issues from the time they started having these problems? That's my question.
Thanks. I think we'll respond to those ones. Maybe John Paul, you want to go first on the first question, and then we'll take the other two.
I think I'll just go with the first.
Sure, just the first. Yeah.
And I think the thing was around generating evidence and how these would align with the Kenya Kwanza manifesto. I think let's talk about the manifesto as it was, during the campaign. There's one key strong thing that was there called universal health coverage. So by definition, universal health coverage would be making sure that everybody has the highest quality of care without catastrophic expenditures, right? So when we unpack what is quality of care, the first thing I mentioned was safety, right? And safety is very important. When we are talking about the cost drivers of healthcare, it's not the doctor's fee, it's the cost of medicine. And if you get the wrong medication, it means you will keep on spending on different medicine. And that means that if you are paying out of pocket, that is the catastrophic health expense. So you might not see genomics there. But if we as a country needs to reduce the cost of care, cost of receiving that care, that is manageable by government, by us, out of pocket, because so far I think about 32% of the cost of care is out of pocket. Universal health coverage must consider issues like precision medicine. And why it is important? Because at the end of the day, it has a direct implication on your treatment, the quality. It has a direct implication and impact on the safety. It has a direct impact on your pocket, because you're going to get medicine that treats you on the go. If it is 5 days of treatment, you'll be good, even if it's on rehabilitative measures. But at least you're going to be treated. So when we ask ourselves, where do we see this topic in the manifesto? It is deep inside the UHC as we unpack UHC. So as the team is working on UHC and looking at how do we implement UHC in the country, this is a deep topic that must be put in there. Thank you.
Dr. Nyabero, do you want to attempt the one on walking and crawling? Now that you've worked in both places, here and the West. So.
Yeah. I worry about that. I worry about, again, as I said, we have to think about tomorrow. When we work, and also responsibility. I think at the end of the day, pushing or shoving responsibility to the government to manage my health is a wrong way to go. And that's just me. So your political persuasions, whatever the story is, I personally think it's wrong. I think what the place of government there is probably using data to suggest what you need to do as a person, because the government won't feel pain. You're the one who's going to be in pain. So you're the one to take care of that. You're the shoe wearer, and you know where it pinches. If you think a couple beers are good for you and Tylenol, you'll lose your liver, which is okay if you choose that. We as a country should not be carrying your weight because you made a choice. Now, I know that is radical, what I just said. Let me put it this way. The responsibility of what we do from the data we've been talking about, from the genomics we're talking about, from the malfeasance and fraud we were talking about at NHIF, we need to think about tomorrow as a people to make sure that whatever we do today does not negatively affect us tomorrow. That is from health, from doing fraudulent things, from doing silly politics, from not following the policies that have been put in place to help us live as a people. So I think we need to also think about ourselves instead of looking at the government all the time.
I think I can respond to the one for health-seeking behavior, and as far as genomics is concerned, borrowing from a case scenario where we were addressing one of the NTDs in our rural settings in East Pokot, West Pokot, where they were not even aware about the disease known as leishmaniasis. I think we realized that making the public aware of occurrence of the disease being there and the effect it has is extremely important. So for me, awareness is important, sensitizing both the community, the professionals, our policymakers, and making everyone aware. If we remember when HIV came on board, we used to see even adverts talking about how to prevent, how if you're sick, what to do. Same as COVID, how to wash your hands, etc. So even for genomics, it is important to create awareness, what it means when we are doing genetic profiling, and all genetically you're predisposed to this. People need to be informed, both from the community level to the professional policymakers, etc. So awareness, and sensitization is important.
Sure. In the interest of time, I think, Yolanda, you can make your comment as well as closing remarks.
Okay. No, thank you. I just wanted to comment on the question around Africa crawling before, wanting to run before they can crawl. And I think the problem is that we don't create sustainable investments in Africa. And there are so many Africans that are actually running in the West instead of running at home. That's why we're always going to be crawling, because there's a huge brain drain. People, experts, scientists that go abroad to go and do amazing things, because Africa cannot accommodate what they need to do. They cannot accommodate their creativity, their innovations, because we just don't have the infrastructure. So I think it's really, really important to make sure that we are investing in Africa so that we retain our scientists, we retain our experts, so that we can move from the crawling to the running in Africa, and we don't have to run in the US or in Europe. So thank you so much, everyone. I think this has been a very, very fruitful discussion. We hope that discussions won't stay here, that we are all going to go away and do something about what we've discussed today. So thank you to our panelists, and thank you to our moderator, Dr. Rono. Thank you.
Thanks to all of you as well for sitting with us for the entire period. We thank you so much for your time. And again, to our panelists for making time. And yeah, so hopefully you can walk and crawl out of the stage and then move on.
So before you leave, we normally have a small token of appreciation at Strathmore Business School and KHF. So I'll request Dr. Nyalita to come on stage and give you a small token of appreciation.
Where's the photo?
So a round of applause, ladies and gentlemen, for John Paul.
Thank you very much. Yolanda, we started a journey many months ago. Yolanda has come to fruition, and thank you for all the insights. We look forward to really spelling out the aspects of economics in the country. Thank you so much. Oh, one more. Sorry. Oh, one more. Link between Yolanda, Yusina, and KJ.
Thank you so much. A better round of applause, ladies and gentlemen. Thank you so much for your insightful discussions. And as we progress to the next session, I'd like to appreciate the presence of the First Lady of Kisumu County. So could we wave to the crowd? Thank you so much for having time to join us. So at this point, we are going to the next panel discussion, which we'll be discussing on revenue collection, resource mobilization, just as a follow-up to what we've been discussing. And at this point, I'd like to welcome a gentleman who holds a bachelor's degree in medicine and surgery from University of Nairobi. He's an MBA candidate with over 10 years experience in healthcare industry. He has trained healthcare management and leadership at Massachusetts General Hospital, attended leadership and management training at the University of Washington. He's a member of the Kenya Medical Association and the Kenya Healthcare Federation Financing Committee. In addition, he serves as a board member in various healthcare institutions. He is currently the Chief Operating Officer of HealthStore East Africa and also the Managing Director of Sustainable Health Care Foundation. So a round of applause to Dr. Walter Ombita to take us through the next session.
Right. Thank you very much, and good afternoon, ladies and gentlemen. Thank you for joining us in this forum. I'll be leading us through discussions on resource mobilization with a group with a very interesting panel who I'm just about to introduce on the table, on the floor. So probably I'll start by giving apologies from Dr. Isabella Maina. She had to address a few urgent things that came up. So we will be hearing from the rest of the team that may represent her very ably. So I'll start with Dr. Wangari Ng'ang'a, who's a senior health advisor in the executive office of the president. Welcome, Dr. Wangari. Next, I'll invite Brendan Kwesiga, who is a technical officer in matters related to health financing from the World Health Organization. Welcome, Brendan. Dr. Rispa Walumbe, who's the health policy advisor at AMREF. Welcome, Rispa. And Dr. Elijah Matolo, who's a medical practice manager at UAP Insurance. Welcome, Matolo. So thank you very much, ladies and gentlemen, for accepting to join us in this panel. From the morning presentations and what we've been hearing so far is that resource mobilization generally from within the health sector is a very key angle to look at how to increase access through a universal health coverage policy direction. And probably I'll start with Dr. Wangari, and this is from a policy direction. Where are we in terms of resource mobilization, and what's the direction going forward? Knowing that we have a limited fiscal space, and we're trying to look at not only government resources, but also other non-state resources that we have to our disposal, as well as the informal sector, if we think about also the private sector. So over to you, just from that policy direction.
Thank you, and thank you for asking me first.
because now I can say whatever, right? And I set the tone for the rest of the discussion. Disclaimer number one is that I am the immediate past senior advisor in the Office of the President. There may be a new one sitting in the room and may be wondering if they've gotten fired. You haven't. I am now in transition, so I'm here as Wangari, which means I really can say whatever. I can tell you whatever I think about revenue raising. Wow. So I probably will borrow from the panel that just spoke before. I don't know that there is money in Kenya that is not government's money. It is all, I mean, as long as you have decided it is for health, at least from where I sit, there is a role in government in some which way. If it is raised from the informal sector through some sort of a tax, voluntary or not, it is now government money. Is that what not taxes are? So I think then out-of-pocket money is not really voluntary. At the time at which I am at the health facility and I require to use it and I have to pay it, is that voluntary really? Is it not government money at that point? Or is it still private money? The point I'm making is that it is almost irrelevant whose money it belongs to. From where I sit, I think the role of government is not, it would not be divided by those barriers in which we used to describe revenue raising academically. Point number one. Point number two is beyond revenue raising, which I will speak to, is a very big obligation around efficiency and equity. So what are you doing with what you have? If I make a very big dare here, how much do you think we need for UHC? Anyone, any number? There's no wrong answer. There's also no right one, and that's actually the truth. The truth is there's no right answer, so there's no wrong answer either. How much money do you think we need for UHC? How much do we need? 10 billion. Yes, no? I'm going with polls now since people are afraid. 20? Okay, so you know, if you don't answer, I know some of you guys by name. I can ask. 30. Too little, too much. Give me a clue. Too little. 100? Too much. 50. 50% of GDP. Wow. Okay, so what's GDP? So that we're taking 50% of that? So now, if the people in this room don't know how much we need, what are our chances of raising enough? Okay, let's assume that we need 50 billion. Let's make it generous. Let's assume we need 100 billion. How much was out-of-pocket expenditure last year? How much is that? That 2% of what? Yeah, and how much was that? So you think out-of-pocket was 320 billion, or you think the total was 320 billion? The total or out-of-pocket? Was about 320? So it was actually 118 out-of-pocket expenditure, and that is what I can see. I've not counted so much of what we spend over the counter. 118 billion Kenya shillings. That's about $1 billion. Is that enough? If I put all that money in Kamunyo's NHIF pocket, we're okay. Okay, I'm getting no answer, so I think I'll pass the mic. The point is it really is complicated. It goes way beyond revenue raising, and I dare say that the money is probably already here. We just need to figure out how to move it from the wrong pools, so to speak. 118 billion in an out-of-pocket pool is the most inefficient, it's the most unequitable we will get. How much money was donor money? By the way, Brendan knows all these answers, and he's just keeping quiet. How much was donor money? On budget. Let's not speak about off budget. First Lady Kisumu, how much? No idea. How much? I hear. Okay. Let's assume it was 100 billion. It was on budget. Off budget is expected to be about the same. How much was government money? This is a health financing conference. Oh, it's because of the genomics conversation. We are lost. Where is Frank? I thought Frank teaches health financing. So we anticipate total expenditure on health as our most recent additions is about 450 billion Kenya shillings. That's government money, that's donor money, that's out of pocket, that's insurance. Now, because one of my very good friends on the end of this panel is from insurance, let me ask the most volatile question so that I'm not given the mic again. How much is, this one you must know, how much is in NHIF? How much? I've had the right answer somewhere. 60, right about there. How much is in private health insurance? 2% is the people. How much money? How much? 40 is not correct. A little further up. And how many people are covered by NHIF? And how many people are covered by private? Now, since I will not be allowed to speak again, the point I wanted to make is that there is actually no magic number, and there is such a paper. It's called There Is No Magic Number. It was done by the WHO team in Geneva. Google it, please read it. All these numbers we quote, 15% of GDP, of total health expenditure, I don't know, 5% of, all those are just guidelines, not instructions. There's actually no magic number. And I have learned from Prof. Edwin, apparently you guys were given homework. Please come back and tell me how 450 billion is not enough. Thank you.
Thank you very much for those insightful comments, Wangari. And probably then I'll move to Brandon, now that you have given him the floor to answer a couple of those questions. And probably just to even further go down and say, so generally there's all these resources. But I think that, as you mentioned, it's available, but it's also an issue of how it's probably allocated, right? And I think there'll be further discussions around allocation. But just probably from your perspectives, Brandon, look at how is this resource mobilized so that we are beginning to see how it's flowing and its allocation. Starting to tease out some of these inefficiencies which we've been discussing even earlier. So over to you.
Thanks very much, and I think it's good to have another panel of omics, which is not genomics. So the transition didn't look obvious, but I think there's some transition. So I was scared when she started because I thought she was going to hand over something difficult. And it's very difficult, but I think the positive is that I won't be asking questions. Hopefully I create a line for you to ask the questions to the panel here. So just picking up from Wangari, so to me the way I would frame it is that what matters is not the how much, the quantity. I think the framing is for countries to progress towards UHC. It is more of how much of that big quantity is government money. And I think as Wangari was asking the questions, we are moving towards that direction. So if NHIF is our vehicle to expanding coverage, how much is there? And how does that compare with what is probably in the private sector compared to the number of what is covering? So I think picking up from where she handed over to me, so that it's important to know that the money probably is there, but then the emphasis on how much is public money. Of course, with the disclaimer that she said almost all money is public. So, although adequacy is important, we are talking about the adequacy of public money because that's probably where we have the leverage to control in terms of ensuring UHC. Now, emphasis, and I think that's where you handed over to me, there's also an important discussion beyond the money. So, other than having the money there, so what are the key issues? And I was taking some of the notes as you discussed, so probably I'm re-emphasizing what you said. So how is the money collected? So the equity bit is how much is out of pocket compared to prepayment, both through mandatory tax and probably other insurance mechanisms. And importantly for Kenya, how sustainable, both in terms of source, but also in terms of flows. And I think a bigger part of the discussion, because there's a disclaimer about the composition of this funnel. We are not, as the health sector, we are not really responsible for collecting money. We are supposed to receive the money and use it well, ideally. But I think other colleagues will talk to that. So, but important to Kenya so is the sustainability of the collection, but also ensuring that the flow to the place where it's supposed to be used. So, meaning we moved from is the money enough or not to how is the money being collected, how is it being used. So the flow, then also the predictability. Now the flow and the predictability are what shape that thing called efficiency. You can't be efficient with money you don't have. You can't be efficient with money you don't have control over. So we can't say health sector needs to be more efficient. Like there are some prior factors or variables that you would have to shape before you have the discussion around the efficiency. So I think to just summarize the handover I received, so the money is probably there, and we talked about how much it is, the quantities, the proportions, but probably we need that to be shaped more for the public to have a bigger control through the prepayment. And once we have then the adequacy in terms of public to ensure that the money is flows in the right way, is budgeted and planned for in the right way, and that translates into a more efficient utilization. I think that's the answer I would give to the handed over question.
Okay, thanks, Brendan. And probably just to move it slightly lower, because this is overall at the national level, and counties also have a role in respect to the actual resource mobilization. And I'll probably start off with you and move it on across the panel. What do you see from the county perspectives? And probably as even the counties are trying to struggle in various ways, because again, there's a lack of equity when you look at all the counties. What do you see on the resource mobilization front at the county level? And then probably I'll ask Crispa to pick up from there.
Thanks very much, and thanks for creating the transition again. So the sources Dr. Wangari was talking about, because in Kenya, health is devolved, so the actual service delivery is at the county. So the sources at macro level also translate to the counties. But maybe just to emphasize why it is important in the context of Kenya to answer the question you've asked in the right way is there's a lot of autonomy or decision-making autonomy at the county level to shape how money can be used. So in terms of the sources we have at county, of course, you know the equitable share as the most important source. And being the most important source, the counties decide how it is used across all the other demanding entities. And for those of you who have interacted with the county budget analysis, you all see that health is a significant beneficiary of the equitable share. But also conditional grants, and I know there's been changes in the architecture in terms of conditional grants, especially with now the government-funded conditional grants being lumped up in the equitable share, meaning the decision space around equitable share becomes more important for counties to try as much as possible to allocate more of what they're receiving from the center to health. But now, an important source at the county level, and I think linked to better financing of the service delivery, is the role of on-source revenue. So for the monies that are being generated within the facility, how are they collected and managed, and who decides on how to use them? I think although we may not have immediate flexibility in increasing the flows, there's opportunity for counties to get more from the money they generate themselves if they increase the decision-making autonomy around those monies at the facility level. So to summarize the very many words, the source, in terms of the discussion around the source, doesn't change much, but what changes and what is important at the county level is the shaping of the decision making around the flows. So for the equitable share, probably would think there's still an important role for health to benefit more. Of course, emphasizing all the inefficiencies and some of the challenges happening, which we can fix as actors within the health sector. But then another important aspect is now the decision space around the own source generated within the facilities and how it can be used better. I think that's some of the leverage that counties have, at least within the monies that are available now. But you created the transition for someone who will answer the question better. So over to you, Rispa.
Over to you, Rispa.
So thank you for giving me a very difficult question. And it's always difficult actually to talk after these two because, you know, they actually said what, you know how they say, they said what I wanted to say. But let me try and say something a little bit different. And I think the first thing I'll actually critique when it comes to the health sector is how comprehensive would we say is, like, for instance, the composition of this panel, right? When you look at funding, anything to do with money, within any country, there is an institution responsible for, you know, public coffers, right? That's actually, like in our case, it's Treasury, you know, or Ministry of Finance in other, you know, contexts. So I think one of the biggest challenges we've had, especially, I think you mentioned that, you know, there's a limited fiscal space, but I would even hedge on saying that and say, I think the way we discuss budgets, you know, in Treasury is very different from how we discuss budgets within the Ministry of Health or within the health sector. And you look at part of what we do, and one of the things is that, as they've said, equity is a big thing for the health sector, right? It's a very big priority. But when you have 118 billion coming from out-of-pocket payments, one, that's inequitable, but also it's inefficient, right? And one of the things that's a big challenge with that is that how do you track the effectiveness of that financing when even the initial financing that you're supposed to receive as a healthcare facility is either delayed, or when it does arrive, it arrives when it's less than what you expected. And you are also faced with the double challenge of it comes late, but you're measured against the parameters that were set on a timeline that you cannot operate within, right? So when we talk about inefficiencies within the health sector, I think we have to couple it with the fact that the health sector does not operate in a vacuum. It operates within an entire structure, an entire government system, right? So at what point do we also stop talking to ourselves alone, because we often do that quite often? How do we bridge that barrier? How do we bridge across that barrier so that you're having more effective conversations? Because another challenge that the health sector has is also packaging information in a way that is relatable for people in the Ministry of Finance or in Treasury. If I give you certain indicators, a lot of the outcomes that we expect within health are not immediate, they're long-term, right? Well, let's talk about the fact that health is an investment and all these nice things we say in other panels similar to this. But how do you package this for somebody within Treasury, right? Now, part of like the work that we do as AMREF is actually see a link between, for instance, at the global level for the G20 Ministers of Health and Ministers of Finance, because one of the things that they've identified at that level is that often these two ministries are so interlinked because you can't. But the Ministry of Finance is actually it's a large ministry. It's an important ministry. If you look at the kind of like how they sometimes determine the hierarchy. Ministry of Finance is responsible for that. So how do you bridge this gap? Because when you're making a case or for increased investments or increased resources, you're doing it in the context of the Ministry of Finance. And how do you package information in a way that's more effective? So that's something that even as a technocrat myself, I know I fail at, right? Because it's easy for me to tell somebody within the health sector, I mean, you should invest in primary healthcare. The long-term investment is really good, but it's not an attractive investment. It's not, something you'll see within infrastructure, where people will now, reduce their commute time and reduce expenses and all of these things. So what exactly can we do in this room if there's nothing else we do, package information in a way that is really making a case for healthcare as an investment, right? And I'm sure there's a lot of evidence of how this has been done in the past. And I think there's also a difference between packaging this for short-term, like investments, but also long-term and medium-term. Then I think for the other thing, I completely agree that there are already resources within the sector. It's just that because of their use being so inefficient, it automatically results in inequity, right? But in addition to it being inefficient, it also increases the amount of money we are spending on managing that inefficiency, right? So even with the money we have, even for those of us in this room, we couldn't actually say how much is useful, how much do we actually need? Have we quantified that? And if we cannot answer that question, how are you having a deliberation with the Ministry of Finance to justify that you even want, let's even go back to that 15% of the Abuja declaration, that we said in the Abuja declaration. How do you justify that effectively? When even with the resources that you do have, they're not actually reaching the people that need it. So that's something that I would say as kind of like a fire starter for us to just discuss. If there's nothing else we do, how do you do that? Yeah.
All right, that's quite insightful, and probably good thing Dr. Matolo is in the private sector, and private sector are very good in packaging health investments. So when you look at how resources are packaged from a private sector perspective, one of the comments Dr. Wangari had, questions she had asked was how much was contributed by private sector. It was about 50 billion, where NHIF was about 60 billion. So out of this 50 billion, which is catering for almost about 2% of the population, in your view, how efficient is that for that target population? In your view, do you think we still need more resources, or is it still an efficiency issue? So over to you.
Thanks a lot. So the amount collected by the private health insurers is covering an estimated population of just about 1.5 million. If you compare that with what NHIF is collecting, then it's at least 4 to 5 times more. Would you say the money is being spent efficiently? I think the answer is no, but it's always because there's always room for you to make gains in the efficiency. So if you look at what private health insurers are paying for and what NHIF is paying for, will look quite different. So NHIF has, as much as they are paying for primary care, when it comes to more specialized care, they've decided to focus on the conditions that would lead to catastrophic healthcare expenditure. So, cancer, things like, kidney disease and the like. On this other side, on the private health insurers, what we tend to spend the most for is actually on, what would otherwise be considered to be primary care. So respiratory tract infections and, what we'll call maternity-related expenditure. So it's probably very different from what anyone would say, this is where the most money should be going to. And it's a question of, what then now determines how much should be used. And it's a simple question. If you walk into a hospital, you have a cold, how much do you think should be spent? Yeah, and part of it is because of the current provider payment mechanisms being used, you'll find the service provider will be incentivized to provide more services. So be it, as many medications or sometimes investigations, and they're not really doing wrong. They're being paid to do that. I think we usually want to do the jobs you are being paid well for. So you are rewarded if you provide more services. How do we then align the incentives to ensure then that the funds that are there are actually being used in the best way possible. Yeah, so there's a significant room for efficiency, and it's just to look at, not look at what private sector is doing. It's really looking at the health sector as a whole. We don't have, there's no, the dichotomy of, this is private, this is public, this is faith-based. It doesn't serve any purpose when it comes to what you consider to be the function of the healthcare system. It should be to improve the health of the population. And the population is all 50 million of us Kenyans. So who owns the facility should not really be a consideration. So how all these, the various arms, the private, the faith-based, and the public, will be looking at financing very, very differently. The public sector will be relying heavily on what comes in as a county budget for health. But then now on the private sector, there's a huge reliance on insurers, be it the public health insurer or even the private health insurer. So I believe there's room for us to really look at health and health financing as a whole and try and see how do we make sure then that there's efficiency across the entire chain. So if you're talking about, the private health insurers spending maybe 5 times more than what NHIF will be spending per capita, does it result in a 5 times improvement in health? Thank you.
Right, thanks, and I think that's a very good point you've left us with. And Wangari, that was not the last question to you. So picking up from where the discussion is, and if you're thinking about getting more health out of the resources we have, what do you think we need to do? Because again, you've put it out that there is enough resource or close to enough resource. What then do we need to do to start getting more health for the money that we have, instead of necessarily driving towards more money for equally more health?
Thanks. Dr. Matolo has said my parting shot, and it's probably not fun to be in an audience where people already are, kind of repeating themselves. But I think if there is that one takeaway, which every panel will tell you, but my takeaway is what the function, not just of a health system, but of a health financing system. The function of a health financing system is not to reduce cost. The function, there's someone taking notes. Hey, this is good to have a panel in a school. The function of a health financing system is not to reduce cost. It is not to make healthcare cheaper, affordable, whichever other word you want to use. That is not the function. The function is to improve health. If you're not improving health, I don't care how much money you spend. I don't care how much money you spend if everyone is dead. It's an unfortunate statement to make that crudely, but it is a fact. So you must always ask yourself what you're purchasing. I am purchasing dialysis services for 5,000 people. How many are alive? How many have worse kidney function? How many have worse dialysis? That is the metric. I'm not just saving. I don't just want your family not to be poor after you die. I actually don't want you to die. We're financing 10,000 cancer patients. 50% die. We're not doing the right thing. The function of a health financing system is to improve health.
whichever. And I love that question that Dr. Matolo has asked at the end, and I don't even want us to get into comparing what the public money or the private money is buying in terms of health outcomes, because I think it would be appalling on either end. But to me, it is extremely unacceptable that I cannot walk into a private hospital and they tell me how many women died yesterday delivering. And I can get that answer in Kenyatta, I can get that answer in Pumwani, I can get that answer in Russia, I can get that answer in Murang'a County Referral Hospital. I know how many died, I know how many had PPH, I know how many had PET. I can't get that answer in a private hospital. It is not unacceptable, especially when I'm paying 4 times more. If we take those ratios literally. That doesn't mean that we are not paying for death on the public side. And I think the point is made. How do we increase efficiency? I'll take a walk. Again, allow me to use Okaka. I've seen Okaka. Allow me to use Okaka and Joanne. Help me answer these questions as a young medical officer, because the two of you were once. Wherever you were posted after your internship, I have presented, I am the patient. I have presented in your facility, having visited a private facility nearby. I was feeling unwell, and they checked my HB. HB is hemoglobin level, how much blood you have in summary, and it is 2. 2 is bad. And I have come to you, Okaka. What is the first thing you will do with my result? You will examine, you'll do all those good things that an MO does, but will you believe the result I have brought you? So you shall repeat. And then you shall refer me to, then you repeat yours and it's 2. And you say, hey, hiyo ni mbaya. And you refer me to Joanne. Joanne is in the level 4. Joanne, I have come. Now I have 2 HBs that are 2. Do you believe? You don't. So you'll do what? Repeat. That's the 3rd one. And we're just assuming over here we're only doing HBs, which is impossible, but let's just do HB. And then you'll refer me to Russia. And let's assume Mama Lupita is in Russia. And I have brought you now 3 tests. One from the private, one from Okaka, one from Joanne. Do you believe? 2 is still, all those labs could be fake, right? So you repeat. That's the 4th one. And it's still not good, so now I'm sent to MTRH. Who wants to be the MTRH doctor? Are you seeing where my 118 billion from out of pocket came? This is the reality of so many of our patients. So many of our patients. And I am guilty. In fact, when you come to Kenyatta, what do you used to do? You throw all of them away. Don't believe any of these things from... I think we only used to believe a few labs, and I am, for being that we're in a private sector entity, I'm sure I'm not allowed to name them, right? We only used to believe a few labs. You just throw all of them out of the window and repeat. And unfortunately, there is grounds for not believing them. I'm not saying that those labs are credible. But to me, some of the efficiency conversations we need to start considering about making those things go a long way. To me, that's where we should be thinking about. How can we unify some of these systems? It shouldn't matter where the HB was done, because someone at the back end has spent so much more time making that process credible, in whichever way you want to call it credible, that a HB is a HB is a HB. And that HB, if it said 2 in that private entity, then it is truly 2. And the only reason I'm repeating it is because it's been 3 months or I have transfused, for a genuine medical reason. So there you are, trying to decide whether 500 bob is enough or 6,000 or however much. Maybe the hustlers can't afford 500, maybe less. It is irrelevant as long as I have to do 5 HBs before I get to the national, and my HB is still 2, by the way. All this time, all of you, maybe now it's even 1. You guys have just been poking. The efficiency conversation goes way beyond. Way beyond, oh, it was KRA that raised the money and not NHIF. Oh, it was the premium for... Those are, to me, escapist details. The work is really far far beyond that. I'll ask you another question. There is a famous road. Let's use the one that has less political battles. Thika Road, I think we are fine with it. Or Dongo Kundu. How many know where Dongo Kundu is? How many know that there is a fantastic road there? How many have been to Dongo Kundu? Okay, 1, 2, 3. Except the 3 of you, do the rest of you know that you built that road? Yes? No? Some people think no. How many think no? You didn't build it. Do you hold a Kenyan ID? Do you pay taxes? You built it. You don't know if you pay taxes. Let's not put you on the spot. So the point I was making here is as long as you're a taxpayer, you built that road. Because money was taken out of your pay slip or from the bread you bought or from whatever, however taxes were collected from you, then the government made a decision to build the road in Dongo Kundu. And whether you shall die before you ever use it, you built it. Right? The same can be said of Thika Road. The same can be said about the highway between Kisumu and Kakamega, the one between Kitale and Turkana. I'm avoiding the ones that might be political hot potatoes. But yes, even that one that has been mentioned there, the one from Westlands to the airport, all those have been built by you. For those who have used that one, between Westlands and the airport, whichever point you entered from, at that point, were you asked for a payslip? Over there where it's written MTC or ETC, is there a queue for payslip? Is there a queue for tax return? Is there a queue for KRA PIN? How come? How come? But at the hospital, in Okaka's hospital, in Joanne's hospital, in Russia, you want what to see first? One of two things. NHIF or? So let's assume Liza's salary is 1 million shillings. It's probably more, but let's assume for the purpose of this conversation. Let's assume, I didn't say 1 million, it could be 1 million in 10 years. Anyway, 1 million. Let's assume Liza's salary is 1 million. Let's assume mine is 1,000. Let's assume Brendan's is 10,000. When we get to the expressway, how many lanes can Liza use? She can't use 2. She spend more. And me? How comes? My contribution to that expressway is probably 0.0001 of a cent. How comes I can still use a full lane? I hope this analogy is making sense in reference to equity. This is what I'm trying to describe to you. I don't understand why we are so obsessed in collecting money only from Liza so that only Liza can use it in the hospital. Until the day we shall accept conceptually that there is actually no difference between Thwake Dam, Lake Turkana Wind Project, Expressway, and NHIF. Until that day, we'll be here asking ourselves innovative financing. Which one did you say? Until that day. Until that day. Until the day you show me that on Thika Road, I was a student when it was built. I was here in med school. So therefore, my contribution was only the bread I bought in the canteen. Bread that time used to be 50 bob, so tax was 8 bob. That was my contribution to Thika Road. Now I use all lanes. I move to the left, I use to the right, and I use it daily. Daily. And we laugh here, but there are people who have been born and died and have never used Thika Road, but they paid for it. But that is conceptually okay. But when I pay, or I tell you, my friend, that you have to pay for insurance so that Liza can use, no. It is socialist. That's what the Americans told me. How can you be socialist? Until that day. That is the efficiency conversation. The efficiency of how we are spending resources at the facility level, and that's why I gave you the example of that patient, but also the efficiency of how we are deciding to allocate that money. Until the day we shall make the decision that there is no difference between Lake Turkana Wind Project, Thwake Dam, Expressway, and NHIF, or whatever you may wish to call it at that time. maybe the last point, because I made it as a joke, and perhaps that health advisor is in this room, or has the space to be in those years. The presidencies, the office, not the people, who have managed to advance UHC are many, but to make that big leap from like a 20% coverage of whatever package you agree to a big, a massive improvement, 70% jump, 80% jump. I'll talk about Thailand, I'll talk about India, and I'll talk about Indonesia. Jokowi, Modi, who was the Thailand one? I forget his name, 2001, he's left now. They all did it in the first year. Today, Jokowi is the Indonesian Prime Minister. Today is when he's talking about renewable energy, battery, climate change. Today, his term is ending in 2024. 2014, when he came in, is when he did his UHC big bang, big jump. 200 and something million people covered. Prime Minister Modi, he did the Ayushman Bharat when? Now is when you're hearing about the Indian currency being stronger than the, it's no longer on the watch list of the UK government. Now, but when did he come in? 2015. You can only do it now. You won't do it 5 years into your regime. All those needs are pressing. The same people are hungry, the same people need to go to school, those same people. If you don't do it now, the window is gone. So you have 10 months. You've had 2 months. You have 10 months to go. You do it this year or it's gone. And it is possible. We've just said we have the money and we have examples. It is possible. You just literally close your eyes and do it. Then you leave us the problem of fixing it for the rest of our lives. When was the NHS started? What is the NHS? Oh, okay. When was the NHS started? After the Second World War, 1947. When they had nothing. They had nothing, they had no money. And since 1947 up to now, is the NHS not on every Prime Minister's speech? That is the biggest success. If NHF is just continuously in every presidential campaign, then you've given us work for 70 years. All you do from that time is just keep course correcting. Oh, it is not equitable. Oh, you forgot ear, what do you call, cochlear implants. Oh, then the next time you forgot actually breast augmentation is mental health, so it's not a want, it's a need. That is what you do from when it is declared for 70 years. But if you don't declare, waiting to get things right first, I've hogged the mic.
And I was about to cut you off. I know you can talk till the cox comes. I will try to, but I think this is the point I can open it up to the plenary. And
so,
yes, I see my good friend.
So we'll start with one question online, one question for the audience downstairs, and one question from the audience here. So we'll start with the online audience. We keep talking about resource mobilization for UHC in the room. In the room, we have many policymakers who have gone for benchmarking in several developing countries where resources have been mobilized. But what is the outcome of such benchmarking? We will continue lamenting, but we have sat on policy implementation and execution. We continue subjecting the Kenyan people to substandard health services through misapplication of resources. The counties are allocated to a lot of resources, but they apply to resources to floated wage bills. So I'd like to get one question from the audience downstairs if they're ready.
My name is Michael Manguza Gitambo. I work in the pharmaceutical industry as a market access leader. I would wish to make some comments or remarks, and the remarks I make are my own. I'm an alumni of this institution. Maybe directly to Wangari. Given the analogies you've given, what language, and qualifying it further, there's a lot of work that has gone into health financing, establishing what are the costs of care, what packages are affordable. And I think time is up in terms of analysis paralysis. How much can we finance? What is the fiscal space what are the benefits package that can be put in the universal health benefits. So I think that ship has sort of sailed, and that is done. And if we run the risk of going back in a tunnel and being in analysis paralysis as a country, trying to establish the how on the UHC. I think it is time to get going on the UHC. If it is NHIF that we've established nationally as the vehicle through which we finance, so be it. What is the language in your wisdom, collective wisdom, and there's lots of people in the audience and online that are experts on this. What language do we use to harmonize the thinking and the work that has previously gone over the last 5 to 7 years on UHC funding and financing, and then building it across the political transition to see it through to light, because we really need to get to implementation of UHC. Enough with the talk shops, enough with the task forces and work, how, and you having worked in the political space, what is the language that needs to be spoken out of audiences like this? My submission. Is that questions?
So I think there's one question here.
Thank you. Big thank you to our panelists for a lovely discussion. My name is Dr. Dennis Ogola. I'm the course lead for the Managing Health Businesses program here at Strathmore. I also do some independent consultancy work. Prior to that, I was in the private healthcare delivery space, leading one of the private hospital groups in the country. Now, I have two questions. One is, really, we are saying that, yes, there are a lot of inefficiencies in health, and we are agreed on that. But can we really say that we have enough money in healthcare? Because we know that per capita spend on healthcare is just about $90. And if we compare that to countries like we've talked about the UK, they are spending significantly more, 7, 8, 9 times that. So if we just look at how much we are spending in healthcare per person per year, can we really honestly say that there is enough money in healthcare? Not to say that there are no inefficiencies. We have to correct the inefficiencies. But I'm not convinced that we have enough money that we are putting in healthcare. My second question actually goes more to Dr. Matolo. And you talked about the compensation systems. And yes, we are in an environment where we focus on volume-based compensation. So when you go and see the doctor, then the hospital is being reimbursed by how many tablets you're given, how many lab tests are done. And maybe, are we moving the conversation towards value-based compensation, where basically the outcomes trump the volume? So if you're dependent on how you perform, then the hospitals get reimbursed for that particular purpose. Thank you.
I see many hands going up. If you will allow for us to have a slightly shorter lunch to take just a few more questions, if that's okay with the panel, with the participants. That's okay? I see people nodding. Okay. So could you take that first round of questions, and then probably we'll do just one more round. If Wangari will start, just take a few minutes.
If Wangari starts, she won't finish. So I volunteered to do the last question, a bit of the last question, then we'll move the mic around.
Okay.
I think is the money enough? So, because that's, I think, part of the framing Wangari started from, what is enough? So, usually most of our framing of the health financing discussion is around how do we pay for the service. And if you compare the per capita spend, so you mentioned 90, it's around 100. If you compare Kenya with most of the lower middle income countries within the African region, we are comparably high, I could say. So we are, but as we said, there's no magic number. So the magic number, so the money enough would be trying to link with what are you actually trying to buy. Because if the money I have in the pocket can definitely buy me lunch, but for the type of lunch I want, if I have to elevate the type of lunch I want, I have to elevate the money in my pocket. So is the money enough? We are saying for what we are delivering, until we improve what we are delivering, it is a bit tricky to say whether it is enough or not. Now, the enough statement then should be driven by what are we trying to deliver. And I like that we piloted ourselves. So we piloted ourselves on the efficiency part, because within the resource mobilization, revenue collection discussion, as health sector stakeholders, that is the only lever we have. So the lever Wangari was giving about doing so many tests, that's us who can control it. It's not treasury, it's not anyone. So is the money enough? Again, it is us to define a want for which we are targeting to then set what is enough. Now, the other thing which I like that we slightly piloted ourselves on is around payment mechanism and structure of payment, which incidentally is another session. When I was talking to colleagues as we were entering, I was saying the session we are having is actually the most, in this conference, I hope the panel will be useful, but ideally the most useless session when you're discussing financing, because our levers are limited as sector partners, as sector people. So the structure of payment and the shaping of incentives, which I think he also talked about, is a whole separate discussion, and ideally does not increase the money that we have, but then helps us send the right signals for what we want to deliver, which I think he did talk about. So I think that's part of the enough discussion. So the enough discussion is a philosophical one, and philosophical questions have no answers. Now, I also touch a bit around the beyond the analysis and the analysis paralysis. So I was excited by the genomics discussion, despite having zero knowledge of genomics, because in economics we believe in market failures, and you correct market failures by shaping the incentive structure. Now, in another field called law, they don't believe in market failures because they think you can put a law to fix it. Basically, there are no problems, you can put a law to fix it. So beyond analysis, some of the structures is what do we do now? Speak like a government technocrat. There has been now defined financing strategies, meaning there's a defined direction by government. And also there's been legislation around some of those bits, meaning at least however much you move from President Wangari to President Brendan, there's somewhere to start from, meaning you don't have to analyze again. But is that enough? Wangari gave a very good futuristic example around big packages. Now, I happen not to be from Kenya, so I can give a Kenyan-specific example and not be accused of politics. So there's a package called free maternity, or Linda Mama as you call it. So that is a specific service package. And what was done to increase coverage of it, I also think it was done in a simple access for all, as by defining the beneficiary population. So beyond that, we have done a lot of analysis, and even tomorrow you could ask me to do an analysis, but you know the answers. So some of these bits now are simple political decisions for which we hand over, and I know we have some waziris in the room, I think she has stepped out, for which the waziris in the room can now push forward. As I hand over the mic, I want to emphasize something which was said previously, which is not linked to the questions asked. I've skipped one question around benchmarking because I'm not Serikari, so any of the Serikari can pick it. One of the things which Wangari says in so many words, but to link the saying building a road and NHIF should be seen as the same. For the students who like taking notes, is try as much as possible to delink contribution from benefit. So delink contribution from benefit. I think that's the simple message that was making. Now, what does that message contribute to? Again, she said the role of the health system is to improve health outcomes. With a slight correction, it is to improve the level and the distribution of health outcomes. So if you delink contribution from benefit, then all of us can enjoy how we drive on Thika Road, irrespective of the size of the car, irrespective of the speed of the vehicle, because we have delinked our contribution to the way we benefit from the service. So I think I can hand over to, not to Wangari at least for now.
Yes. So, and it's, I'll pick up a little bit from the last thing Brendan said. It's very easy for us in this room. How many of us have received an M-Pesa request from a relative, a friend, a neighbor who requires funding for something. I have. I don't know. Yeah, yeah. Even our brother from next door. It's very easy for us to conceptualize doing a harambe for people. From my community where I'm from, we even do it for people who have left us, right? And we will raise a lot of money for that. But it's so difficult for us to conceptualize me contributing into a system that I may not benefit from, but will benefit my entire community. As a continent, we pride ourselves on being very community-driven. We pride ourselves on, if I need sugar in my house, I can go and ask Brendan, who is my neighbor. But if I tell you today, can you give me money so I make sure that I am paying into, for instance, let's say NHIF, that's very difficult to conceptualize for people. Even for some of my own relatives where I'm like, I might not give you money for a bill, but I'll pay for your NHIF for 1 year. 6,000 for 1 year for your family. But they want, but instead of paying like, let's say 16,000, for instance, for your bill. Now, I don't know, I don't have the answer on how to make this concept more tangible for people, but I think that's something that, as you said, we need to delink contribution from benefit. Because we already do it. We do it for, you know, people who are in need already. But it's very difficult for us to conceptualize it at that level. Especially when you talk to people outside the health sector. When you talk to people outside the health sector, if you tell them, I'm just going to, let's say, increase your contribution a little bit, but I know most of those people actually pay into, let's say, private insurers, right? But when you tell them that, that concept is alien. But at the same time, they'll go for a funeral gathering and contribute triple, double that amount, right? And be comfortable with it. So for the technocrats of us in the room, let's think about what that means and what we value as a system, right? The other thing I wanted to mention is that we're actually, as much as we say, is the money enough? I think we also have to understand the money will never be enough. It'll never be enough, right? One of the things we have to recognize, interventions keep increasing we get better and better at the kind of interventions that we are providing for people, right? We are learning more, we are doing more innovations, and we are learning more about how to deliver care more effectively. We've just had the genomics discussion, right? The cost of delivering on that, we've just talked about, I think it was 2% research and development that you're supposed to contribute as a country. Now let's pause that a little bit. But one of the things you have to understand is that it's very difficult to ensure that you have effectively mobilized resources and you've channeled them towards the right place, right? So I think one of the things that I want to give as a take home is that the money will never be enough, but that's not to say you should not continue increasing it sustainably. We were just told that within the NHS system, I'm sure when they started, it wasn't the amount you see today. It wasn't, right? And we've said that sometimes these numbers will continue to confuse us, and there's no magic number. There's no silver bullet. But the point is to start. And I think, as a country, we have already started. The point is to make sure that you are sustainably increasing this. And you're starting to look at those incentives that Brendan was talking about. What exactly are we paying for? What is within our control as a sector, and how do we present that information within that sector to other sectors? For instance, the Ministry of Finance. Because they will pay for what they see. And if you show them that what you're paying for is tablets and those kinds of things, then that is what you will be reimbursed for, right? But it's a very tricky balance, and I think that's something that's really important. And the final thing I will say is that there's already work that's being done between, for instance, the private sector and the public sector. But how do you make that more refined? Because, again, we do not operate in a vacuum. The same 50 million will access services within the private sector, will access service within the public sector. So how do you make sure that you're operating as a system with a unified goal? That we're all in agreement of what that goal is. So how do you make that linkage between operations within the public sector and operations within the private sector? How do you make sure you're viewing it as one goal? So when I need access to information within the private sector, it's very easy for me to do so. So that efficiency question is actually a cross-cutting question, because the patient or the person receiving the services is essentially the same person.
Thank you very much. Matolo, do you want to add?
Yes, sir. So I wanted to respond to Dr. Gola, but before I do that, one of the things I think we need to acknowledge as a country, and specifically the stakeholders within health, is that everyone deserves to have access to healthcare. We have not, we will say it, we will quote articles in the Constitution, but we still don't really believe it. Yeah, because you'll find a patient goes to hospital and even the doctors will say, I don't think they can afford it. The fact that you say that someone cannot afford it is where we start failing. So when we talk about UHC, and I think we're making progress. Anytime the government spends money for a particular population of vulnerable groups, then we are one step towards that. So UHC is meant to be progressive, so it will happen. The fact that you start the journey today means that you're on your way there, provided you can show progressive improvements in, number one, the number of people who are covered, whichever that kind of cover that will be, the number of services that they are covered for, and how much they are being paid for, so that you also progressively reduce the out-of-pocket expenditure. So that's what we really need to believe. We need to believe that everyone can access, and not just any form of healthcare. We need to accept that everyone should have the best care, so that whether I have an insurance either from NHIF, or I have an enhanced scheme under NHIF, or a private insurance from any of the local insurance companies, or even from the international insurance companies, there is care that should be the same across board. You don't say, this one has NHIF, I'm going to give amoxicillin. This one has private insurance, I will only give Augmentin. We are the same people. Some of these variations do not help with the efficiency that we are discussing. So is there enough money in healthcare? I think that I've already answered that. It's a progressive journey. I think what we have right now is what we should be focused on, making it give us the most improvement in health and health outcomes. So the discussion around reimbursement based on volumes, we know that fee for service doesn't work. It incentivizes over provision of services. So are there discussions around value-based healthcare? I'd say to a very small extent, and part of it will include what people commonly refer to as packages, where you're saying there's a particular payment for the outcome. Let's say a delivery, you're paying a fixed amount and you're basically paying for that specific one. But even more interesting discussions right now are around paying for outcomes. So you have a particular cohort of diabetic patients. Right now the discussions is around, can we pay you as the physician to coordinate a multidisciplinary team with a nutritionist, a diabetic nurse, educator, and a counselor, to make sure that the patient gets all the care that they need to help them. And initial results from some of these, small pilots that are being done by private health insurers is showing that that model actually works well, and everyone seems to be getting more money out of it. The physician gets more money, but the patient also gets much more support. I hope we understand that you can't manage a chronic condition if you're seeing a patient once every 3 months. It will never work. You will come, you'll find the patient is not doing well. You either scold them or you feel sorry for them, but at the end of the day, it won't work. These patients need support almost on a daily basis, so that we get them to the right level. Yeah, so a transition towards that would really help. And it's not just on the private health side, it's supposed to be across board. Yeah, that's how we should be managing patients. We need to know how are they doing, what are the outcomes, and are they actually getting an improvement in their health. Thank you.
Thanks very much for that. So,
unfortunately, we are short on time, so we'll wrap it up because we are really going short of time. So for the questions, you can pick it up when you have the panel discussions. Maybe you can have a final word, moderator, then I bring in the next session.
All right, thanks very much. I think we need to give a round of applause to our very able panel here. Thank you very much. For those of you who have follow-on questions, just because of time, I believe they are going to be around for lunch. And so we can pick up this conversation as we will be having a bite after this. So over to you.
Thank you so much. I'd like to call upon Dr. Ben Ngoe to come and issue a token of appreciation on behalf of Strathmore Business School and the Healthcare Federation. And also he'll guide us on the next steps on the roundtable that we'll have in the afternoon. So karibu Dr. Ngoe. So you also
so the many ones deserve 2 bags or what?
So Dr. Ngoe will highlight a few details on the afternoon session.
All right, so ladies and gentlemen, thank you very much. And I think our moderator, Walter, and the panelists actually do deserve another round of applause, no? Yeah? It's been a very interesting discussion, and we really must apologize for cutting short the questions. We've been monitoring what is happening both, you know, in the various forums, because we have quite a number of people joining us online. We have quite a number of people joining us in the alternate room. And the big issue is you people seated here seem to be favored quite a bit. So if you don't eat your lunch quickly and come and secure your space here, I cannot assure you. Maybe the online guys will have arrived and taken it. Eh? Fair enough. So without further ado, I know it's not good manners to stand between people and their lunch. People tend to become very hostile. What I want to do before inviting you to lunch is just to share a couple of changes. We've had to make some adjustments because of the depth of conversations. Number one is I want to make a commitment on behalf of my panelists and moderators. We were unable to answer all the questions here. But if there's one thing that COVID has taught us is that engagements can continue in other forums as well. So whereas we're able to capture the questions on the ones that have been sent on Zoom, for the ones who are here physically, both here and in Oak Room downstairs, allow me to ask you to still print out these questions. Because the idea of this conference that we're having over the next 2 days is that it is not just a talking shop. We are actually hopeful that we'll be able to come up with solutions. We want to put these solutions in the form of white papers or policy briefs or whatever newfangled name they are given nowadays. And we want to make noise about these things because each and every one of us, I want to believe, is here for the betterment of our health system. So kindly, don't go away with those questions. Leave us with those questions. We will pose them to the right people, and we're going to take advantage of those answers to enrich whatever solution we're going to put out there collectively. Number two is that because of time constraints, we really have to go for lunch now. They have been ready for us. And what that means is that the roundtable discussion that we had scheduled for now, we are seeking your indulgence in combining it with the roundtable for the afternoon. And so what that means is that the roundtable in the afternoon is going to tackle two topics. Revenue collection, which is the conversation that we have just had, and it's also going to be about risk pooling. Now, why is your participation in these roundtables important? It is important because this is where we are going to be co-creating the solutions. This is where we'll be getting the meat that we are going to use to enrich this policy brief. So I really, really want to urge you to come for those. In terms of the operational details, we have 4 working areas. One will be this space here. The other one is going to be, there is a flexi room right next door on this floor. So when you get out here, it is the first room here. There is another one immediately above it. And then for our colleagues who are virtual, they will have a conversation in the virtual format. For those in Oak Room, they will stay as one group. So what does that mean? It means that for those of us here, we are going to split ourselves into 3. So allow me, if you may, to just suggest that maybe those in this, is this a column or a row, or what do you call it? Is a column, wengine wetu tulienda zile shule za nini, where they were counting votes. So this is a column, right? Okay. So if I can ask that maybe from here up to the first, now if you say this is a column, what is 1/3 of a column called? Yeah? Aya, sawa. The ones who went to those schools. So this column and this strip. Can I ask that then we go to this room immediately after lunch? Not immediately after lunch, sorry. Immediately after lunch, we're coming first for a plenary session. And after the plenary session, in terms of breaking out into groups, this is going to be one group. Now, the ones in the column that is on my extreme left, up to the first strip, okay? Then when it comes to the roundtable discussions, we will go to the flexi room up. That leaves these 2 strips here and these 2 here to remain in this sector. We will try to announce this again just after lunch. I know now glucose levels are what they are, so that we can do it right. Please, when you go in there, go as an open book on the one hand, ready to receive, but at the same time also carry your intellect with you, because we really want those answers. Finally, speaking of answers, we are coming back after lunch for a spotlight address by one of my old friends. I don't know where he had disappeared to, but I'm happy to see him here. Professor Wasuna is here. And then afterwards, we're going to have a panel session preceding the roundtables. For the panel session, ladies and gentlemen, because we have to become very efficient, allow me to ask or share with you one definition. For the moderators and the people who will be here, a good question. Those who've heard me say about it, a good question, what are its characteristics? Starts with a capital letter, ends with a question mark, and the distance between the two is extremely short. Okay? Well, if it becomes a paragraph, we get lost. So we don't even know what to answer. So please, as we will be participating in the afternoon, let us try to do that so that we can be very precise with our responses. But similarly, when it comes to answering, since somebody once shared with me that we have an allocated quota of 15,000 words in a day, please don't use all of them answering. For the panelists, we don't want you to be prevented from participating tomorrow. So save some words. So also we make the answers very, very precise. Okay? So once again, thank you very much, and a warm welcome to all of you on behalf of the Institute and the school. And maybe we take it away now to lunch? Sorry, one more announcement for the afternoon panelists and speakers. So Professor Asuna, Mike, Gilbert, I saw Moses coming in just now, right? There you are, okay. Robert, as well as the round table moderators. That is Liza, you're still here, right? Anita, I saw Anita somewhere here. Joanne and Benudrin. So please, Marianne, where are you? Yeah, please, as you are leaving, just identify. Marianne has some information for you that you need to get before you go to lunch. So thank you very much. Over to you.
Thank you so much, Professor Ngoy. So at this point, I'd like to give directions. The meals are served at the second floor of this building. You can either use the left or the right. For those who came late, the washrooms are also towards the left and the right. They keep interchanging as you go. So you go to first floor, to second floor, serve your meals. Then I humbly request you, once you finish, there's a place that will be shown where you'll take the utensils after. So with that, I think we are free to go. We are taking a short lunch. It's 1:45, so we'll be back by 2:15. So let's hurry up and keep the discussion as we continue through the next afternoon. Thank you so much.
As a leader, you need to know how to manage people, and managing people entails you able to take these guys from where they are, lead them to where their organization is going, and be at a position to be able to get the best out of them.
With the program, I was promoted to the head of audit, East Africa role. The other one is the fact that the program has enhanced my ability to manage my team. I'm also now able to have even difficult conversations where necessary. And lastly, there is enhanced delivery of tough messages. My role requires that you deliver very tough messages to the board as well as to the executive management. And sometimes you will have a difference of opinion. So that, for me, is a skill that I acquired when I was going through the program.
I have a team of young, dynamic IT professionals. So managing the team was one of the things that I really learned in terms of keeping them motivated, keeping them engaged, bringing out the best value out of them. I learned about managing projects because it's a key part of what I do, and how to deliver projects within cost, within budget, within timelines. Also, I've learned about the entire process of budgeting and spending within the department.
I have what it takes in terms of skill sets, in terms of thoughts, in terms of insights to be able to manage even 100 people. Why? Because right now I can be able to literally know how to manage an officer and get the best out of him. And one of the key things that I know that we have under major issue with is in terms of performance evaluation. And I think that is one thing that has really changed in our organization, especially in my department. I used to have issues, quarrels with my staff, especially when I'm doing performance evaluation. I mean, since last year, I've done performance evaluation, mid-year evaluation in January. Right now, actually, as we're talking right now, I'm doing the annual performance evaluation, and everybody is happy in our department. Why? Because the approach has changed from, the boss there having a stick and trying to find out if at all you already finished what it is that you guys agreed, into a conversation that is there to help my staff to be able to be and to really understand what they have been able to achieve, what things have not been achieved and why. And then from there, we are able to really draw plans for them to be able to move to the next level.
What we do is project appraisal. And I've been able to go out now, like with these guys now, like to maybe to do the audit, to look at the various businesses that we're supposed to finance. But what I'm finding is not like this, that more at ease and more comfortable, like actually letting people run with the program, and me not like just standing in the background and not like giving them guidelines, not like as to what they need to do.
I would encourage every professional, whether you're a manager or a director, to really think of taking this course, because it will give you the insights, it will give you the practical experience, the practical knowledge on how to be able to become an effective leader. And most important thing, you'll be able to get so many guys to work with in that class in terms of creating networks, and you'll never forget, or never regret that actually went to Solomon University to do a PMD class.
My name is Carol Kinoti, and I'm a fashion designer. I design for the Carol Kinoti brand. I'm also the founder of two initiatives, that is Fashion on the Road Limited and Mavazi Elevate program. The Mavazi Elevate program is an initiative that was founded based on some, the challenges that I faced as a designer over a long period of time. Because at some point I was concerned about why I'm not scaling, why I'm not growing. Why do we all seem to be stuck in the same place as designers? So I listed those challenges and narrowed down to areas of production. And when I talk about production, I'm talking about high costs of production. I'm talking about having to import fabrics, having to deal with tailors that are not disciplined in a certain manner in the field. Therefore, the products that we produce cannot meet, the standards that are required for export. And I realized that to be able to improve on that, then you must train, because that's the only way to elevate. I believe creative in the fashion industry, and I would like to explain what a creative in the fashion industry is. Fashion is not just about the dress. Fashion is about the accessories and, the beauty sector within the fashion industry. All that is the ecosystem of fashion, and together we make the industry. I think that the fashion creatives need to be incubated, so that beyond the knowledge of being a fashion designer, then we are able to teach them, or at least not more able to help us know how to run the business of fashion. So this program is an executive program, and it teaches the designers what their role is in the value chain. It also brings together and pairs us up with other players in the value chain, so that we are able to execute and put together the brands in the right way. They fixed me. So at some point when I didn't know what to do with the fashion business, and I got into the owner manager program and learned how to step aside and look at the business from the outside and work on it. So that 1 year was a game changer in my life. So when I started looking for a knowledge partner, I did not think there was any other better person to fix the problem. I went back to Strathmore and told him, you fixed me, so fix the industry. And together put up the Mavazi Executive Program. This program is eligible to anybody who is a part of the fashion value chain. And what do I mean by that? Are you selling clothes? Are you importing clothes? Are you a fashion designer? Are you selling jewelry? Are you looking to manufacture your own? Do you want to be a fashion brand? Do you want to produce fashion products? You're all eligible to be in this classroom.
My full name is Arifeni Mnene Rao, and I am the Global Talent Acquisition Manager at Dalberg. So that is part of the Global Shared Services team. That's why I have global in my title. But essentially what the Dalberg group does is we are a group of change makers working to build a more inclusive and sustainable world, where all people everywhere can reach their fullest potential. That could be whether you're within the organization or externally as clients and partners that we work with.
We're defining ourselves not just as Dalberg advisors, but as active agents willing to take on risk and actually make things happen with our own hands where our advice is not sufficient.
I like to say I start my day with Asia and I end with America. Unfortunately, I'm not bilingual or multilingual, so everyone who works with me needs to speak in English because that is the only language I speak. But maybe I will grow my repertoire of languages. I get to support a team of close to 600 individuals across the world. I've realized that advancing one career can happen internally within the organization with how you conduct yourself, how you perform the role that you're in, and it can also happen externally with the connections that you build and any additional learnings. One of the things that I realized as I was moving along was it is the best person in their skill set who gets promoted to the leadership role, but we're not all born leaders. A lot of times there may be qualities within us that we need to draw out, or there may even be learnings that we don't have and we need. And I realized that I was so boxed and focused on my career as a HR professional that I wanted to add a lot more knowledge and experience. And that's why I came to Strathmore Business School. So I did 2 courses. I did Women in Leadership, and then I must have loved SBS so much, I came back for Program for Management Development, PMD. I felt a lot more equipped to take certain chances in my career. There are opportunities that came my way that I would never have taken were it not for being exposed to the different facets of learning available. The individuals I have met and I've grown my network, I'm able to say I can call upon person XYZ and I'll be able to get the support or assistance or even just feedback that I may need. And then there are also certain, let's call them in-skill learnings that I got from the program. For example, negotiation. Another thing is accounting. PMD made us do the numbers, and my math was not as good as it should have been, but now it's better. And it has changed the conversations that I'm able to have in the workplace. I no longer view myself as being a one-trick pony, only focused on my core competency area. I'm able to have conversations with different department heads. I'm able to have conversations with different business unit leaders and to speak and understand their language because I've been exposed to these things in the SBS programs. There was a lot. One is the quality of the teaching and the faculty. The individuals who spoke to us were very, very knowledgeable in their areas and in their subject matter, and they were able to teach it exceptionally well. The composition of the classes for women in leadership, being in a room with women across different industries at multiple levels of leadership was something I had not experienced before. At that time, I was working in fintech, and it was a very male-dominated field. So being in a room learning from other women was an exceptional experience that I'm not able to replicate or replace anywhere in my life. With PMD, what I loved was, again, the varied levels of leadership, the varied levels of sectors that were covered. We had individuals who were in manufacturing, we had individuals from telco, we had individuals in NGO, individuals from government, and each of them brought such wonderful experiences that I was able to learn from that I don't think I would have gotten anywhere else. More than a tweet. I mean, we're in such a high dynamic, fluid environment that reading takes time, but I still fall back on Lean In by Sheryl Sandberg. That stood out. A lot of times you would see women in a specific position, or even other individuals in a specific position of authority, and you don't know what it took for them to get there, or even that they had to fight battles to get there. Leadership is not a walk in the park, but it's always good to have your support structures and your allies with you. So Lean In stood out with me because listening to Sheryl and how she was able to navigate the workspace, and she made it more approachable, more real, and was able to share experiences that I am able to draw from. And funny thing is that I was always the note taker at meetings. I was always doing logistics and serving tea, and I realized, wait a minute, there are other things that are more impactful that I could be doing in these meetings. So it's not that that's not a vital role, it's that I don't have to play that role. I hope she's listening. So I hope everyone else will. There are many things. One is the importance of mentors and people who will walk along in the journey. Another thing is understanding that not everyone who's in your court is playing for you, but also not to sweat the small stuff. There are certain things that I had planned and I had said by such an age, this is what I need to do, and I need to do this, and I need to do that. I hadn't thought of the preparation that would be required for that. I hadn't thought of any speed bumps or roadblocks that may come up, but also to realize that everything happens for a reason, and it's to pick up the lessons and to go with them. There's no point going through the lesson if you don't learn it. So not to just sweat the small stuff and to keep the eye on the prize.
The program has been, needless to say, very interesting. I've gained a lot of skill. I've gained a lot of knowledge in terms of policy. I've also come to understand how things work, especially in the public sector. With my MBA knowledge, I knew only the business side without really knowledge on the policy side. Now I have both, and I think I am well skilled to undertake a new assignment. The person who structured the course really, did a good job, because it exposes you all round. You're able to understand why certain things happen the way they happen. Before I did this course, I would read the newspaper and I would take what is written at face value. But after doing this course, when I read the newspaper, I'm able to tell that which is propaganda and that which is news. That is very important. How many Kenyans are able to do that? One of the key skills that I got was in the negotiation class. And I've come to learn that with negotiation, a lot can be achieved. Sometimes it is not about going up straight and saying, this is what I want. One of the courses I think that you undertook was policy analysis. You get to understand how a policy framework is executed, and you're able to follow through to see the outcomes, because the most important thing is to ensure that there are positive outcomes out of the policy agenda that you're undertaking. So as you implement projects, it is not just about implementation, it is also about ensuring that there are outcomes. You are able to see how that project has touched on people's lives, how that project has impacted on the community and the country at large. What I've come to learn is policy shapes everything. Without proper policies, even the businesses will not thrive. So actually the two must go hand in hand. Without good policies or enabling policies, then the businesses will not have a good enabling environment to thrive.
My name is Sarah Karinge. I'm the co-founder and CEO of Summer Holdings Limited. Summer Holdings Limited was co-founded by myself and my late husband, who was Mr. Karinge Masharia. We have a number of companies. One which is called Sarma Guest House, that is a hospitality company. We have another one called Summer Water Suppliers. We have another one which is Bridge House Holdings Limited. This is a real estate company. Then we have this company where we are now seated. This is one of the oldest companies that we have. What do? We manufacture doors. My late husband used to be very particular when it comes to quality of work. We use wood that is dry. We also make sure that we listen to our customers what they want. Then when they come to time of delivery, we are very good. Once we agree with our customer that we are supplying these goods at a given time, to be honest to you, by a day before, that is when those goods are ready. So that customer, of course, when called by my team, and told that, of course, the goods are ready, they get very excited. So what happens? They keep coming back. If it's not that, they bring other customers our way. The last time I had stepped in class was in 1985 when I graduated with a general degree, that is for marketing, from the University of Nairobi. And later on, then I realized it's like I was becoming almost dead in terms of knowledge, in terms of understanding, in terms of running the business and many other things in life. Fortunately, I think there's someone who put up a flyer in a WhatsApp group, and I said I'll go to Strathmore University. So I took the first course in Enterprise Development Program. That was in 2016. Then 3 years later, I joined Owner Manager Program. Oh my goodness. When I went there, I found very serious business people, people who are willing to learn, people who could ask questions, and then you're like, what has this person asked? And for me, I was like, even me, I think I'm going through a similar problem. Actually, one of the things that I can say I have benefited from this program, that is post-OMP, is the fact that my class, which was headed by our president, Major Boke, we have continued interacting with one another, we have continued networking with one another, trying to find out what is happening in our business. And then the other thing is that, and of course that has made us to continue bonding and gelling, and so we have continued supporting each other, especially this time when there was COVID-19. And then the other thing is that the fact that now we went to class and we learned those aspects of business, I'm a person who is very positive. And I said, as an entrepreneur, I don't have to give up, I don't have to slow down, but I have to change the strategy. So I said, though there is this COVID-19, and with whatever I have learned in class, where of course I also have to look at my financial issues, I decided now to check through to see which particular things, of course, whatever we manufacture or we make is bringing more income. And then we started marketing ourselves very, very aggressively. So because of that, we have actually not been feeling the pinch that most companies are feeling, that COVID-19 has come to swallow our businesses. For me, I'm looking at it from a different perspective, and I'm seeing things change. Just because I've been going through the notes and seeing what can I apply that I have gotten from the class. Can I proudly say that I market Strathmore University like I am a partner in that university? I have already mentioned to about, I think there are 10 or 11 people who I have marketed this program to, and I have told them personally what I have benefited from. Besides that, they have even seen the change that has taken place from the time I came to Strathmore OMP program. So for me, OMP is good for business people, and let them not count money, because you see what, money comes later. And besides, if you know how to network when you go for the OMP class, for me I was able to have done, when I joined, I was able to have recovered my 1 million shillings within, I think, the 9 months. Yes. Soon, within, even when we were still doing the program, I was able to get some business from our members, and then also those members of my class also connected me to others.
My name is Eric. I'm the founding CEO for Maridadi Motors. Here at Maridadi Motors, we are interested in 3 things. Number 1 is that we are interested in training people to become competent, safe drivers. People who can drive their cars comfortably on the road without causing accidents. Number 2 is that we are interested in helping our customers to get the best cars at the best prices. This they can get by buying from our showroom, or we can help them to import directly from other parts of the world. We also make finance arrangements to make it easy for our customers to buy their vehicles. We also have an internal circle where our customers can save up for their vehicles and get internal credit for their vehicles. That thing that we're interested in is that we're interested in helping people to invest safely and sustainably in the auto industry. We therefore have an investment department that our customers talk to when they want to invest in the auto industry safely and get a return out of it. Welcome to Maridadi Motors. I got to see the post for OMP on social media. I remember it was on Facebook. And I have always been looking for a business program that is pragmatic, a program that imparts true knowledge that would be able to impact myself as an entrepreneur and how I do my business. And I thought that OMP was looking like that, and I decided to give it a trial. And so far, I have no regrets. I have enjoyed a lot of things. First of all, the content. The content is very, very relevant. If you look at topics like, doing a strategy for your business, if you look at topics like, innovation, if you look at topics like, how to deal with your talent in the organization, the human resource aspects of the business, the financials of the business, I would say that the content has been not just interesting, but very enlightening. It has been challenging to broaden my thinking on how I manage my business. The other beautiful part has been the organic interaction with other entrepreneurs in the classroom. The stories that we've been telling each other. We've shared stories of failure, we've shared stories of triumph. We've shared stories of the challenges and the opportunities that each and every entrepreneur in that classroom is seeing in their industry. And I would say that has been a very, very reassuring bit of the program for you as an entrepreneur to realize that, some of the challenges that you have are actually challenges that other people have gone through, or they are challenges that other entrepreneurs are going through. And I would say that the OMP class has ended up being, like a support group. You can call a buddy somewhere who is running a business and tell him, I'm having this challenge. How do you think I can go about it? Those two areas have been very, very good about the program. I think I am more introspective right now. For every decision I take as an entrepreneur right now, I am going to ask myself, how is it going to affect, area A, B, C, D of the business? What is the impact of this decision on my human resource? What is the impact of this decision on my financials? What is the impact of this decision on my taxation? As an entrepreneur, many times you find yourself in a jungle without any map to read. And I would say that the OMP course is really providing a map that is showing you this is the destination of where you want to go, and these are the routes that you must take. A conversation on a difficult topic like succession, the OMP program has confronted us as entrepreneurs to understand that we will not always be youthful, we will not always be energetic, we will not always be the cool guys in the market. The market is shifting, a new generation of consumers is coming, and you have to prepare your business to be taken over by a younger person in the future. Those kind of conversations, although difficult, are very, very important in helping us create businesses that can go beyond our lifetimes. I would recommend that an entrepreneur does this program. Like I said in the beginning of this conversation, this is a program that is designed with pragmatism in mind. It's not theory. You're not doing it so that you can do an exam at the end of the day. You are actually doing it so that you can be shaped to be a better entrepreneur, to be a better person who is creating your business to take it places. Entrepreneurship can be very lonely. You can be in the market struggling with your problem, not knowing that there are 20, 30 other people that have gone through this problem before you. The OMP program brings you case studies of people that have gone through similar challenges and how they navigated some of those challenges. I would recommend, without a doubt, that any entrepreneur out there who is looking forward to creating a business that can outlive them, this is definitely a good program to take.
My name is Maureen Juguna. I work for Safaricom. I'm the HR lead for 3 businesses: business development, financial services, and enterprise business unit. The one thing I learned about the SMLP program is that it looks at leaders holistically. And when I say as a whole, it's because it has very targeted modules around how we lead as leaders, how we lead within teams, but also reminding yourself of who you are and how you show up when you're leading teams, yeah? I totally enjoyed the fact that you have one module that is not locally based, it's based out of Singapore. And for me, the exposure into other cultures and being taught by professionals who are not locally based also provides completely new insights for the program itself. SMLP has a way of ingraining this culture of how you do projects and how you approach your process of doing a project. And for me, when I think of my role, there's some elements of it that requires to do some project-based work. And out of going through SMLP, I was able to do two great change management programs, and I applied some of the learnings I had in the program in terms of project management, focusing on project timelines, thinking of different stakeholders in executing the two change management programs I had. The second thing for me is I created some fantastic networks out of SMLP. And one of the ones I can think of is one of the programs I was running that had to do with change. There's another company that was in the room in SMLP, a few colleagues who also had gone through the same thing. So it was easy to reach out to them and find out some of their learnings and use that as a benchmark to also enable me in the project I was doing. The third thing for me is, with the passion I have for coaching, I managed to get an opportunity to work with Strathmore. So I'm currently contracted as one of their adjacent coaches. And that came out of having gone through the program, having benefited from coaching, but also being a coach myself. I have seen my role transition, so I've changed roles. In the 2 years, I moved from being a business partner for one of the organizations within Safaricom, and now I'm doing more commercial organization. And I would attribute part of my growth as well from some of the learnings I had in that program. And I'm also excited to say that I'll be transitioning at the end of August to Andela. I'll be taking on a senior director role there. I'll be looking after the software developers, and I'll be taking care of so far 5 countries. And it's a role that's looking after the whole of Africa. So I'm excited about seeing my career transition and grow as well. When I think of the senior management program, leadership program, it's very different from many programs. And it's because it's really purely targeted towards growing leaders. I found that some of the courses we did were instrumental in terms of how you think and how you manage an organization. I would say for any leader who's looking for transition from being people manager to being more leading teams, this would be a fantastic program for them.
My name is CPA Ronald Bosse. I'm the group managing partner of Ronald's LLP, East Africa. In terms of summarizing my job description, I'm in charge of the business strategy for Ronald's LLP. I also provide leadership and also in charge of new markets across Africa and also linking with the international markets. Ronald's LLP, we are a professional services firm. We started out as an SME firm, but of course with time we've progressed now to even offer services to international companies and also the public sector and financial institutions. In terms of those clients that are looking for expansion in the East African region, we are the firm that will support you in terms of your business strategy within the East African region, in terms of compliance, in terms of setup, HR, taxes and audit, and every bill you require in those countries. We have actually networks that we leverage on to ensure that you successfully actually go even within the region, expand through the region. The achievements we've had is one is in terms of how we've supported various businesses. One, we've actually supported a lot of companies in this market to set up proper systems and structures within their entities so that they are able to be more sustainable businesses. The other aspect is we've actually supported a lot of companies in terms of tax compliance and also just arbitrating the issues that they might have with the KRA successfully so that tax doesn't have to shut their businesses down. The other issue is also we've been very impactful in terms of creating governance structures among the African-based entities so that we make sure that these companies are very well structured and positioned even to withstand competition. In terms of even the staff members, we have a team of more than 100 staffs, but of course we've trained many staffs for this market, some of them who have left the company and impacting the industry in various areas. Some of them are finance managers, others are maybe in terms of risk and internal audit, capacity building, even other staff members who are not necessarily our employees through various training initiatives. And the other issue also we have supported in a lot of issues in terms of content development. We write about various issues, we educate the general public on various fronts. So yes, we've had a significant impact in this market. Of course, African market is rising, and it offers a lot of opportunities for companies that probably are established anywhere in Africa to actually leverage even on the African Free Trade Area Agreement, and also maybe do market diversification by seeking establishment in other countries. Because you realize that as a country we are limited in terms of the market. So there's a way that if you have actually gotten a product perfectly, then you can actually take it cross-border, maybe in Uganda, Rwanda, Tanzania, and just duplicate the knowledge that you have learned here. Of course, factoring in other issues like cultural differences, and also that might impact on the product intake, or uptake by those countries, and of course looking at the labor supply in those countries and the other unique features that you have. So it's actually very advantageous for every company that is growing to always have a regional perspective of things, and of course to also consider global trends, because as a country we don't live in isolation. What impacts the globe will actually come and catch up with us, every aspect of it. So you cannot just live in isolation and don't have that global view of things, and of course regional ambitions. I believe I'm the single most largest beneficiary of the OMP networks, because almost 90% of my classmates that are my clients, I audit them, I advise them on tax. A week will not pass before we have an interaction on areas of their needs. And sometimes I feel I really owe a lot to the OMP program. The other issue is when you join OMP program, there's an opportunity to just look at the business in the other aspects of it. And it actually, I learned that the business of business is not merely your industry specialization. A business is broader than just the technical bit of it. There's issues to do with HR, which is also covered under OMP program. You understand how do you manage people, how do you recruit talent into your business, how do you train them, and how do you make sure that these people are actually really onboarded into the company and initiated into the company in the corporate culture. I recommend the OMP program for anybody who is seeking to grow their business to the next level. It's for progressive business people.
For the last 2 days, I think it has been mind-boggling. It has brought to fruition the fact that I have to join the dots between the strategy, the risk, and the numbers. And why the numbers? Because all what happens at the backyard, you can only see it when the numbers start telling.
The most important part of this course, sitting with colleagues from government parastatals, gives you an avenue of how to operationalize and work within the local Kenya government rules. It opened up the issue of transparency. An example was given of how Netflix is restructuring their board and creating more transparency, thereby reducing risk. And last but not least, I met a colleague who we were with in college 35 years ago. And he came and I couldn't believe it. So the course is very special to me. I'll not forget that.
The facilitators really took time to know what are the emerging issues in boards. And for me, that was, it is at the right moment when we've seen a couple of big corporates falling, the likes of Nakoma, the likes of Uchumi. Now KQ was the ideal case study at this point in time. It mixed strategy where government is involved, private sector is involved, taking deeper decisions than anyone could imagine. So I would say for every board member to read on the same page. I think this is an out of ordinary class that every board member should attend.
I also like the choice of the site. Is very quiet, very serene environment.
I like the participants in the class from various backgrounds and experience, you know. I like even the mix in terms of ages and the spectrum of industry experience of the participants in the class.
There will be quite a number of things that I will implement. One, and the most important one, is to make sure that I'm forward-looking. I need to look at my key performance indicators and make sure that 60% of what I do is forward thinking, forward understanding, and the history. Whereas it is good, I should be able to think about tomorrow and the day after, so that we make Cooperative Bank of Kenya a better institution.
In our day-to-day business operations, we take enterprise risk management as another thing to be done. But you know, out of this session, I've come to realize how it is connected to strategy and how ultimately it speaks to the numbers that come at the end of the trading period. So there's a very strong linkage between a strategy, financial performance, and how you manage risk in between the two, and then the whole life cycle starts afresh.
We see each new day with promise and hope. We see the possibilities when others only see the obstacles. We don't judge the possibilities based on the circumstances. We know that the world needs a lot, and it needs it from us. We know that we'll be defined by the chances we take, the people we meet, and the people we help. We believe the work we do matters. We know that everything we do today leads to a better tomorrow. We believe in our mission to serve society and shape the future. We are not afraid to face the unknown and conquer our fears. We know that without perseverance and commitment, nothing happens. We shake off the doubt and get back up when adversity hits. We don't fear failure because we know that is where all the lessons are. We don't give up and settle where we are. We go after it with all our strength and capacity. We show up and fight for it with all our tenacity. We know that tough times give rise to new opportunities. We are not most people. We are the leaders that break through barriers. We are the leaders that build the future. We are the leaders that make a difference. We are Strathmore University Business School. Join us.
My name is Ben Goy. I'm the faculty director here at the Strathmore University Business School and a researcher and faculty at the Institute of Healthcare Management. Now, I want to share with you a little bit about some of the executive education programs that we do offer at the Institute of Healthcare Management here at Strathmore. Now, we have two broad categories of programs. So we do have what we refer to as open programs, and these are programs that run on a year-on-year basis with a fairly regular schedule. And then we have what we call customized programs. These are on-demand programs that a health sector actor would come and request of us to come and run on their behalf, either for their own employees or for the people who are participants and beneficiaries in their various programs. Now, for open programs, we currently have two standard and standalone programs. One is referred to as LIHO, that is the leading high-performing healthcare organizations. And this is a course that is targeted at the very top tier of our health sector actors, primarily for the public sector, but also incorporating the not-for-profit health sector, the FBOs, the NGOs, and the private sector actors in healthcare. And the basic idea here is to help develop the leadership capabilities, because as it may be very well known to each and every one of you, the challenge in our healthcare space really has very little to do with the resources, but has nearly everything to do with the leadership and management of those resources to help us achieve whatever it is we want to achieve with our universal health coverage. For the other program, this is the Managing Healthcare Business Program. This is largely targeted at business owners, at people in the private health sector space who have needs that are specific to them, that are different from what the public sector or the not-for-profit sector would. And so in this instance, we focus a little bit more on issues around turning your healthcare practice into a business, how to run your healthcare venture as a business, whether it is a dispensary, a pharmacy, a growing group practice or an individual practice, learning the language of business, learning the language of banks, and so on and so forth. Alongside each of these programs and beyond the technical bit that we put in, we also encourage participants to engage in an institutional improvement project and or in a leadership project, and at the same time try to create opportunities for them to create strong bonds that can help to nurture them as they move along their entrepreneurial or leadership or management journey. There have been some notable alumni of each of these programs. I will not bore you with the details, but I will encourage you to dig deeper into what we offer under the open EE programs in the Institute of Healthcare Management, and you will see this for yourself.
Good afternoon. I hope you've enjoyed your meal, and we can proceed with the next stages of the discussion. And now, the next panel presentation is not a panel per se. I'd like to appreciate Pharmaccess, who's one of our sponsors. We have Illumina, we have KHF, we have we have ThinkWell Global, NHIF, and also would like to appreciate Kenya Healthcare Federation and Strathmore Business School for calling us here for this particular event. So at this point, I'd like to welcome a gentleman who is a seasoned leader of international health projects in Africa. He has spent over 20 years providing technical vision, managerial oversight, and technical assistance to donor and government-funded health projects. He combines solid analytical skills with special expertise in health system strengthening, resulting in technical strategies and approaches that yield significant results. He is the country director for Pharmaccess. Previously, he worked for the Council of Governors, where he served as the health financing expert seconded by the USAID as a part of a team of experts. He also served as the country director, chief of party for the Intra-Health International-led Human Resources for Health Kenya mechanism. A round of applause to Dr. Wasuno Owino, the country director of Pharmaccess, to give us the remarks. Thank you.
Yes. Yes, good afternoon. I'm delighted to make this presentation to you. And one thing which is interesting is that the questions that we are addressing today are the same questions we were addressing in 2001. And in 1996, when we were actually developing the first health sector strategic plan, because I was consultant at that particular time. So that tells us that maybe there's one button that we are actually not touching on. Now, this presentation actually builds onto the discussions that we have had, and what is very, very critical is that when we do resource and risk pooling, there are certain things that are a must, things that we actually need to do. And I'm going to illustrate that with the case of the activities that we are actually implementing at Pharmaccess. So just to give you an update of who Farm Access is, I'm sure many of you must have heard about Farm Access. It's it's headquartered in the Netherlands, and it has country offices in Kenya, Tanzania, Ghana, and Nigeria. Those are the key offices. So our vision is actually to improve access to healthcare for the people in the region, and this is leveraging on mobile and digital technology. So we work in certain components. The major one is on digitization, innovations. Then we also have access to credit, which comes through the Medical Credit Fund. We also look and provide for law insurance-based solutions, especially targeting the low-income groups. And we have quality improvement. And to be able to guide this, we also provide support to research and analysis. So those are really the critical areas. So in the next slide, what we really demonstrate there is that the digital revolution has the potential to disrupt the health markets and help to achieve universal health coverage. And I would just like to share with you a few statistics when it comes to technology. And one is that the mobile technologies and services generate about 9% of the GDP in sub-Saharan Africa and provides about 650,000 jobs. We do have high mobile penetration, and I would just like to see by a show of hands, how many of you here have more than one line? Just be honest. 3 lines? 4 lines? I know some of you are being shy. But the point is the SIM penetration in the country is actually about 119%, which really means that on average, we do have about 2 SIM cards or something like that. Of course, I know, forget about the ones who jump from one to the other because of Fuliza. You know, they tell you now, don't use this number, use the other one. But of course, it depends on the purpose for which it is there. So the critical question is, how do we utilize the potential of mobile and digital technology to bring around a change in health? And that's something which is very, very critical. And what that slide does focus to is that the future of health is digital. It disrupts the health market and brings in new players. And I would just like to give you an example. When we were working with the Minister of Health, that was in 2001, the days of co-sharing. Shifting from manual to those days cash register, you know, it was a struggle. But one thing you'd actually realize is when we did change that as a Ministry of Health, the revenue went up by more than 10 times. And so many changes have happened from 2001, 2010, and now we are 2 decades after that. So the question is, how do we utilize the technology even to enhance promotive and preventive care? And we saw a lot of this even during the COVID period. So what I would like you to think of as we move along is actually the power of the digital technology. So in this case, our theory of change is that we need to address the system to work towards a virtuous and not a vicious cycle of trust, fueling inclusive health markets. And if there's any word I would like you to carry today is TRUST. And that is trust. Not the other trust we know, but it is trust. in any place where you do not have trust. If people don't trust the quality of services, will they come to your facility? If people don't trust that the money they have paid is going to bring a difference in their lives, are you going to pay? And that's why we also talk about value for money. So the issue about trust, the issue about confidence is very, very important. And these are issues that are actually brought in by technology. So what I would want to illustrate very, very quickly, and because of a shortage of time, I will not be able to go through them in detail, but I'll be able to share with you the presentation, and we can engage more really after this. So I would want to go very, very fast because of time. So what I would like to demonstrate to the team here is how can we build a health systems, an eco-health system which is all-rounded to be able to bring difference where we can encourage pooling of resources and at the same time risk. And this will be demonstrating how we do this from the activities that we do at Farm Access. So the first important thing is about safe care, which is equal to quality improvement. You'll not be able to pool finances, you'll not be able to pool risk if people do not really have a trust in a health system that provides quality services. And that is very, very important. So at Farm Access, we do have self-care methodology that we use. And here we actually partner with organizations like Aga Khan. How many of you have gone to Aga Khan Hospital? How many of you have gone to Penda Health Services? How many of you have gone to Mbagathi? One, two. Okay. Now, the point is, when you go to each of these places, as soon as you actually enter into the facility, you are able to say one or two things about the quality. So we have actually teamed up with several international organizations to be able to provide quality improvement in many facilities, both in public and private sector. And the organizations I've just mentioned, especially Aga Khan, and that's Aga Khan, which includes both the offices in Nairobi and also in the region, and also others to be able to improve on the quality care. And we do provide this technical support also using digitization. So in the next slide, what it shows is that we do have self-care certification levels, which actually move from 0.1 to 0.5. And this is equivalent to a 5-star hotel, a 4-star hotel, a 3-star hotel. So when you go to a 2-star hotel, you really know what to expect. If you go to a 5-star hotel, you really know what to expect. And therefore, the question that we may need to ask ourselves, and this ties to the discussions that we had in the morning, suppose we change our provider payment mechanism to be based on the basis of the quality rather than on the level of the tire. At the moment, we provide more to the national level facilities and less to the lower level facilities. And if we look at it from an economics perspective, where are we actually giving the incentive? Where are we giving the incentive? You know level 1, level 2, level 3, level 4, level 5, and level 6. Yeah. We know that, okay? If we look at even the NHIF reimbursement scheme, is it true that we reimburse more to level 6 than level 5? And more to level 5 than to level 4 downwards. So 2 questions we need to ask ourselves. Whom are we giving the incentive? To the higher level, isn't it? And lower to the lower levels. So, suppose we made reimbursements on the basis of the quality of services that they are providing, rather than being at a higher level. That's something that we really need to think of. So what we do here is that we do walk the journey with the respective health facilities. So initially we do an assessment, find out the level where you are. And after that, we actually now move with you as we actually go along. And we do have a digital platform that has got about 13 metrics. And once we do the first assessment, it really tells us where you really need to improve. It has got a quality improvement plan. As a manager, you are also able to see how your network of facilities are actually doing. Through that technology, it also provides tasks. And you're able to monitor from where you actually are. And this is a journey that we have actually been moving on with the facilities. So this is different from just coming to do inspection. We actually find out where you are, and then we see how to move together with you. So of course, there are those tools which I really not want to spend so much time on. So currently what we find is that the self-care methodology is actually active in 2,113 facilities. We have done about 3,600 assessments. We have also trained assessors. And we have also been able to contribute to about 6 million patient visits. And what we have actually seen with the facilities that we are working on is about 81% have actually improved in their self-care scores. And one thing that we have actually found is that there's a positive correlation between quality and income that's actually generated. Once your quality improves, more patients come in, and by implication, the economies here, P times Q, which is equal to income, you really get more in terms of the income. So we can engage on that more. So the next product we have is, in this ecosystem, it's important, and especially for the health SMEs, to be able to provide some finances that will actually assist these facilities when things are not going well, or, for example, when there are delays in payment, or you really want to improve on your infrastructure. So what you do have is what is called a medical credit fund that we actually also provide as Farm Access. So this actually focuses in the region, and we not only provide the funding, but this is actually accompanied by business support, quality improvement, and also in training. There has been a lot of discussions in terms of the medical doctors running facilities. And the issue is there are many entrepreneurs who don't have knowledge in terms of the business environment, in terms of the specific areas. And I think we have also partnered with Strathmore at one point to be able to give trainings to these specific groups. So what's important there is that we do provide support to the health SMEs, and this is actually accompanied by technical assistance and also ensuring that these facilities improve on their quality, and we also provide a focused business management training. So in the next one, in this ecosystem, it's also important to look at financial protection. And this is actually targeting on those who are financially unstable. So in this case, for example, with the county government of Kisumu, we do have Marwa. And for those of you who know that language, Marwa, what does Marwa mean? Marwa. Hours. So we do have a financial protection scheme in Kisumu, where we are actually taking care of 42,650,000 households, and that is equal to 117,000 lives. And this is through a special product where we provide the NHIF a super cover, and this is not only accompanied by just paying the premiums. We go beyond that to ensure that these groups have access to quality care. At the moment, we are working with about 49 facilities using the safe care methodology. Anybody or any institution that has problems with respect to finances, we also provide the financial support. And of course, we'll see what else we actually have there. So what we are saying is that in this ecosystem, it is important to be cognizant of the fact that not everybody will be able to pay financially. And therefore, what is critical is for us to be able to have a very, very specific targeting mechanism, which is actually, it catches the wrong fish. How many of us have benefited from the government insurance scheme, the people who are here? Free something, either free net or free something. Several. The right net, but catching the wrong fish. Again, this talks to about efficiency in the way we actually do this. But what's critical here is actually that in the provision of this financial protection scheme, we also use technology, which in this case is called MTIBA. Now, how many of you have heard of MTIBA? Wow, that's quite a good number. Now, this is actually a product that we implement jointly with CarePay, and Moses is here, is going to address most of those questions, which really leads to that. So again, what's critical is that through the MTIBA, we are able to resource mobilize, either from the individual, from your friend, from diaspora, from the county. They all come to one pool. And that money is actually ring-fenced in that health wallet, and is only and only available for provision of health services. So when somebody sends you money, you cannot go and buy chips with that particular money. It is ring-fenced, it is protected, and we do have that digital technology which ensures that it is disbursed in a timely way. So I'll not be able to talk so much about Marwa. We can engage more. But one thing that I would just like to bring up in terms of the success factors of Marwa, and I think it also ties to some of the discussions we have had. Now, one is the issue about the legislative framework. And I had a discussion about the county raising resources. It is one to raise on resources, which of course is currently low at around 10%. You can actually increase it. But when this money is increased, this money goes to the county revenue fund. And you can only remove that money from there to use if the county assembly agrees. And that brings in the politics. So it's not just a matter of going to raise money. Once you raise that money, you really need to have a proper legislative framework to ring-fence it for health. Now, the other one is you really need to have the county commitment. I've come to your house. I'm taking care of your family. There's no way you are going to distance yourself from your family. So you really need to have that commitment to be able to support this specific cause. And what many partners are now looking for now is the idea of the matching fund. What do you put on the table? And remember, we are moving from aid to trade. And that is, instead of giving you 100% every day, I'll give you 60 and expect you to give 40. At least you'll be able to have something. So that's something which is very, very important. And of course, we really need also to see how to align with the NHIF, which I think is the major driver now. So as we talk now, in Kisumu County, we do have an MOU with the NHIF to be able to make all these things work. Now, the other critical issue that I would also like to mention is in this ecosystem, it's very, very important to be able to strengthen the PPC arrangements, that we really have. So at Farm Access, I just want to share two key products. And one is, we did talk about the private sector having liquidity issues. They're not really able to pay it, in good time. So currently, we are actually working with the NHIF on what is called an AFIA credit or what's called a grace period product to see how we can actually work with the informal sector so that, A, using technology would be reminding them before 9th that you are due to make your payment on such and such a day. We are also going to work with a bank partner so that on that specific day, if Wasuna here does not have money, I'm able to borrow digitally, just like we do with the Fuliza, and your premium is actually paid, and you're given a small grace period to be able to pay that. So that's something that has already passed the proof of concept, and we are going to see exactly what to do. We are also working on what's called an innovative value-based care model for chronic illnesses, starting with diabetes and hypertension. And the key objective here, one, is to have the first point of contact at the community level. And then we only go upwards as and when it is necessary. And of course, we are going to do this through the PCN network. And the key objective is to enhance efficiency by trying to bring care at the lower levels. And we only make payments for specific outcomes that will actually be agreed upon. And therefore, we can talk on, and I would just like to stop here, but I want just to emphasize one thing, and that is for us to be able to effectively pool resources and risks. There are certain things that we really need to look into. And the first one is we must be able to build trust and confidence, and this ties to efficiency, and that's why as Farm Access, we are very much focused on mobile and digital technology, and also working with CarePay on MTIBA. So number one is the issue about digitization is very key. Now number two is the value for money. And in this case, we must be ready to improve quality of services. And I would like to see, even from NHIF, more reforms towards that direction. And that's why, from our side, we also promote the self-care. Then we talked about health-seeking behavior and all that. So we should also be able to stimulate demand. And that's why, for example, in the Marwa, which is the Kisumu Health Solidarity Scheme, we're really trying to protect those who are really not able to pay. And for those who are able to pay, especially in the informal sector, coming up with an arrangement where they should be able to do that. Then three, of course, within that ecosystem, we'll be having small and medium-term enterprises that would not be having money today or tomorrow, and therefore it's critical to be able to increase financial support to this group. And next, we need to exploit the untapped potential for the private sector, and this is especially through the PPCs. Now, in one of the projects that we're actually working on in Kakamega, IPUSH working together with AMREF, we saw members of parliament coming in voluntarily. They want to support their constituents. So how do we actually mobilize these monies? And if you look at the support by the members of parliament, if you look at education and you also look at health, you'll find that a lot of money goes to education in terms of bursaries. But here, what we are asking for is just 6,000 shillings from a household who will be about 5 to 7 people. We also had those working in the gold mines coming to support their people. And this is what we should actually tap on in terms of the corporate social responsibility. We will not be able to succeed unless we have commitment from the national and county government. I know this is tied to the politics of the day, but We need to have that as part of the governance. And we also need to focus on major consumers of care. And the major consumers of care will be the mothers and the children, women and children. Those are the major consumers, and therefore it will be important to put adequate resources in that. And then lastly, we need to shift, and I want you to get this difference. We need to shift towards a health-oriented nation rather than disease-oriented. It's a difference between health and disease. So the direction that we need to move is towards a health orientation. The discussions we have been having here is about hospitals, it's about that. That says nothing, or it says very little about what's happening down there. Now, if you do your analysis, you'll find a lot of allocative inefficiency, and I would just like to give you several of them. In a county, the biggest consumer will be the county referral hospital, yes or no? And that will actually consume 60 to 70% of the resources there. So what remains really down there? And bulk of these resources, if you do further analysis, 60, not even 60, 70 to 80% of them will go to HRH. Again, you have men there, but they have no tools to work with. And therefore, as a nation, if you do further analysis, find out what goes towards curative care and what really goes this other side. And personally, I would really be very interested to know from NHIF, when we changed from National Hospital Insurance Fund, now that hospital was actually curative based because we were paying basically for inpatient. When we shifted to National Health Insurance Fund, so we removed the hospital and replaced it with health. I would like us to have that discussion. What has changed? Has that shifted us from curative to health orientation? Thank you very much.
Thank you so much, Dr. Wasunwa. Another round of applause, ladies and gentlemen. You could clearly see the passion, and he aligns what we discussed in terms of availability of resources, the over-reliance on direct out-pocket payments, and the inefficient, inequitable uses of resources, which this summit tries to portray. So before I introduce the next panel, I'd like to just let you know that next week we'll also be having a last healthcare event, which is a healthcare sector roundup. It's a dinner and dance. It's not a discussion like this that we are doing. I could have some more claps. So it's organized by Kenya Healthcare Federation. It will be at the Radisson Blu Hotel from 6 p.m. to 10:30. The cost individual is 6,000. A table of 8 delegates, 44,000. An exhibition booth is 50,000. You can pass by the KHF desk. You'll get the further details on and also Dr. Nyalita will align the chief guest who's coming at a later date as well. Yes. So at this point, I'd like to introduce a lady who's an health economics and health system specialist currently based at the Health Economics Research Unit in Nairobi. She has 8 years experience in health economics and health system research and practice, and 1 year experience as a nursing officer in public health system. Her areas of interest include public finance management, health financing, costing of healthcare services, public-private collaboration, efficiency of health systems, and economic evaluation. She has previously executed health system projects for several partners as the World Bank, Options Consulting Limited, and Melinda Gates Foundation, who are actually our sponsors for where we have the other attendees who are here today at the Oak Room, having enabled it to be a room that can be used both virtually and physically. So a round of applause to Anita Musianga, who will take us through the next panel discussion.
Thanks. Good afternoon. Between my impatience and my high heels, I'm not going to be standing for a long time, so you're in very good hands. This is going to take the shortest time possible. Just picking up from the previous presenter, I'm glad I did not say the meaning of Marwa from where I come from. I'm sure Dr. Wala can relate that Marwa, from where we come from, means alcohol. So I'm going to be taking you to be moderating the session on risk and financial pooling. And thank God I'm not answering the questions. My job is to ask. So, and I have a good group of people who are happy to answer the questions, and of course with the help of you panelists. May I have the pleasure of inviting Moses G. Kuria, the Managing Director, CarePay. We've heard a lot about CarePay. And Karibu, he believes that between mobile technology and mobile money and people, then we can get a panacea for our health financing problems. I hope we can. Previously, he was an auditor at Deloitte. So nice to have someone who's not very health-oriented on board. May I also take this pleasure to invite Caleb Mike Mulongo. He's a doctor, Mandela Washington Fellow. He's a consultant, and he has led various projects locally and internationally on health finance and health system strengthening. He has worked for various organizations, World Bank, WHO, Global Fund, UNICEF, UN Habitat. Karibu sana, Mike. Last but not least, Robert Rapando. He's a health systems and policy specialist. When I looked at his profile, the first thing I saw was 40 under 40. A round of applause for him. So Karibu Robert, he's big on ring-fencing health funds and strengthening community health networks. So he's going to be to tell us how, whether there is an increased focus on community health and primary health care now that there is a shift to a health fund and not a hospital fund. Karibu Robert. So where I come from, we've been accused of admiring the problem. And as our previous speaker was talking, one thing he kept saying is that these are the same problems we've been solving for the last 20 years. So do you believe we are admiring the problem? We are just admiring the problem. This is a very good problem. It looks very good. It is, we need to come up with ways of solving the problem, but just admiring the problem. So hopefully my team of panelists by the end of this will no longer be admiring the problem. We will be solving the problem. So I just saw Wangari walk away, but she said we have 450 billion or thereabout. And I believe the reason most of us are not sure why we do not, why or what figure exactly we have is because of pooling. So starting with Mulongo, sorry for putting you on the spot. Are the current pooling arrangements enhancing financial risk protection?
So thank you very much, Anita, and the summit team for the privilege of just engaging today. So the question, the political answer would be a mixed answer. To some extent, yes. To some extent, to a great extent, no. I see Martin around, and so I'm going to hit at them a little bit from NHIF. So yes, to the extent that, one, we appreciate that the background, we work within a context as a country where about 80% of the population don't have a form of insurance. And again, a portion of about 80% of the population is vulnerable to a great extent by virtue of either poverty or just being middle class. And then the other reality in terms of a number is that we work within a context where 80% of those who are in employment are actually informally employed. And so to that extent, we have a lot of vulnerability, either by virtue of income level, geographic level. So to what extent has NHIF or the pooling mechanisms that we have advanced equity? We can say, for instance, we know that NHIF has Linda Mama that targets the vulnerable mother and child, and Dr. Osuna has mentioned the mother and the child. We know to a great extent that the UHC sponsored program in itself is targeting indigents. So to that extent, there is some element of cover or equity by virtue of income level. But the other reality that we have to face is that we know for a fact that with the high level of informality, if only those who can contribute are the ones who are getting the cover, then you're locking out a large proportion of the population, number one. Number two, we look at the fact that only 20% of the population have some form of insurance. That means that 80% of the population are not covered. And we're not equating insurance to coverage, because essentially it's you being able to access care when you need it. But then when, for instance, we have NHIF and has let me just use a good example. You have the super cover and you have the enhanced schemes. The difference in those two is that one, you pay more and you get more benefits from whatever you contribute. If care essentially should be harmonized so that I access it based on need and not ability to pay, then the existence of multiple pools, the enhanced schemes, do not then advance the cause of equity. Maybe the other final point I would point towards that is if we were to reflect on the fact that from the data from 2021, NHIF had empaneled 72% of the people or the providers within NHIF were government of Kenya, public facilities, and only 24% were private. But when you come to reimbursements, more than 70%, roughly 70% of what NHIF paid out went to the 24%, the private sector. So then we're asking ourselves then, to what extent does that advance equity? So I would say it's a mixed bag. There are good things, but there are areas where there's still some work that needs to be done. Thanks.
Thanks, Mike. So Mike has talked about NHIF. And when I remember Edwin's conversation in the morning, the pools are many. There is MOH, there is NHIF, there is the 47 county governments, there are corporate covers, private insurance, donors. So, Robert, you sit at the Council of Governors. From the NHIF perspective, it's a mixed reaction. Mlongo says that. So at the current pooling arrangements enhancing financial risk protection for Wanjiru, as at now, can Wanjiru go to hospital and I'm going too far, like even the middle class, like for me, Anita, when I exhaust my insurance cover, do the current pooling arrangements enhance financial risk protection, not just for me, but for the poor?
Okay, maybe I'll say it's a yes or no, because if you're talking about pooling, there are two aspects that are very key. One, it is the size of the pool, and then two, diversity of the people in that pool. If you look at what is happening now, all those schemes, for example, they are very specific. That's why Professor Edwin was saying they are not sustainable. And then two, from NHIF data, I think 20% coverage, but out of 25%, I think only 14%, or rather, very few people are paying consistently, meaning that even the pool is very small. It may appear big in terms of absolute number, but if you look at how people who are contributing, they are very small. So one is to expand the pool, and how to expand the pool is we have a universal, or rather a compulsory cover. Everyone has access to insurance. And then two, we diversify that. So as currently constituted, the Wanjiku, I think that people in this country have had the benefit of going to places like Turkana. You have insurance. If you look at, for example, the indigents, the people under UHC scale-up, you are given a target of 32,000 people. After 8 months, you ask how many of the 32,000 people have been able to access a service using insurance, and they tell you only 20 people out of 32. The other people are going to facilities, they are paying out of pocket.
Finally, Moses, CarePay is designing a mechanism to mobilize resources from individuals, governments, the private sector. This is an attempt to pooling. Have you been successful? If so, how can NHIF learn from you? And apologies from Osoro, NHIF. So how can they learn from you? And I can see that you're also looking at mechanisms of bringing in the informal sector with NHIF. So what is NHIF doing to enhance financial risk pooling and risk pooling?
Thank you very much, and good afternoon, everyone. It's a pleasure to be here. Before I answer that question, I think we really need to tackle this bull by the horns. The current risk pooling mechanisms in this country are just simply not adequate and are not, and we have to be honest. When we are talking about only 20% coverage, when you're talking about, according to the research that was released last year, the FinAccess survey, a survey that is done this country every year looking at how people access financial services. And we say that only 1.9 million Kenyans access private health insurance. Only 5.9 million Kenyans access NHIF actively. Now, this is a country with 50 million people. This is a country where we have also all kinds of vertical funding. So the risk pooling mechanisms and the risk pools that are there are simply not adequate. Every time we say that 1 million Kenyans are pushed into poverty every year because of healthcare spending. So I think we need to, while it's a mixed bag, because there is some, there are some successes, I think we need to be more self-critical, because this is still the same land of M-Pesa, where in the same survey, over 22 million Kenyans access mobile money services, over 10 million access banking services. And beyond that, over 8 million people are in informal groups, the chamas that are, you could consider them, form of informal risk pools. So we must do more. So let me then come to what we as CarePay, as MTIBA, we are doing. I think the biggest issue that we see is the fragmentation of the risk pools that are there. Whether you're talking about the social-based insurance, NHIF, which I believe is, whether you're talking about private health insurance, and I saw my good friend Dr. Matolo in the previous panel, whether you're talking about disease pools or you know, pools that are targeted with vertical funded pools, for example, malaria, TB, and so on. All these pools are there, and even the out-of-pocket as people pay. I think the biggest issue is consolidating these risk pools and getting the efficiency out of these risk pools. And as MTIBA, what we have done is to build a platform, MTIBA, which combines all these various risk pools and payment mechanisms and connects healthcare payers, providers, and users. Because there is no way, if I give you a vertical fund of malaria, it does not mean that you will not have TB tomorrow, hopefully not. But it does not mean that you will not have you will not visit your primary care facility. So we must combine this, and technology enables us to do that. If we look at this country, M-Pesa created the ability for multiple financial solutions, and banks have really exploited this to the maximum, where they are able to offer services on the same M-Pesa ecosystem. So that is what MTIBA aims to do. So today we have over 4,000 healthcare facilities connected across the country. We have worked with NHIF to target and reach these informal sector groups by making sure that people are able to consistently save and pay towards their NHIF premiums. People are able to consistently be reminded. And then we've combined various vertical funds and layered those on top of horizontal covers and health plans, which I believe is fundamental in the achievement of you know, adequate risk pools.
Thank you, Moses. I would not like to undermine the expertise that the plenary has, so I would take comments and questions before we continue, so that we don't feel overwhelmed at the end. Any questions, comments up to here?
Thank you, Anita. My name is Michael Mangutha Gitangu. I'm a medical doctor by training, and I also work in the pharmaceutical industry. I'm a market access leader in the pharma space. I have previously worked in funding and financing across multiple geographies in sub-Saharan Africa, and maybe a few comments related to what we've said. One, NHIF has done a jolly good job at what they've been able to do from their inception. So 1966 to 2022, there's some competencies that have been acquired along the way, no doubt. I think as a country, we have a pretty good understanding of the fiscal space, of the healthcare expenditure, including the costs of care, which have, you know, like there are technical working groups that have put a lot of work there. There's empirical evidence. Myself and others did some studies across patient journeys and costed them. So we have a firm understanding, and the knowledge and the human capital is there. Again, going back to my earlier comments earlier today, the how. I think and what I'm looking to get out of this summit is the how. We have understood how we should probably finance. We have put it in law. We know that voluntary contributory schemes do not work world across. There is evidence, no doubt. How do we get these informal sector contributions pulled into this large enough risk pool? Because we know, as it stands today in Kenya, the formally employed are the ones cross-subsidizing care for the informally employed. How are we going to make this informally employed Kenyans or informal contributors through a mandatory contributory scheme pulling into a risk? And I think we have the answers.
Any other questions, comments?
Thank you very much. My name's Ibrahim, former CEC Health, Wajir County. Mine is just a comment. Maybe you can react or you can give. Basically, since the summit is on the healthcare financing, I see that health has become commercialized in Kenya, because what we are trying to addressing is access, not quality of care. Because you might go to a facility. I think my colleagues from the health professional bodies will just excuse me for that. I'm just giving a comment. When you go to a private facility, after you've been diagnosed, for treatment, you are being asked, are you paying, what is the method of payment? Are you paying cash or insurance? Because maybe the kind of treatment you have been given will depend on the kind of payment, whether it's insurance or cash. I don't know whether you saw yesterday, there was something going around in social media from a senior politician in the country that he has gone somewhere outside the country for a procedure, and he said that health is very expensive in Kenya. That's why he went to that country for treatment. So that's one part. Other thing is, I happen to be one time CEC Finance in Wajir County. We have the component of the own source revenue in our budgets. And I think most of the counties, they hardly achieve the target, because we normally have the finance bill that's been taken to the county assemblies, and we have the revenue streams that's supposed to be approved by the assembly, so you can put into market and they can get tax. Now the MCA is actually holding ransom the governors that they cannot pass any finance bill unless maybe they are being sorted out themselves. So the issue of on-source revenue is also another problem for the counties. The other issue of quality in the private sector is another problem. So how do you address health in the country? Thank you.
So I'm glad I have someone from COG to tell us how they are going to ensure that we get money. So for the others, just, okay, I'll take our last one, please.
Thank you. I was excited about the discussion on mobile phones coverage, and it's a question that I keep asking in terms of revenue mobilization. What are your thoughts about, say, taking a certain percentage of monies that subscribers buy resources from and channeling that money to a health fund? So we know that so many people, up to the informal sector people, own mobile phones and they buy credit. What do you think about the possibility of just taking a bit of that money
and it being sent to a central pool. And then we do away with the user fees so that facilities are just, financed adequately and people go there knowing that they've already paid for care by purchasing airtime. Thank you.
So, Robert, you want to go first?
Okay, I'll focus on the physical space. It's true, as a country, our physical space doesn't look good. So what is happening, I think the broader, when it comes to the on-source revenue, I think recently there's a report by the Commission for Revenue Allocation. And what they said, what the counties are raising, it is very small. And in health, they say basically if you allow health facilities to be autonomous in terms of operational and financial autonomy, they can raise between 4 to 7%. And I want to give an example of Nakuru as a county, which has granted that autonomy even without, all processes. They moved from like an average of 500 million to around 700 to 900, and now they're doing 1.2 billion. I'm sure a county, if you take what the counties are raising as on-source revenue, for example, from the health sector, if you allow them to spend that money at the facility level, they will triple or even go 5-6 times. But once I raise money for somebody else to take the money and go to Israel for benchmarking, will you raise money? So those are the wider reforms that we need to allow facilities to have some level of autonomy in terms of resources. And then that autonomy does not end at the money aspect. If you want that in charge to hold the staff in that facility accountable, give him some level of autonomy. Give him some powers. He will ensure that there's no absenteeism at that facility level. He will ensure that the community unit which is linked to that facility is working. And then I'm looking at all this in terms of pooling. I think if you look at investing in preventive measures at that level, the benefits far outweigh even the financial issues around that. So we're working around the law on that. Then finally on the surplus, there was a question here prior on the surplus from NHIF, and I was thinking, if NHIF has surplus, is it possible for NHIF to send that money back to where the money came from in terms of like a motivation for people to prevent more people from falling sick so that you avoid people spending money? So, and then finally on the funds, there's somebody who has mentioned about the funds. Personally, when I look at a fund, when I look at any entity that has a fund, I look at a broken system. There is something that was supposed to work, and because it's not working, you go away to go to the fund. So let's sort the political economy. We talk to people in finance and revenue and tell them, if you allow facilities to retain money that they collect, the county is going to increase fourfold on-source revenue collection. Once the county increases, as a country, we won't need a lot of money from where we go to borrow resources. Over.
Mike, you have something to...
Yes, thank you very much. I think Michael mentioned the fact that NHIF is, and as a country we have a history and we have lessons. And for a fact, given our structure as a country, and I'm speaking to the concern around the informality of our context, to expect that we will mobilize adequate resources and pull risks from contributory systems within our context, that is a hard nut to crack. The reality is that all the countries, even those that have been mentioned earlier, whether it's the UK and the NHS, whether it's India, whether it's Chile, whether it's Mexico, the reality is that that adequacy has been largely driven by the government pumping money into health. So the moment that sinks in and that conversation happens, then that is when adequacy becomes something we can. And even now, the NHS is still struggling with a concern on adequacy. But the reality is, if you're looking at sustainability, if you're looking at advancing equity, given our context, then government funding of health becomes paramount. And then, so that then it's not about mandatory contributions, but it's about automatic recruitment into this cover, and not necessarily that you have to contribute. That's one. On the aspect that has been raised on care and the quality of care, that's a very valid concern, because even as we are advancing the cause for universal health coverage, the question is, you're improving access to what? Are you advancing access to poor quality of care? because that is what we have, yeah? So the reality is that there needs to be a marriage so that this advancement in access is married to advancement in quality. And we appreciate, and that's what I know even Safecare are doing with Farm Access. It's a journey, but are we committing towards that journey? And that commitment is not just a responsibility of the provider. It is a responsibility as well of government. And yes, the government has set standards, the KQMH and so on, from 2014. That has been in existence. But what are you, as the payers, knowing that we are all stakeholders within this health and the quality conversation, what are the providers doing to incentivize quality? Are your payment mechanisms in incentivizing quality or overproduction of services? So the signals that you're sending through how you're paying or how you're purchasing your services also have an implication. The other bit, as far as from accountability is concerned, how empowered are our populations, our consumers or the patients, as far as a quality conversation is concerned? Dr. Osuna mentioned the aspect of building trust. The trust in the public sector, the trust in the private sector is waning, and largely because of some of those perceptions around quality and the perceptions around just the cost of care. The discussion around whether we could have some forms of levy or taxations on existing, so for instance, mobile usage, as it were, that becomes a good, and I know, by the way, about 2 years ago, part of the taxes that were being levied towards mobile services were actually being channeled towards health. So that essentially speaks to the role of government mobilizing that resource towards health. And that is something that can be advanced. Thank you.
Yeah, go ahead.
Yes, I think I want to start with just building on what my panelist has said. Technology is there that can enable the levying or the taxation or the administration by tapping into the payment ecosystem. But before we do that, the number one fundamental thing that has to be addressed is trust. Do I trust that I will get these health services if my deduction is taken off from my M-Pesa or the other mobile money services that are around? And this also fundamentally addresses the issue why when I show up at the point of service, I'm asked, are you paying cash or are you paying with an alternative mechanism? Because if probably cash, I can have it. I don't trust whether the alternative mechanism will come in terms of the time that they have said they will pay. And that speaks to the provider-payer engagements, which I know there is a discussion later on. So I think technology is, and we have seen this even in banking and so on. Technology is there and it can enable the mobilization of funds in terms of the efficient administration, the efficient levying, the efficient engagement, so that even as I get a deduction, I know this is going towards my health, healthcare access and so on. But we have to address the issue of trust before I get there. One of the biggest issues that we see is that if no one trusts in that healthcare system, no one will prepay. And even if we put taxes and levies, in this country, our tax base is also quite thin, so to speak. And therefore, we must be able to capture the informal sector space and the broad space that is there. And today, the prevalence of mobile money enables that. But that conversation has to be preceded by what will I get? Will I trust the system? Will I trust the efficiency? That if 500 shilling goes every month towards this risk pool, that I will get quality services. And I think that's a fundamental thing to have. But broadly speaking, also the approach, maybe let me just add this, we also fundamentally believe that with the approach that government has taken with identifying the vulnerable and supporting them and mandating and encouraging mobilization of resources beyond the tax base, but also mobilizing from the contribution so that by taxing, we don't crowd out already the funds that are in the system. Thank you.
So my final question, how can we reduce fragmentation and increase consolidation of pools? How can we ensure that we have one pool? It's not the COG, it's not the MOH, it's not this disease fund, it's not MTBA, sorry, it's not NHIF, but it is one pool providing care for Kenyans. You first, please.
Thank you. Yes. I think the biggest thing is we can leverage technology, and technology today enables, in fact, I know most people, particularly those who are formally employed, have a private health insurance cover, they have NHIF, and so on. So technology today enables the health wallets and health benefits to be bundled in, and even the vertical funds and the other pools that can then be targeted, so that if you're paying for maternal care, there is probably a that can be channeled and administered in a digitally efficient, trustworthy way. So technology is there and it exists.
So it's technology for you. Mulongo, in 3 words, what's the solution for you?
3 words. I don't think there's a magic bullet, in my opinion. And technology is an enabler, but it isn't the solution. But we must also appreciate that the challenges, what are the drivers of this? Why do we have fragmented pools? Why does, for instance, NHIF have multiple pools? Are you able to address the politics that drives those multiple pools? That's one aspect to remember. 2 is if there's the push and the drive by government financing, because most of us pools exist simply because they're trying to mobilize resources, as it were. So if the question around mobilization of resources is largely handled by government to a great extent, that can be addressed. Then the final thing is standardization or harmonization of the benefits or care, so that it doesn't matter whether it is the super cover versus the enhanced or the private or the MTBA. Thank you.
Robert?
Okay, to me, I think the silver bullet here lies in using data for the decision making. I try to think the same woman who is being covered under Linda Mama is the same woman who has a child who is covered under Edu Afya, is the same maybe woman whose husband is covered under an InGen program. So if we can get very good data and harmonize all these pools into one, I'm just looking at the calculations here, 36% of Kenyans are poor. Those are 4.2 million households out of the 12 million households as per the 2019 census. If we were to pay all of them NHIF, it costs to 25 billion, which is very small money. I'm sure the money that we are spending on Edu Afya, Linda Mama, and all other schemes combined, it's more than 25 billion. So we can use data, we harmonize all these into one pool, and then we pay as one.
So for my panelists, it's technology, it's the right revenue raising, it's about data and sharing. I don't know what is the answer for you. Ladies and gentlemen, I'll take a final comment, and thank you very much.
Thank you very much, Anita. I'm Edwin Moses. I've been here from morning, and this is my contribution. Number one, it's interesting that we are geared towards ensuring that we have proper primary health care. So I want to give a case study or a scenario whereby this lady from Nyalgunga, that's that part of the world, could it be possible to have kind of collaboration between community-based healthcare finance system with the NHIF, and therefore NHIF provide the infrastructure and they pull together, because maybe the hospital is 100 miles from the community, so they are faced with challenges. So when they pull together these resources, they're able to be trained, and therefore they are able to provide or use the money they have in accessing the healthcare wherever the system they have around. I think to make summary from all this discussion is, number one, we don't have the spirit of accountability. And because of that, that's why it's very unfortunate that we are discussing the issue of NHIF as far as health financing is concerned, and the stakeholders in the ministry within NHIF, they are not here with us. So that's the spirit of accountability is a major problem as a country. Number two, the spirit of accountability comes with also the issue of misuse of resources. In this part of the world, Anita and the rest, it's the only place where somebody can escape traffic using chopper with the public funds. So when you're talking of pooling of resources, how will you be incentivized or motivated to pay when you know very well when you pay this money, at least you are not able to get proper services. So I think it's the stakeholder to incentivize us or the community or Kenya at large to make it more appealing for you to contribute, even if you are self-employed or if you are employed, because you know very well that money is going to be used effectively, and therefore the nearby hospital will be well stocked with drugs, and by extension, you not be asked when it comes to issue of health to dip in your pocket to support your family or support any family member. Thank you very much.
Thank you very much. So I'm also a big advocate for accountability, and especially social accountability. So it's technology, it's data, it's social accountability, and accountability in general. And for you, it's?
For me, it's, my name is Dr. Anba Ganatra, and I'm representing the union. I want to first say that we seem to be focusing so much on risk pooling and NHIF as a driver of UHC. My concern is, when are we going to start talking about how can we work towards ensuring the county governments are well funded so that they can pay their workers and also invest in health, the same health that the NHIF wants to purchase from GOK facilities. So how are we going to ensure that? When are we going to start having conversations of financing of health, not in terms of risk pooling?
Sorry, no more comments, no more questions. I hope we have a Twitter hashtag so that we can keep on engaging. Ladies and gentlemen, it's technology, it's revenue raising, it's accountability, it's HRH for some people, but we are all moving towards the same direction, which is UHC. And UHC means that Wanjiku, sorry, can I give another name and say maybe Rapando can get quality, affordable health care. Asanteni sana.
So much. A better round of applause, ladies and gentlemen. So before you leave the stage, I'll call upon Professor Kokwaro to give you a small token of appreciation. Could clap for them. It's the only group that has maintained the time slot allocated. I'd also like to call upon Osuno on stage. We have a small token of you. Prof, don't go yet. From one professor to another, so. Thank you so much. So for those joining on us, please continue sending in the comments, the directions, and you can see it's a lively conversation. Sorry for rushing you through a bit, but we are really short on time. So at this point, we are going to do a spotlight address. It will be a 10-minute address. And the person leading it is a seasoned human resource management practitioner with over 19 years of experience in the field of human resource development, organization, transformation, process engineering, and implementation. She holds a Master of Business Administration from the University of Liverpool, Adaptive Leadership Certification from the Harvard Kennedy School of Law. She's a member of the Chartered Institute of Personal and Development, CIPD. So a round of applause to Ms. Terry Ramadhani Kiungu, the CEO for KEMSA, to give a short remarks. Karibu.
Good afternoon. How heavy was lunch? Huh? Did we do? We had a good one. then even though I have 10 minutes, I would really want to encourage all of us to just stand for 1 minute and stretch. Maybe that will put blood back moving and digestion will work. You know, just stretch out a little bit. You know, if I had enough time, we would be jogging and, I don't know, doing what on the spot. But I haven't got that much time, so just a little bit of a stretch. Excellent. Thank you very much. So good afternoon. Thank you. So I've only got 10 minutes, and in 10 minutes, I intend to sort of share with you a little bit about KEMSA, and then perhaps, you know, share with you also some items, you know, some thoughts that we've picked up from the conversation so far, but also perhaps things that need to be captured as we go along. My name is Terry Ramadhani. I'm the CEO of KEMSA. Is there anyone who doesn't know KEMSA in the room? Yeah, our reputation supersedes us. We are aware. So I am glad that I don't have to explain what KEMSA does or what KEMSA is to a great detail, but I will, in a nutshell, tell you what we should be famous for as opposed to what we are infamous for. And then I'll share a little bit about our strategy and talk a little bit about challenges and then a few thoughts, and I hope to do all that all in about 9 minutes. Now, so first slide first, please. So now, this slide is very wordy. I keep telling everybody in my team, I really need somebody who can do really good graphics to make this like really tiny, because it's copy and paste what the act says. And they keep telling me, oh, but you know, we can't really compress, well, a whole story. But basically, what KEMSA is supposed to be doing, very simply, what these many, many words are telling us, is one, we are supposed to procure, so that is source, and we are supposed to warehouse, and we are supposed to distribute medical commodities and equipment. So HPTs, health products and technologies. But I like to use medicines and equipments, because at least that way we're not leaving anybody behind. Everybody gets what that is. You know, when we say HPTs, everybody gets a little lost out there. But medicines and equipment. And we have a few other strategic, you know, objectives, like having networks of distribution across the country, as well as helping counties to have the capacity to be able to do their forecasting, their quantification, etc. That's what we should be doing. So, next slide, please. We are working on that 3-word. Somebody, the moderator before was saying in 3 words. Our 3 words are turnaround strategy. Because where we are, where the institution currently is, really needs to be in a different direction. And we have made progress towards that new direction. And what we are really focusing on right now as KEMSA is 3 pillars: operational excellence, customer focus, and repositioning. That is all we talk about. And those 3 things are hinged on a very strong foundation of governance and stakeholder engagement. And governance is important. Stakeholder engagement is critical as well. And what will all that do for us? It will help us to get these medicines and equipment, sorry, please go back, these medicines and equipment to our customers, quality, affordable HPTs to save lives and improve lives. That's all we are trying to do now, you know? We're not trying to do any of those other things that we're infamous for. We are just trying to get these commodities to the patient affordably, good quality, in good time, to save lives and improve lives. That's all. And if we do that really well, then we will hopefully become the HPT supplier of choice. Now, I put there the values because KEMSA had integrity, customer focus, operational excellence, diversity and inclusivity, and innovation as our values. Recently, in the exercises that we've been doing in terms of co-creating what our agenda as an institution should be, knowing that we need to deliver this very essential service to the patient, 2 more values were added in a process that was actually quite captivating because it was not led from my office. It was very much led by the staff themselves. And they came up with 2 new values that melt my heart: empathy and trust. Now, we've talked about trust. I've had trust mentioned at least a dozen times in the 15 minutes I've sat here. I mean, I think it's pretty obvious to all of us who live in this country that we have fundamentally broken the trust that the people who receive services from us, you know, they really don't trust us. So what are we going to do about it? Well, I can tell you talking about it is not going to make them trust us. It's going to be about delivery of service. It's going to be about walking the talk. That if we need to deliver the commodities, delivery of commodities is what's going to make the patient trust us. And that's what we are focusing on doing. Next slide, please. Now, key highlights. What are some of the things that we are doing? Under operational excellence, we have embraced principles, philosophies such as Kaizen to help us cut waste, to eliminate inefficiencies. Because this is very much a process-oriented organization, and those processes have to really, really speak to what we are trying to achieve. And the end-to-end visibility, I mean technology, you know? Technology will help us to be able to see where is the inventory at any one time, and what are we not getting right. It will be the answer to, when the counties order what they've not been ordering before, then somebody will ask a question, what's going on? I didn't think they had malaria there. What's happening? You know, is somebody up to the usual? Anyway, so some of the other things we are doing is we need to have very vibrant conversations with our manufacturers. Because for us to continue getting the benefits of best pricing, we need to really talk to the manufacturers. Because at the fullness of time, we need to be having contract manufacturing, as opposed to relying so much on importation of all our commodities. Because if we learned anything from COVID, is that we will not secure our pipeline if we keep relying from external supply chains that may not necessarily prioritize us when the next pandemic hits our shores. Now, customer experience. Our counties keep telling us, you are not providing us with what we need. We agree. It's true. We are not. We're trying. You know, we really are. But we understand why we are not. We understand why what it is that they should be, you know, getting is not what we are giving us. And I'll tell you a little bit of that in a while. Our brand image. I mean, I can't even say anything about that. I think we are well known for whatever it is. Financial sustainability, healthy cash flows and ratios, financial ratios. For us to be sustainable as an institution, that is imperative. You know, we do need to get to a place where we don't have, you know, to sway in terms of when things change, then we're struggling. The people and culture. We are trying very hard to make sure that all our staff are competent with the skill sets that we need, but more importantly, the right orientation. Because the right orientation will speak to empathy, trust, and all those other values. The right orientation will put the patient at the heart of every conversation. The right orientation will know that KEMSA doesn't exist for KEMSA. It exists to serve the patient. Now, the last thing there is, of course, we are looking to have better quality work, but also better rewards, you know, so that people are motivated and engaged and feeling that they are doing a very positive contribution for their country. Next slide, please. So some of the successes and developments of, you know, what it is that we've gotten to our order fill rate from 18% last year. For those who may not really know what the order fill rate is, it means for every 100 items that the county orders, how many can we deliver? Last year, we could only do 18 out of 100, which means if you order 1,000, then we only give you 180. If you order, you know, you can get, you get how it goes. And the orders in the counties are large. You know, there are very many products. And we could only do 18. Our order turnaround time was 46 days average. Now we've moved it to 16. And we've collected 5.6 billion from sales in the last financial year, and this quarter we've done 1.9 billion. Please go back to the last slide. This particular slide is very important because Best practice globally is 95% order fill rate. At 60%, we're still off the mark. We're still really, really doing badly. But it's an improvement, and we have to acknowledge it. We are in the right direction, but we won't stop pushing until we get it back to 95%. But getting it there has many ingredients. One, financial. Two, getting the right quantification and forecasting of the right products. So one of the things we are doing to make sure that we have the right products is stripping back our focus to entirely 100% VTA, vitals, tracer items, Class A, for both non-farms and pharmaceuticals. Class B and Class C will have different timelines and different expectations, because we can't have an inventory that is full of Class B and C and stocked out on Class A and tracer and vitals. I mean, what are we doing? And then we keep these things in the warehouses. They're slow moving, dormant, to wait to incinerate. What are we doing? I mean, that needs to turn around. And so 100% focus VTA, that's what we are doing. Turnaround time. We've done our route optimization. We've piloted in Kiambu County to see how best to deliver the commodities so that we are not going backwards on ourselves. That, you know, you take something to Naivasha, come back, take another one to Nakuru, come back, then take another one to Kisumu and come back. I mean, you know, using 2 billion in transport costs a year. We can do better, you know, so we're doing a lot of route optimization. We're also doing network optimization, which means that we are putting in place our warehouses out in the country, upgrading them. We've started with Mombasa and Kisumu, so that we bring these commodities closer to the hospitals, so that our target of 157, 1 day for critical emergency items, 5 days for hospitals and 7 days for primary health care centers is met. We are at 16. We won't stop until we get it to 157. Our collections continue to be a huge issue. Even, I think, in today's paper, they were discussing what we discussed with parliamentarians last week, that we still have 3.2 billion outstanding in counties for various reasons, you know, and we are pushing to get that money back in, but it's not easy. Please go to the next slide. So, from an infrastructure perspective, we have a brand new supply chain center that has given us an increase of 141% space. It has almost 14,000 pallet space. If we add the old warehouse, which has about 9,000, it gives us about 23,000 pallet space. And it has a height of 7 meters. That's as high as we could go without offending Kenya Aviation Authority. And then 8 cold rooms. 4 big ones, 4 small ones. When I say big ones, I'm saying the big ones are probably, each is half of this room. So 4 of those, and then smaller ones that are just slightly smaller than the bigger ones. So quite a big, impressive cold chain that goes way beyond -25. In pallet firefighting, we are very proud of this feature because it means we don't need to lose commodities. If there's an incident, the fire is extinguished in pallet. Now, we're repairing our old warehouse so that we can have an end-to-end flow. Why is this important? Because the more space we have, the quicker we are able to process the orders. So as we move all the commodities for storage into the new warehouse, the old warehouse becomes more and more operational. So we keep taking down the racks and getting more space to get the dispatches out, to get the staging, to get the picking, all the activities that are to do with warehousing. We have talked about Kisumu and Mombasa. Processes. We are developing a new ERP. We do have an LMIS, which we've been using for a while. It will be revamped as we are revamping the ERP. We have an electronic proof of delivery, which allows us to be able to have on-time delivery evidence, which is really important because on that basis we get paid. And on governance, we have a fully constituted board. We have a substantive CEO now. We have a turnaround strategy with revised values in place. We have a new organizational structure that we are trying to deploy, but we have some legal challenges. And we have staff commitment, absolute staff commitment in a time that is very, very difficult for staff. But the amount of energy that I see in the warehouses excites me because I think those guys really get the mission. You know, they really get the mission. And it's moving on across all other departments. Next slide, please. Now, challenges and support. I wanted to put this last because, you know, I wanted to overwhelm you with all the good things so that you don't feel like we're still struggling so hard, which we're not. So we talked about the financial. You know, actually, I've talked about almost all this in one way or another, as I've spoken in the other, about the other slides. The financial ones, we've iterated what kind of amounts are outstanding in different places. Cash flow, I'm sorry for the choice of color, it's not coming off very well here, but we do have some funding gaps, and the OFR is attributed to us not having enough money to pump towards the OFR commodities, and also other issues in terms of disruption to global supply chain. So you have a lot of non-performing contracts because the prices that were quoted vis-a-vis the prices of commodities by the time they are procured, not matching. And so the suppliers are declining. And we have other issues related to supply chain. And then procurement, the stockouts, again, related to some of those issues we've talked about, having the wrong items in large quantities and the ones we want in smaller quantities because of interruptions of global supply. So a whole streamlining of engaging the suppliers, getting the quantifications of what we want brought down to scheduled deliveries so that you're not caught in one big consignment, and if that supplier fails, then you are really in trouble. And other tactics like those. Reforms, I've talked a little bit about the litigation, the issues we've had with unqualified staff, and you know, they've been captured mainly in the media. Next slide, please. And so, what are we looking to do? Where would we perhaps partner? First off, in the concept, in the construct of local manufacturing, I was just talking to CEO KHIF and I was saying, you know, first quarter next year, we would like to have a forum where we invite all our local manufacturers just to talk about manufacturing for KEMSA. Can we start that journey? Can we start that conversation? How does that look like? Can we come out with a white paper that is something we can implement in a year or so to get the manufacturing component becoming one of the key pipelines for KEMSA, so that as we increase our offtake on commodities that are available locally, manufactured locally, then we are reducing our appetite for imported commodities. Debt collection, you know, if anybody here has skills in debt collection, we are looking to partner, please. We'll give a nice, commission. Building capacity for our board, we continue to do that. Capitalization to ensure sustainability. The legal reforms for revenue diversification, because until we get out of this rut of county governments will pay, but are not really compelled to because there is no law that can allow us to get the money directly. We continue to be in this particular situation. Therefore, we need to start thinking, what other ways can KEMSA make money? You know, can we get to a point where KEMSA actually buys for everybody in the country? Would it be so bad? You know, would it be so bad that we are buying even for private sector? Would it be so bad if we were buying for some of the countries that are neighboring to us? I mean, imagine. Maybe that could actually give us some income. Maybe it could even help us to get the commodities to our public health facilities at subsidized price, maybe at no cost, maybe. You know, that would go to the conversation of health financing that we are having here, remembering that 40% of health cost is commodities. And by the way, you know, one of the things that I've noticed in this document is that there is absolutely no mention of KEMSA. And I was wondering, how do we have a conversation on health financing and nobody's talking to KEMSA? And I don't get that. 40% of your cost is us, it's commodities. Shouldn't we be having a bigger conversation on how our efficiencies drive the cost of healthcare lower? Because if that 40% was 10, 15% or lower, that's 20, 25% money back into our pockets. Isn't it? Isn't that something we should be having in this document? So imagine if the word KEMSA is missing from the document. I'm also imagining all the thinking around how we procure and all the things we need to do, the thinking is also missing. Yet, the number 2 objective is to maximize efficiency and value for money in management and utilization of available health resources. Dr. Nyalita, your homework is cut out. So, ladies and gentlemen, that is us. We're looking for your support. We look for your prayers. If you pray, please do pray for us. The task ahead is big, enormous even, but I have absolute every belief that we can get it done, because even if we moved the needle just a few degrees, imagine what a difference that will make for the patient who cannot get paracetamol from the kiosk outside Strathmore like we do. For the mother who's waiting for oxytocin. And can she really delay the birth of that baby? Or can she put it off and say, oh, well, you know, this year is not a good time to be sick. This year is not a good time to have a baby. Let's try next year. Next year, we will have the medicines. This is a big deal. And I think as a country, we need to take it seriously and start to do the things that are best for the patient. For just this once, let's think about the patient. Thank you very much.
So thank you so much for your wise words and counsel. So I'll request Dr. Nyalita to come and issue a small token of appreciation. So thank you so much. So now we are at the tail end. We are going to the breakout sessions. We'll take a maximum of at most 20 minutes. Basically, this is just a you're reflecting on today's discussions in case anything is missed. We're just having a reflection on the same, then we'll relay the information. So the question that we're reflecting is in the conversations we've had. What can we do better? What can we propose as a way forward so that there'll be people in the rooms. They'll jot down whatever is not captured. They also take their emails in case they are burning questions. I'd like to appreciate those who are online. Those who are in Oak Room is one room together with those who are online. Please don't leave. You will be having Anita Musianga who will be doing the reflections with you. Those in Oak Room, that's at the business school basement, together with those who have dialed in online. Then we have 3 rooms. We have this room. We have 2 rooms, one next to the auditorium and one upstairs. So as we had said, so this row, you'll go to this first room here. This second row, you'll go to the second upstairs room. This other one, you remain here. That I hope is clear. The left side. So those who will remain, who will go to COP room, will have Mr. Oludare giving the reflection. Those at GK room, which is upstairs, will have Wangari Nganga. Those at auditorium here, you'll have Dr. Liza Nyawira, who will remain with this group that is side. So I'd request this group to kindly wake up and move to the next room. The second room, go upstairs to GK room. The rest remain here. Online, we have somebody who's coming to engage you with the other online guys who are at Oak Room.
That's the main, yeah.
So the rest you can move forward so that we have an insightful discussion ahead. Yes? These people didn't get you. No, you just changed it a bit.
May I request for help?
Yes.
I want to talk to Moses.
Mosulu.
Oh, I've seen him.
All right. Please start because people will start going.
Hi, everyone. Do you want to move in front so that we are closer? So I asked for guys to move in front.
Those who are here?
Yeah. So we're in 3 groups. We are staying here. We are just discussing the same things but in different groups.
The others have gone to another group.
Yes. Where were you today? So I think we are going upstairs. Yes. Good afternoon, everyone. How are you? So now we are doing that in a more focused way. It's the same conversation, okay? So we are looking at revenue mobilization and risk pooling. And I have a number of points or questions that I would like us to discuss. So it's going to be a very interactive process. I think I'll just, my name is Liza Nyawera, if I didn't introduce myself. So I'm going to pose the questions and then I'll let you guys guide the discussions. Once we are done, I'll give a report back at plenary on what we've discussed. That's okay? Sorry, I'm just looking. So the first point of reflection is, what are we doing in terms of risk pooling, and is that the best that we could do? So who wants to go first in that reflection? Where are we in terms of risk pooling arrangements, and is that the best that we could do? Maybe you could just introduce yourself when you have the microphone. Thank you.
Thanks, Lisa. My name is Anne Musuva from Thinkwell. And apologies, I'll be running away. I have another meeting at some point, so I just wanted to go fast. I think, honestly, this is one of the areas that still requires considerable work if you look at the different health financing functions. So I think we've made great strides in terms of increasing the amount of funds that we are allocating to healthcare. But in terms of pooling, just from what we saw, just from NHIF alone, for example, we have over 70, 80 schemes. And all of these schemes need different people to manage, administer, and so on. So just even within NHIF alone, I think there's a lot of room for bringing together all these fragmented schemes. There's EduAfya, there's Linda Mama, there's HISP, there's Inua Jamii. There are tons of schemes. And so I think even just within NHIF alone, I think that would be a great starting point. How can we consolidate all these schemes to make sure that we have a bigger scheme, and that also it's much more diverse. Now, at the county level as well, there are a number of counties that have come up with their own schemes. Makueni is one of them. I think the other counties are also coming up with their own sort of schemes. And so I think while the attempt at increasing coverage of their populations is great, unfortunately, these still end up being sort of small, further fragmented schemes and so on. And so we really need to have discussions about how we can consolidate these county and national schemes. Like, for example, I think what Kisumu is doing is a step in the right direction, where you have the Mara Care, but it's still under NHIF. So I think there's a lot of room still to consolidate all these schemes. Over.
Thank you, Anne. Do you have anyone from NHIF here? Okay, so I would just like you to give a quick commentary on where we are in terms of trying to consolidate the schemes within NHIF. Is there any work that's going on around that?
Thank you. My name is Mbai from NHIF. I'm in Beneficiary Management Department. So far, there are discussions in that line, but currently we have, as you are aware, we get our revenue from the formal sector, and that is the employed, the ones who work in formal employment, and then also the formal employment, and that is what we get from the Chuakali sector, and those who are not employed formally, that is the 500 a month. And also now we have got some revenue from the National UHC scheme. As you are aware, the national government last year, I think sometime around November last year, they passed some money that was approved. That was 6 billion shillings for the indigents who are identified by the counties. There's a proportion that was given. And also now we are also getting some revenue from some of the county governments that are partnered with us. I think it has been mentioned that is the Marwa scheme, that is Kisumu. It's about 42,000 members. We also have some from the Lamu County, 20,000 households. And then, of course, we have some donor funding from AMPATH. That is AMPATH, there's AMPATH Eldoret. They also have support program in Busia. And also from the NGCDF, that is the national government CDF. We have one in Changamwe. We also have one in Nyali, Ikolomani, and South Mugirango, among others. And of course, that convention about consolidating them comes in because some of them is an initiative. If you look at some of the proposal, I think there's an act or a regulation in the national county CDF, national government CDF, where they're allowed to spend a fraction of their resources towards health. And towards this, some of the counties, some of the national government CDF, that's why we have the Shangamu and the rest. They've used that provision to be able now to identify a few indigents within their counties to support. So I think I can stop with that unless there are other issues I can build later. Yeah, thank you.
Thank you, Mbai. It's Mbai, right? Yes. Okay. I think we've heard what is happening at NHIF so far to help with these fragmentation issues that we are talking about. Yes?
Sorry, I'd stepped out when she was making such a very pregnant point as far as this risk pooling is concerned. This is my opinion. We have a lot of money when it comes to the area of health, both from donor funding and also from local. So I think the creation of a different segment within the NHIF department, this is where the problem is, because you realize the allocation of those funds is encouraging the misuse of resources, and by extension, the corruption easily finds itself in. So if we were to have a one-stop shop of a NHIF and money allocated accordingly based on the need and accessibility, then you realize that whatever we need based on the revenue we collect and the amount going to the health, then it means it will be sustainable for all citizens. So if NHIF can be properly constituted and then maybe given the autonomy without any political interference, because that's where the problem is. Like I was surprised during the presentation that you find the private sector, which contributes 24%, when it comes to dispense of the money, they get almost 80% vis-a-vis the public sector. Yet we are all encouraging our people that when you are sick, the first stop where you can trust, go to the nearby public hospital. So how is it that the private, which is 24%, getting more allocation than the public? Then that means there's corruption somewhere there. That means there's misuse of resources. So I think leadership is required moving forward. And then number two, accountability is also required in that area. That means you need to get competent people who are ready to dispense and do what is required of them. I think we have enough money. All of us, we are citizens in this country. Some of us, for the past 20 years, we have been paying NHIF, but I don't remember, I've never used NHIF. So that means that money is there, and perhaps others also, that means there's excess of money, and that excess is what bringing these all privileges. Thank you very much.
Thanks. I didn't get your name again.
I'm Edwin Moses. From several sectors.
Okay. Anyone else wants to comment on that?
I just wanted to comment on what Edwin Moses said about, and this is a rare place where I'll actually be on NHIF's side, right? So my organization, ThinkWell, has done quite a bit of work with the various counties, looking at how they're participating in different NHIF schemes. And the participation in many counties is very poor. So I'll just give an example, for example, of the Linda Mama program. We've done an evaluation across about 10 counties that show that facilities only claim about 50 to 60% for Linda Mama services. Now, note that at level 2 and 3 facilities, they have already offered the services for free. So whether this is delivery services, antenatal care, postnatal care, all they need to do is claim. They are not claiming. But let me tell you, if you walk into any private facility, the first question you asked is, how are you paying? You know, it needs to be very clear, and you're not going to live there without having, you won't live there without them claiming if you're an NHIF patient and so on. Now, when you try to dig down into what are some of the reasons, there are a number of reasons. But one of the leading ones, and has been mentioned earlier here, is that facilities don't, some counties have not granted facilities autonomy to retain the funds that they generate, to retain them at facility level. So as a provider, what incentive do I have to put in all that work into claiming, you know, filling out all those NHI forms, and then the money disappears with the MCAs for benchmarking in Israel and wherever they go. So that's the number one reason, actually. But the others are smaller issues. You know, they don't have a photocopier to photocopy all those NHIF IDs and so on. So in my opinion, that's actually one of the main reasons that the funds have been sort of tilting more to the private sector. The other thing has been obviously that the reimbursement rates have been different between the public and the private sector. So you'll find, for example, for a delivery, a private facility will get double what the public facilities were getting, but that has now been harmonized in these new contracts issued this financial year moving forward. So I see a situation where that might actually tilt somewhat to the public sector. I just wanted to comment on that. It's not really related to what you're talking about.
Okay. For the fruitful discussions, let's keep the fire burning.
Oh, good afternoon. I'm Rono, print and medical doctor, and I'm sorry to take it to this direction. One, we want to believe that healthcare should be as a basic need for everyone, and so it shouldn't be, as much as it is, well, in this country, open to the market forces of, well, it's a capitalist country. Should we be looking and saying, what we have hasn't worked, but there are some countries where these are seem to work. I'll take it and look at it and say, social securities should be, in a way, a good form of Robin Hood. You take from those who don't have, and then you give it to those, you take it from those who have, and give it to those who don't have. But from what we've seen today, NHIF benefited more of those who are on premium packages than those who should actually be subsidized. So in essence, what happened here is, it was twisted, that the people at the bottom actually subsidized those at the top. And as we've seen today, that we have actually maxed out on the enrollment to NHIF of those people who should be subsidizing these others on the ground. But we really still want to keep improving this enrollment. What do we do from that point? And I think I would look at it in this. We had a discussion with a group, and we said, maybe then it's good that those 2% who are being covered by the private insurances, which is actually about 90% of the NHIF, should we say insurances, the private insurances should contribute part of their premium, say 30%, into their common public security fund, health fund in that matter.
Very, very interesting points there. So before anyone comments on that, maybe I'll just pose a question to you, because this is also a point we're supposed to discuss. Do you have any examples of any other countries or scenarios which have seemed to work in terms of these pooling arrangements?
Well, where this discussion happened is, it was in Germany, where, well, I was there for a short period of time. And what you see there is that all the people, everyone in Germany is covered, regardless of who you are. If you can't afford to pay, then the government pays for you. But the catch there is you all are enrolled onto the public insurance, but you can take an additional private insurance to add on top of what you have. And I think the discussion they were also having is how they can now use that in the private insurance to contribute to the public sector as well. Yeah, and maybe then we could also add that everything there is covered. I was in a pediatric oncology unit, and everything was covered for all those patients, including the fare for the taxi to bring them for their sessions. Yeah.
Wow, okay. As I'm bringing the mic to you, I want to pose this question and ask, do you believe that it is possible for us in Kenya, for the government to cover everybody, for everybody in the country to be covered under insurance? Is it a possibility?
I don't want to monopolize this discussion. I don't have monopoly as far as the knowledge in the line of academia is concerned. My senior is here, Dr. Mike. But I have two case studies which this has happened, and I've practically involved one with the other. Number one, all of you know about BRAC in Bangladesh. It's a similar system with our NHIF here, and it has been used globally, and it's the most successful story in that part of the world. So I encourage all of you, and during your free time, go read it, and with all we are discussing, compare with what is happening in our country. So why? It all goes about the leadership and also the vision as far as the primary health care for those countries are concerned. Recently, you had a discussion also in Cuba, and Cuba is simply, their system is based on strengthening the primary health care, and therefore the preventive measures is making Cuban government to ensure that every individual, wherever they are accessible to health, and it's quality, and they have surplus of doctors also. Now, look at our scenario. Our doctors, like now, even an intern, when is the last time they were paid? And then you devolve healthcare to counties. And in the counties, you leave healthcare system to be run by people who does not have any idea how health system operates. And they're the decision makers, they're the policy formulation, and they want also to be the policy implementers. That's where the problem is. So in my opinion, if you were to devolve health, then devolve it slowly by slowly until the county are well equipped to handle the issue of health. So we go back to the national. That will be number one answer. Number two, Ethiopian government, which have been privileged actually to participate when it's come under the Bill Belinda Gates funds. Recently, Kenyan government was to also enjoy these funds in terms of procurement supply chain in the procurement of healthcare system. Dr. Terry, she's not here, but I like what she's doing. It was unfortunate that you realize that how do you, okay, fine, you have a team which is qualified as far as procurement area is concerned. But procurement in healthcare is totally different in general procurement, guys. And yet these are the people who are running KEMSA down there. So tell me, when I see presentation that a place like Kisii or Nyakiancha or a place like Kisumu does not have drugs, I know where the problem is. Because do they understand how health system operate and how those products they are talking about can be delivered and the turnaround time? So I think all this we are discussing here, the solution we have, the problem is the goodwill. And goodwill both in terms of political goodwill and then in terms of the proper leadership to do what is right and what is rightful. Finally, as I conclude, why are we forgetting in this discussion of NHIF the place and the space for doctors, especially the low-cadre doctors, the MO, the registers, and the CEO, the clinical officers, who are the point of care for this patient before you transition them to the consultants. Now, when we talk of NHIF, where do we place them? And do we appreciate that they have a role to play as far as dispensing the health to the larger population is concerned? We all know it's true, isn't it? So why is it so difficult? It's so difficult because, again, we go back to people who are running the healthcare system in this country. Some of them stopped practicing 10 years ago, and by virtue they were doctors, now they find themselves in the board. They don't know even the latest technology, the latest idea, the digital world we are living in. But they are the decision makers, so they use the traditional way of making decisions to affect the young doctors. And the young doctors are frustrated. If you're a doctor and you're frustrated, surely, will you have time with your patient? And by extension, will you have quality? And what happened now to the pharmacy when it comes to dispensing? You'll be surprised, even including the dosage, including the medicine, which is being dispensed at the pharmacy level. You'll be shocked that the technicals are here. They will agree with me on this one. So I think let's not forget about the doctors in this discussion of NHIF thing. Let's not forget about the healthcare providers in this discussion of pooling. And therefore, we move as a team, and therefore, we are able to get the solution amongst ourselves. That's my submission. Let me hand over this. Sorry, Chairman.
Thank you so much. I'm called Emmanuel Oloka. I work with American Society of Clinical Pathology. I would like to take this opportunity to comment on a few things. Number one, as a question, we've talked about efficiency, effectiveness, and you know, there's really, I think we really have a big problem there when it comes to service delivery in Africa. We need to look at that very well. And the big gap and questions being risen today on those areas is that we've not looked at how do we measure our efficiency and how do we measure our effectiveness with service delivery. In every area, you know, NHIF and you know, talk about the pooling and how do we measure? How do we measure so that we can say this year we did a little poorly, we have improved, and you know, there is a trend that can be tracked that we're getting more effective and getting more efficient in attaining what we really want to attain. And then the other issue is I think that we need, like for instance, we talk about NHIF, who regulates? Who is the regulator? You know, is it regulated? Who checks? Where are the checks and balances? We need to really make sure we look into that, because without checks, it's easy for these funds to just keep flowing wherever it is going. And you know, of course, looking at policies are written, but policies can be defied, unless if there's someone who is regulating and saying, I think we're going outside the policy. And then we also need to look at issues to do with appropriations. How are the appropriations done? You know, what is appropriated where? If we have clear appropriations done of the fund, then it is easier for us to track, and it is easier for us to give a clear accountability of how the funds are being used. Thank you so much.
Thanks. I'm coming to you. I would like Bai to respond on regulation of NHIF. What checks and balances do we have?
Well, I think the issues of checks and balances, that is not my purview. Though I think that it should be MOH. But what I'd just like to point across, there was an issue that was raised regarding the preference to pay private hospitals vis-a-vis public hospitals. I happened to work in Rift Valley region for about 4 years. And we used to move around just to see, in terms of efficiencies, how are these facilities, public hospitals, reimbursed? And one thing that we discovered was, it is the issue of claiming. Like I can tell you for free, for those who are here who are doctors and who are in private practice, you realize most private hospitals have actually assigned an RM, just the way banks have an RM for different sectors. So that this person is the one who ensures that there's the documentation done correctly and then submitted. Remember that NHIF, for you to make a claim, there are certain requirements. There's a copy of an ID of the member, there is the case notes, all these things that are supposed now to be attached. So you see, if these are not done in time, and the issue comes to incentives, you find that the public also don't claim in time. I'll give an example. We worked closely with Nakuru County. And Nakuru County currently, by the last report we did, the Nakuru PGH. Nakuru PGH gets the highest reimbursements, even in terms of inpatient and in terms of even capitation. And remember, capitation is a member chooses through a mobile platform. Capitation doesn't mean that it will force you to go to a facility. And remember, it's every 3 months. You can opt in or opt out. So you can imagine now a patient in Nakuru opting to leave the some of the private hospitals and choosing Nakuru PGH because of the sub kind of services. What Nakuru County did, they established an office within PGH whereby they put on staff. I think to me, what I remember the last time I was there, they put young people who are tech savvy just to ensure that all those claims that are coming from the facilities are verified and they are batched together nicely, and even we built capacity from the Nakuru branch to ensure that they're actually submitting claims. That actually ensures that they are getting the highest reimbursements currently. And also, I'm not very conversant, but I know they passed a bill whereby that the funds for that are coming through the PGH are actually utilized within, I think there's something called an FIF bill within the county, so that those monies are utilized within PGH. So the issue of reimbursements come in terms of how issues are in terms of actually claiming. Another example is MTRH. They've done the same thing. Recently, they gave NHIF some space just to have an office, so that when you have an issue with the MTRH, you, instead of going to the branch in KTDA, which is in town, there's an office within the MTRH where all your issues about NHIF can be sorted. So for me, I believe the issue of just building capacity. And remember, right now we put an e-claim system. We have a seamless system. We use biometrics. We have a system. So it's basically the issue of just claiming. And that's what I'm saying. Let us go back to, in terms of efficiency, how do we look at these issues of claiming? Now, what else? I think those are the areas. Yeah.
For now, if we'll have time, I think if you remember something, you can still add on to that.
Yeah, thank you so much. My name is Rhoda, and I would like to say that NHIF has improved since it changed its name to Health. Yes, so if you draw back to the 2000s, you'll realize that NHIF was like very low in terms of even advocacy in the community, but currently NHIF and making it compulsory for most of the members to have it has really improved. However, I feel that NHIF should really invest more on advocacy, especially in the community level. The first presenter in the morning on NHIF covered some points, very important points, and said that NHIF supports the vulnerable in the community where it covers 100% of their hospital cover. And I was really like, have I ever seen this? Is it true? Is it true on the ground? I've really never seen this. I work in a hospital, a referral hospital, and any disabled person covers their health, like they register with NHIF just like any other. So is it true? And does the community people know? Is everyone in the country aware that NHIF can cover your cost of care if you are disabled? And for the issue of 18 and above, for those who are studying, I think it's also not clear to the university students whether the parents can still cover them up to the age of 21 or so. And I was for the opinion, since personally, as well, I use a private cover and an NHIF, but I've never used NHIF cover. And I was for the opinion that can NHIF give us the mandate to maybe fund somebody else using our own NHIF? For instance, fund maybe an old grandmother in my village, or perhaps maybe contribute to someone else who is not able to contribute, so that we don't have like Moses and eyes cover going on waste. Can it be made public so that in case your NHIF cover has never been used, can it be contributed to somebody else so that it is effective in that order? And Moses also talked about a very important point, that it is possible in this country to cover everybody, and it is possible to have a very effective healthcare system. The reason we are not where we want to be is because of the people who have been put to head, the leadership in healthcare. The leadership in healthcare is a total problem. It's a mess in this country. I'm not saying everybody in healthcare, but if you check keenly on who is the HR, who is the who in healthcare, you realize that doctors, every healthcare worker is not taken care of this the way they should be taken care of. I worked in Seychelles for some time, managing COVID-19. And I realized that healthcare in Seychelles is free for any Seychellois, like any citizen. Healthcare is free. There is nowhere they contribute to. They just use the revenue to cover the health. But if you check the healthcare workers, they're also very well taken care of, because you'll always associate a free thing to maybe a failure in the professionalism. But the professionals are well taken care of. They report to work on time. They are motivated on time. They celebrate each and every achievement, each and every small achievement. The country runs very smoothly. It's only if you are a foreigner that you really need to pay. And their healthcare systems are really great. Public centers have, like, it was the first country that I realized every primary school has a public health officer. Yeah? And every primary school has a nurse. Yeah? And primary health care there is well taken care of, and you don't see anyone paying. And I was like, what can we do better? It is the leadership, and we need to do something on the leadership. Let's employ the right people. Let's consult with the right people. Yeah, and our country will really go far. And NHIF, kudos, but you can do better.
Thanks a lot, Rhoda. Before I come to you, Boniface, what was I going to say? I've forgotten. I will remember. May I start here? Then I come to you. Thank you.
Thank you so much. Mine will be a bit short but broader. This concept. The elephant in the room is UHC. On equity, the private sector is believed to be taking 24-26% of the payment, whereas the government takes about 70-76%. When it comes to investment, the controller of healthcare in Kenya is actually the private sector. Over 60% of the so-called level 5 and level 6 in this country are actually based or built on brick and mortar. If you do a clinical audit on the so-called level 5 and 6, they do not meet that threshold. So then the question would be, with that basic gap, and in absence of engagement with the private sector, who are playing the main role and who will play the cardinal role in the success of the rollout of the UHC, which plans do we have, or which plans NHIF putting in place to make sure that the clinical infrastructure through public-private partnership is enhanced, establishments are properly done in those hospitals. I would wish to paint a picture in the neighboring county, 2 counties of Ukambani. There's a county in Ukambani that has 1 level 5 hospital, the rest are level 3. And if you do an audit from clinical infrastructure to HR establishment, there's nothing really that can anchor the so-called UHC. So for us to address the UHC success, rollout and success, we need to broaden this discussion and give it an holistic approach. The discussions that we are having here, at times I feel that they are boardroom discussions. I'm overseeing hospitals spread across 9 counties. I've been in healthcare for the last 17 years, both in Kenya and out of Kenya. I've visited nearly all counties. That which is being experienced down there is in conflict with the so-called proposed UHC and the rollout. And that as we discuss, so that we come up with modalities that will facilitate the enrollment of this and the success of the UHC, we need to take stock, right from the NHIF. We need to take stock. An example of that would be on the scheme administrations. Hospitals, for example, private hospital entities, are not allowed to handle some of the cases, for example, because of the categories. They are then directed that this patient X diagnosed with this should be referred to a government hospital. In that government hospital, there's no clinical infrastructure to cover this. There's no personnel. Personnel actually will be hired again through locum arrangement from a private entity. So at times, with your permission and indulgence, I feel that it is true to say that until we get our act right, until we get out of the boardrooms and go to the field to go and actually make it done, UHC will still experience these challenges on the rollout. Because yes, on the equity and amounts being paid, private entities are receiving much. In sub-Saharan Africa, there's no government that has invested much in UHC and in cover and in offering healthcare to its citizenry. We are trying to copy-paste what is happening in Rwanda, but there's too much, they say that politics and development are intertwined. By the time we learn and separate this, politicians to politic, technocrats to be allowed to do their jobs, we'll still be meeting to discuss. And so this, from where I sit, will be a continuous discussion, not unless we roll up our sleeves and just get out to the field to go work and have it done. But there are a lot of challenges out there, a lot. From establishments, that is HR establishment, capacity building, to clinical infrastructure. The level 5 in conclusion, level 5s in the counties, level 6, all those hospitals were elevated politically. There was no clinical audit that then anchors the so-called level 5s and 6. They are not there. They are politically instigated, they are politically anchored, and as such, are we then saying that with this political anchorage, the UHC will be a success? Point to be taken home, perhaps to be answered tomorrow. Thank you. I'm Maurice Kana. I'm a health system management consultant. I also sit at the board of 4 hospitals, which I'm sorry I won't name. Thank you.
Thank you, thank you. As I give the mic to Boniface, I would like us to reflect on one thing. When we talk about pooling, is NHIF or is insurance the only way that funds are pooled? And yeah, we need to have a broader discussion. Thank you.
Thanks. My name is Boniface Mbudia. I work for ThinkWell. I just want to make a contribution about, the pools. One thing that we must start our discussion at is we do have many pools within our country. And the real question we need to ask ourselves about each of these pools is, do these pools, are they oriented to be able to take care of the poor in our society? So for example, the county governments now have about 130 billion. But how much of that actually goes to take care of those who are very poor in our society? That's the real question, because sometimes it goes to build, it goes to brick and mortar and doesn't go to take care of the very poor. And that would still speak to the pools that are within the Ministry of Health, even those that are in the private sector and so on. The second thing that's also important is for us to know that with the kind of pools that we have, we must align those pools to meet the health needs of our people, so that we can begin to maximize them to ensure that we can have better benefits for the people of our country. The third thing that is also important is to say that when we have this universal health coverage conversation, I think we need to also look at it from a more simpler, approach. For example, after the 2019 census, the Ministry of Health estimated that for us to be able to cover everyone in the country, we needed only about 84 billion shillings. And that's money we can be able to raise. It's possible for us to raise 84 billion. And out of that 84 billion, we'll probably cover those who cannot be able to cover, because those who are already in the cover would continue being in the cover. And our system will not wait for some things to be okay for us to be able to move. So we'll probably move as we go. So like, I'm opposed to the discussion that says that we have to reform our system for it to be perfect and then we give them the resources. That might never happen. The truth is, even the UK system is not perfect. When you go to Australia, it's not perfect. Even when you go to Germany, it's not perfect. But they are able to work with it the way it is, but with a goal in mind. And those are some of the things we need to be able to bring into our system. The fifth thing is to look through at NHIF and note that we have made some progress, but we can still do more. Because, in the early 2000s, I think NHIF used to have only close to about 10 million shillings per year. And now they have gotten to 60 billion. The key question we should be asking ourselves from the 60 billion is, how well is this 60 billion aligned to help us meet our national health goals? So that NHIF does not pride itself on how much millions it has paid, but how much health it's been able to buy. So that the conversation moves from payment of claims to purchasing of services. And I think a lot of these discussions we should be able to continue having. The last thing is for us to all remember that it's good that we have medical covers. It's good that we are covered. But it's good to remember that there are many people in our society who do not have that privilege. And we need to be able to remember that for us to be able to achieve universal health coverage, it will largely be done through public funds. And so the question is, how do we ensure that public funds that are available within existing pools can be able to cover more people within our setup, especially those who are poor and vulnerable, so that we stop this discussion of being excited about roads and people cannot be able to go to hospital. Being excited about tall buildings and people cannot be able to get the basics of healthcare. Because every day, the citizens are demanding of better healthcare. But we have a fair level of resources that can be able to begin to meet some of those needs. So we need to begin to have the conversation that helps the resources we have to meet the needs that we have. Even if we are going to start at 50%, but we need to be able to start that conversation.
Thanks, Boniface. Okay, hi, Irene.
Good afternoon. My name is Irene Tanyai. I'm a clinical officer, but also I'm a student, health economics student at the University of Nairobi. I'm always bothered by the fact that I come from a community where I feel NHIF is less known, that is Narok County. And I'm thinking it's not like it can't afford, but are they aware that health insurance could be of benefit to them? So this is a question to NHIF. Do we get to Mashinani, the rural areas, to educate the residents of the benefits of the health insurance? because they may not get the money monthly like most of us who are employed, but sure they can have money after harvest season. For those guys working in the market, they won't mind paying a 20 bob, because 20 times 30, that would be 600, amounting to the minimum contribution of 500. So I'm thinking, do we have the education to the guys in the rural areas especially? Because I'm aware those in the urban settings, they could be aware because of the nature of where they are located. But I'm thinking of that person in Turkana, Samburu, Narok County, who may not have access to media. Are we able to reach them and tell them the importance of health insurance? Also, on KEF, the gentleman who commented on the KEF levels in this country, I'm thinking because of the capitation, the private sector is taking it as a way of minting money, but not necessarily giving quality services to the citizen. So for anyone who is sitting in that board, I think there should be review on the KEF levels of these facilities, especially the private. They would say they are maternity, but they're in a very dark place. You can't imagine getting health services as a person. But we are the guys to go out and help protect the vulnerable, because that's where they'll go and seek health. And sometimes it may not be the quality of care needed. Thank you.
Thank you, thank you, thank you. I think most of us have had a chance to talk. Anba?
Good afternoon, everyone. For me, it's been a pleasure to listen to all the conversations, but I want to take us back to the actual question of what are we doing to risk pool and can we do better? Currently, I think less than 20% of Kenyans are insured. So that tells us that we are very far from pooling our resources and protecting each other from the catastrophic expenditure of health. 80% of us are definitely going to fall into poverty if we are faced with the health expenditure. Another thing we need to look at is even those of us who are actually insured, are we able to use this insurance to protect ourselves from the expenses of health? And that is a broader discussion, because sometimes you're insured, but you can't access the healthcare where you live and where you need it. So again, you're forced to move out of where you live, where you work, search for healthcare, and maybe sometimes it's too late. So those are some of the conversations we need to also have in terms of risk pooling. Yeah, thank you.
Thanks, Anbar. I think I'll start with this hand because I saw it first.
Thank you. My name is Rachel Ndunga from Fibroid Center, and I work with women of reproductive age. We create awareness around fibroids and connect them to gynecologists. And one of the challenge has been access to treatment because of affordability. And a few times I've spoken to NHIF on how we can collaborate. We don't mind building a pool or belonging to your pool and bringing these women together, mobilizing them to sign up with NHIF or to make the regular contributions. So we'll be very happy if you're open to that sort of discussion. I still believe NHIF can implement the universal health coverage. I think it's best placed. But maybe with partnerships and collaborations with some of us who are on the ground, with your members, may help. Yeah, so I'll be happy to continue with this discussion after this. Thank you.
Thanks, Rachel. I think we have a representative from NHIF here. You could carry on the discussions after this. Thank you.
Thank you very much. Just a few pointers, and really just existing within our context. The reality is, and I think Edwin mentioned this, decrying the pain of the caliber of politicians or leaders that we have. The reality is, they are the ones that the populace have elected, and they are the ones who are actually running health at the county level and at the national level. So it would be an effort in futility to want to engage in reforms and leave them behind. So we must, if we really must see progress, engage and align to a great extent. Because the reality is they are the ones who determine the resources you get, the approvals for the funding that you get, the policy priorities. It's important that we appreciate that. The other bit is appreciating still the fact that even as we're having a conversation around health and the finances available to health, the resources that are available to health for that pooling that we are conversing around span beyond health. So appreciating that there is a greater universe beyond health that determines the resources that are available to health, and therefore to the health priorities becomes important. The other bit is appreciating still the context that we are in. There was a mention around Seychelles, a mention around Germany. Germany has a different context. The level of formal employment is significant, and therefore how they pool is through what they call sick funds. So payroll deductions. In our context, that may not be very feasible, in as much as that is what the current dispensation is trying to advance. Yeah? But you will still notice, even within Rwanda, in as much as they have their community-based health insurance schemes, that largely you have government having an eye on those who are vulnerable and ensuring that they are still covered. And looking at our context still, and Boniface mentioned this, if the aim is ensuring improved health outcomes, improved health, then looking at the costs and the cost drivers within our context, and the numbers that we have is that really, in terms of utilization of care, outpatient, 56% is public sector, 32% private sector. That's the Kenya Household Health Expenditure Utilization Survey, 2018. If you're looking at inpatient care, 60% is a public sector. What that tells us is that the private sector plays a critical role, but we cannot ignore the public sector. And in view of the resources that are available within our context, then the public sector becomes a more efficient or a more affordable approach, and that becomes important. Again, still on context, Germany looking at their GDP, as it were. You know, most of the other countries will not look at, they will do cost effectiveness analysis. There was a conversation in the morning, not a boardroom conversation, around health technology assessments. You know, and for most, the clincher is the cost effectiveness thresholds. For Germany, because of their GDP, cost is not an issue. For them, their consideration is efficiency. So that tells you that we have a journey to make as a country, yeah, in terms of mobilizing and growing our economy, but also ensuring that we are looking beyond just health, because otherwise, as someone mentioned earlier on, we'll be speaking to ourselves a lot. This conversation about health and resources and pooling goes beyond health, because the drivers of the inequality and inequity that pooling seeks to address are in education, they are in income and trade and the economy. So if you're looking at health alone, then we will miss the point. Thank you.
Wow, thank you. Thank you, Dr. Mulongo. I think we gave a few examples of countries that have done well. We've mentioned Germany, Seychelles, Rwanda. Keep the examples coming. But I posed a question and asked, we've talked about NHIF. Are there any other ways that we are able to pool funds, or is it just one way, and that's the insurance way?
This is my opinion. If you want to get it right, then what we do, we have a proper leadership in place, and then we encourage private investors and the private sectors to thrive, and then they create more funds in terms of employment opportunities. And then you, government of the day, tax the private sector. And then the money you generate from that, plus the in-money collection, pump into the healthcare. So what you do is, as a government, you reduce the corruption at the procurement level. So you don't procure a machine which there's no technician to use it down there, maybe in Turkana or somewhere in the interior there, simply because there was 10%, but you go by need basis. So the need basis here will sort the issue of misuse of funds and also misappropriation of resources. And more importantly, and I agree with my senior, that the so-called level 4, level 5, indeed, those hospitals, if you have been there and you are in this country, you'll agree with me. they are nowhere within level 5 and level 6. So that's the only way, at least, because private sector play a critical role. And actually government, most of the established systems, they thrive on the money generated from the private sector and then utilization of those funds in channeling them to every sector which is required to be utilized properly. But that one has to be deal with the giant in the room, which is the corruption. But corruption, that's a subject which is beyond us. Maybe it's system-based. Thank you.
Just to further contribute is we do have other polls, we do have other mechanisms. There are community-based insurance schemes. There are households ways of promoting social protection. However, why NHIF becomes a bigger conversation is because of the level of investment that has been done over the years and the capacities that have been built over time. There's a time NHIF only used to pay the bed charges. And so when they would pay £1 million shillings per year to health facilities, that was like almost insignificant to the growing health costs. But when the benefit packages were reviewed and more benefits were brought in, the significance of NHIF in that conversation became very clear, particularly with the increase of these chronic illnesses like cancer, renal dialysis. So you see, you need a reliable pool that you can be able to draw from at that hour of need, and then NHIF becomes that more reliable pool. And why we need to be able to try and walk through this path is because if we can be able to continue improving the capacity of this pool and ensure that we can put our eyes on the poor and vulnerable, so that we are not only discussing about the benefits that are available to a few people, but rather ensure that we are able to reach to the larger population, ensure that we can have a reasonable cover, and then we can be able to also input in other required efficiencies that will help to be able to stretch these resources. Then that becomes an important factor. The second thing that is important is when we look at our current resources that are available to county governments, we notice that the amount of money available to county governments has increased and even surpassed what the Ministry of Health currently holds. But the question of efficiency now comes in, because does having more money for the health sector at the county level, has it translated to better coverage for the poor? That remains still a question that is out there. And that means we need to be careful that every time we talk about improving our pools, we must retain our eyes on the poor and vulnerable, because that is the measure that we can be able to tell whether our pool is serving the right purpose or not. Otherwise, it's possible to have a pool that only takes care of the rich and the well-to-do. And that's what NHIF was before we got to a point where they started to have other schemes that were specifically taking care of the poor. Because the pool that was available was only for those who were in employment, and we were comfortable as a society. And that's why we could not increase the coverage beyond 20%. So because what essentially it means is that when you are in employment, you're in that pool. Once you are out of employment, you are out of it. And the person who has replaced you replaces you in the pool. So you continue with your 20%. But the truth is we cannot achieve universal health coverage that way. We can only achieve universal health coverage when we begin to say how much of our resources are being dedicated to ensure that we meet the health needs of the poor and the vulnerable?
Great, thanks, Boniface. So I'm coming to you. We have many schemes within NHIF. We've talked about them. We have EdWAF here, we have Linda Mama, and so on and so forth. And we are talking about consolidation of pools. Let's talk about the political feasibility of doing this, because if we say we are going to abolish some of these schemes or put them together, it has an implication. So do we want to comment about the political correctness of this kind of decisions? Thank you. That is food for thought.
Thank you. Just very briefly, I was thinking about the faith-based organizations and NGOs that the government can take advantage of. Maybe they can support programs, healthcare programs through NHIF, just closely and in linkage to UHC. Maybe the government can take advantage of funding from faith-based organizations and NGOs, from global. I remember there was a time, was it WHO supporting malaria? Like malaria treatment for free. So such cases, maybe they can now regulate them, bring them on board, but regulate them, and they should go maybe through NHIF so that we have a proper healthcare system.
Thanks.
I wish that we're having these conversations when we have figures, like a report, so that we're discussing something that has got, figures attached, and it's very easy to, outline on how we can go about playing with the surpluses. Now, in the morning we had a presentation where we had percentages given for formal sector as 19% of the population, informal sector 80%, and then we had the poor 36%. Now, you realize that maybe the formal sector, not maybe, the formal sector is able to contribute to the fund. And then informal sector also will be able to contribute to the fund. Now, the 36%, and that's the poor, are the ones who are really, really in need of, an input. And I think that looking at this and looking at the percentage of the figures at hand, we should be able to know how much project and know how much is needed for the poor in order to cover them. And then we can be able to look at, strategies of fundraising in that particular area of a problem. And I think that there are strategies. There's room to be able to contribute to 36% of the population. And maybe, like it's been said already, the NGOs and even just public campaigns, fundraising campaigns, to contribute towards this fund. If it is well justified, I think that some people can be able to put money into this, and at the end of the day, we will be able to cover the 36% of the population. Thank you.
Thanks. So I'll ask this question maybe to Mike. I'm a health economist, but I get a bit, confused on some of these issues. So would it be prudent for us to focus on covering the 36% poor and vulnerable that we're talking about, because the others who are not in the 36% have ability to kind of take care of themselves? Or is it prudent to focus on just covering everyone?
So the ideal would be to move with everyone. That's the rallying call of universal healthcare. Leave no one behind. The key thing would be to move with everyone, but appreciate that everyone has different needs, and there are those who have different capacities or different things that hinder them from accessing that need. So the ideal would actually be to ensure that everyone is covered. The reality is that even in the best of contexts, that doesn't happen, but the reality is, to a great extent, the greatest need, as in for you to move together, that need of that person who is most vulnerable must be covered, so that then the rest are adjustments. That is what I would say.
Thanks.
In the context of political goodwill, this is the challenge we are likely to face. Number one is that the status of the citizen, politicians, that is their area of thriving. Because if you empower them in terms of the health care, and therefore they are sustained and they have a psyche in terms of the mental, then chances are very high you'll start questioning them. You start interrogating the manifesto they bring to you, and you are likely not to be on their side. So this is a tool they use to manipulate the entire citizenship when it comes to election. So to get it right is that to persuade them. We need to persuade them through the leadership of NHIF. When you sit with them in the boardroom, just use the persuasion kind of leadership to make them understand that you still need these people to be more productive, to give more birth, so that your kids who want to be politicians, they will still have votes, people to vote for them. But without persuading them, I can tell you that's a tool they're using. Even if you look at their manifesto, the last recent election, look at how much they promise us they are going to do as far as improving the health care under the UHC is concerned. Some of them even narrow it down and say 5 years is such a long time, they only need 100 days, isn't it? Now we are almost approaching 100 days. Have you seen any element or any sign that they are likely to achieve this? The answer is no. So my request is, let's just persuade them, because that's a tool they're using against us. So if we confront them with this reality that they empower people under the UHC, and those people are able to be more productive and start questioning and interrogating what they tell them, they know very well these people will be more empowered in that. So we use the persuasion to persuade them so that they take it up. The good thing with them, like today in this forum, if you are to tell them that this forum is such an important forum discussing the future of the country, you are giving them per diem. I can assure you, they will be here, they will be occupying this space. But since this was an open discussion, where are they? They are not here with you. And remember, they're the ones sitting in the county government, they're the ones sitting in the national government, they're the ones making us, we are just discussing. But them, they're the ones forming the policy, they're the ones going to ensure that those policies are implemented. So we just need to incentivize them in another way under the boardroom structure to help them have the bigger picture for the sake of our nation. We have enough. I'm persuaded we don't need, there's a lot of money, and every citizen of this country, all these sectors you see coming in Nyawira, they're coming here to make money. They're not giving you money for free. She is here, Mr. Granani, will tell you that all the money they pump here, there's nowhere in the world money is given for free, guys. Kenyans, let's get this. Even your own brother and your own sister. I started giving you money for free. Go behind me and ask, why is he giving me money for free? There's a piece of land, there's like a plot somewhere. I want to persuade you to sign that document so that we can sell. So there's nowhere in the world that an NGO or any other person will come to this country and tell you, we are here to help you improve your health care. No, they are using the loopholes within our health system and our porous policy to get something in terms of return. But we can partnership with them. They can give us their expertise. We can collaborate. Through collaboration, we are able to achieve this UHC. We are not saying we don't need it. We need them because they have the money. They have the expertise in those areas. But our politicians, guys who are meeting them in the boardroom, Dr. Mike, if you happen to meet them in the boardroom, please persuade them that this health thing is such a big thing for us as a nation. Thank you.
Thank you very much. And I think Dr. Mike is very good at persuasion. And what we're saying is that we need to involve the political class in these discussions. Otherwise...
And just to add, the reality about the value of politics is this. There's no policy that we will ever pass that will not require a politician to either sign off or participate in its formation. And the way we have structured our constitution, politicians are, we cannot wish them away. We cannot run away from them. If we want to get access to any resources within the public system, there will be a politician on the other side of the discussion. Now, politicians, when it comes to things like health, they desire to improve health, but they have a wrong way of doing it. So I think what we need to keep endeavoring is how we interlock our technical inputs and the opportunities that exist within the political space. If we look at countries like UK, and we can use UK as an example, the development of NHS was not necessarily a political system, but it had to get the political backing to have its existence and to have access to resources from the government. And it's the same thing, NHIF and all these good things that we are discussing here today do require to interplay with political interactions, because that's the only way we are then going to translate our desire into reality. Otherwise, we will talk to ourselves until the cows come home.
And we don't want to talk to ourselves until the cows come home. So as we wrap up, we were supposed to have a plenary discussion and a report back after this, but in the interest of time, I'm told that that will not happen. So we shall just have a wrap up of these discussions here and call it a day. So I'd like to give anyone who hasn't spoken an opportunity. Anyone who wants to say something and they've not had a chance to speak?
So thanks a lot. I'm Dr. Elijah Matolo. I work with Old Mutual Health Insurance. I think there are a couple of things. We need to appreciate that at least half of the healthcare provision in this country is done by the counties. And the alignment of incentives within the counties is missing. The person on the other side, so number one, if you ask, why is it that the private healthcare facilities seem to be getting more money from NHIF? It's a known fact. The public facilities do not claim. This is someone you're giving extra work. They don't understand why they're doing it. Number one, if you talk to some of them, they'll tell you, you're forcing us to claim, and then this money is going to go into a CRF somewhere. So why should I do that? Money that goes to CRF, even if it's come from the health facilities, will almost usually, so it almost never comes back, or at least there's no way to demonstrate that that's the money that came back. So they don't have an incentive to claim. If they don't have an incentive to claim, then it becomes very difficult for that to happen. Even at the facility head level, they have no incentive for them to make sure their staff are claiming from NHIF. Yeah, it's not in their scorecard. No one is going to come and ask them, so how much did we claim? If you ask for a county to give you their NHIF data, you will struggle to get it. Actually, they don't track it, so it's not important. If you go to any private hospital, you'll find a room with young people who are just documenting claims. So that's how money comes into the facilities. So making sure that the facilities are aligned, and it starts all the way up to the top. Why would a governor want to ensure that everyone is claiming from the facilities? It doesn't seem like there's a very good reason for that to happen. Yeah, and even if you look at the leadership at the county level, they're also not incentivized in any way to make sure. So they'll complain, yes, there's no funding in health, but NHIF is a very good source of that revenue. Yeah, and that's on the one side, on the facility side, but also on the patients. If I have the option to go to a private facility where I am sure I'm going to get the drugs that I need. Yeah, so what sometimes happens is they'll go and see the doctor at the public facility for free. Then now they go to the private side and know at least there I'm going to get the drugs. Yeah, so there's really a lot that needs to be, to be fixed around how counties manage their healthcare systems. And including even partnering with the private health insurers. The counties just don't think that is an avenue open to them. You would actually beg them, and still, you hardly find that incentive for them to look at that as a viable option. So a lot of what we are discussing, even around healthcare financing, will really revolve around how well the counties will be able to use the available funds to deliver the health services to the populations within the respective counties. Yeah, and when talking about pools, I think the other bit is there are so many pools where an employer decides I'm funding healthcare for my staff. We don't know how much that fund is. probably we need to register or have some form of registration, hopefully without requiring, without a lot of red tape, so that people know that this is all the funds available. Large organizations running their own internal schemes, that won't be counted, or there's no direct way of counting it as part of the funds available within healthcare. So there are quite a bit of areas here and there, but I like the discussions. It's usually when people talk, that's when solutions start coming about, and let's make sure next time KEMSA is part of this discussion.
Dr. Matolo, so we've said about alignment of incentives. So far we've had some exemplar counties, for example, Nakuru or even Nyeri. You could give other examples where they've passed the FIF bill, where the facilities are allowed to retain the NHIF funds at the facility level, which incentivizes the facility to claim the money because they know they will be able to use this money. So any other person? Last, okay, let me just give Dr. Ian Odor, and then I can finish with you.
Okay, I'll just make a very brief comment. I'm Ian Odor, I'm a medical doctor, just recently graduated, so I speak on behalf of maybe the upcoming group, the young doctors. And I feel like conversations that we are having today, we really don't get to have such conversations in our schools, yeah? And part of maybe preparing the upcoming and junior guys so that these are not basically just for us that all conversations that we have at such high levels, but also to try and empower the upcoming generation. And looking also at healthcare, I think we need to start looking at healthcare as an investment and not so much as an expenditure. I think the perspective of the government is as though healthcare is something that is consuming, yeah? But from my thought, I think it should be something that is kind of like an investment. And I think the moment we define that and move from looking so much at what the government can do to the health facility as opposed to us ourselves owning up and really taking leadership at the lower level of our facilities to make them productive. I had an opportunity to train at MTRH, and I see maybe the kind of investment that they have put into the health facilities. It's probably even helping to finance the facility itself. You look at, if we come to the level where we ideally invest in our facilities, then we might not even come to a position where we now start talking about how do we finance, how do we do this if we invest in the structures. And then the issue of pooling, again, maybe we might have to look about issues around legislation. I think we can limit the number of these through legislations and even do audits and see how effective some of these things are so that we don't have just structures that are in place but really not benefiting. So that's my small contribution. Thank you.
Thank you very much. That's from a junior doctor in the system. We've had the thoughts. So I think I'll finish with Mr. Mbai from NHIF. Unless there's anyone else with a very pressing commentary, please keep it very short.
I'm just concerned about our discussions. I think when we're talking about healthcare here, we're focusing more on treatment and we're not looking at preventive. I think that in discussing this in the future, we need to focus on the preventive because then we'll have saved a lot of trouble, going into treatment. So yeah, that's just what I wanted to say. Thank you.
Very, very important. Once we focus on preventive healthcare, that has been shown to be more efficient for the health system.
Okay. My name is Shem Wayera. I come from Nyamira County. I'm talking about community health strengthening systems for the community-based organizations at the grassroots community level. Because at the county government, since the advent of devolution, there's a lot of bureaucracy and monopoly in the health sector. The governors are not doing their work, and there is inadequate civic education for the enhancement of NHIF. Mama huko nyumbani hawezi elewa the vocabulary you are talking here. So as I concur with my friend who said about the boardroom meetings, at the community level, there's nothing happening. Civic education should be there and at the focus to strengthen the primary health care through community-based organization. I'm representing the voice of the community through community-based organization from CPO movement and NGO cooperation. I remember the times of National AIDS Control Council, where we had the Total War Project against HIV/AIDS, AMREF Manisha, where we were funded at CPO, and we do adequate civic education at the grassroots. That's what should be strengthened and group strengthening for the mamas, youth, people, and even the general population. Because we cannot have those workshops at the national level, but at the community level, there's nothing taking place, and the governors are not minding. They are after per diem, getting money from the national level, the bureaucrats, there's no improvement for medics, there's nothing taking place. And I am requesting for even the health minister to be referred to the national level for more collaboration.
Thank you so much. So as we have said, we are not leaving the political class out of these discussions. It is also important to remember we should not leave the community out of these discussions. Very, very important. So finally, Mr. Mbai.
Yeah, thank you. I think mine will be very brief. I think I want to respond to some issues Irene raised regarding advocacy. We are trying to partner with other partners. There's AMREF, there's Farm Access, and also in the branch offices, we have satellite offices that are able to do that. Another one that an issue regarding the national government actually sponsored 1 million indigents, a scheme that is 6 billion, and the issue that I will be having mostly is identification of these indigents. How do the counties were given quotas, and they are told go out there, identify the poor of the poor. They have some tools they are supposed to use. They give us that data. We validate that data, and these people are identified. Unfortunately, the thing that because we have got a very elaborate system, was once when you're getting this data, we found out that some of these people are actually employed. They actually have other covers. So the issue boils back to how were they identified as the poor? Because that was their role. Our role was just to validate and ensure that they get the cover. So I think that is something that we're working on. Some of the data we gave it back, and then we're hoping that going forward, because actually the target of the government was actually to have 5 million identified poor who were identified by the National Bureau of Statistics as the poor. So we started with the 1 million and hoping to go to the 5 million mark that was there. And then I think those were the issues on pooling. We're also trying to work with the telcos so that at least we're able to have, I think somebody mentioned, I think you mentioned about why don't we, if you're not using your NHIF, how can that cover go to somebody else? I still give an analogy of a motor vehicle. If I have my insurance for a motor vehicle, I don't get an accident. Do I give my cover to somebody else? That is not possible. But what we're trying to do is that we're trying to look at possibilities whereby families can come together, contribute small monies through telcos. For example, you can use some small airtime that you have. When you're buying maybe your 250 airtime, you take 20 shillings, maybe your 5 brothers, the 100 shillings, you put it together, send it to a pool whereby NHF will be able to manage that, and then identify a beneficiary. So that beneficiary, after some period, will have the 500. We'll be able now to raise that money for them, because UHC is about everybody coming together. We have donors, we have the government, and we have got relatives. As I conclude, you realize I used to work in Eldoret, and one of the things that we used to get, I used to get a call when somebody is really sick, and then the first thing you ask them, can I give me your copy, give me the ID number. When I check in the system, they have never paid. And then they tell you, if I pay now, can I get the benefit immediately? Tell them there's a waiting period. So I think Kenyans don't yet appreciate the value of insurance, isn't it? Even I'm telling you, as I conclude, if for a motor vehicle, if it was not a must that we pay insurance for motor vehicle, I doubt whether any of us would have taken motor vehicle insurance. We'll say, nikigongwa, nitaenda kwa garage, nilipe. So it's the same thing. And what you're getting as NHIF, I think I was working with the Terry, Doc, and one thing we are realizing was adverse selection. If you look at the people who are paying NHIF voluntarily, either they have got some issue that they want NHIF to sort out. So they discover I've got an issue with the dialysis, I'll pay NHIF because I know NHIF will pay 18,000 per every week. That's about 1 million, isn't it? 1 million a year. But if I don't have a problem, I'll not pay NHIF. So the people you are getting who are paying voluntarily, most of them come when they are really in, then some issue. So you find that that cohort of patients really eat up on the pool that is there. So that's why we're encouraging, counties are sponsoring, by the way. I mentioned NGCDF, I mentioned Changamwe, Lamu, and the rest. So I think once we bring all these people together, we're able now to support these deserving indigents. I'll end it there. I'll give you back the mic. But I think I will get your contacts. There's something you mentioned about pulling together. I mentioned earlier on we have about SACCO that are coming together, the border associations. The other day we met with the hawkers in Nakuru. They came together as a group. It is easy when they come as a group and they pay as a, because it is easy to manage. Like Boda will come and tell you we have a group of 100 or 200 as a group. They say we'll pay the 500 from our coffers, and then we'll find mechanisms of collecting that money from our members, isn't it? So that way it's easy for us to offer them insurance as a group, and also even do the advocacy, the mobilization and all that. So we encourage those sort of groupings. And I think that is something I'll pick up immediately after this, so that you can actually have we normally do MOUs. We've done an MOU with the border associations. We've done with KTDA. In fact, there's a team out there right now working with the farmers. We are doing MOU with many other organizations that are coming. They're coming as a group and then wanting to be given insurance as a group. Yeah, so I think for that, we'll be able to pick and any other issue that that may come up. Thank you so much.
Thank you. We see there are collaborations that are already happening here. So we have said that to have the society or the community appreciate health insurance, we first need to enlighten them on how health insurance works. Secondly, we need to move from voluntary to mandatory health insurance. So to sum up everything, because we have said so many things and all of them are critical, I think the buck stops with the leadership, the buck stops with goodwill. So once we have sorted out our leadership issues and our goodwill issues, all the other things fit in within the system. I think with that, I will finish unless, yeah. Thank you to my group. You have been very engaging. Clap for yourselves. And I've enjoyed this discussion. I hope you have all enjoyed too. Thank you.
All right, thank you so much. Another round of applause, ladies and gentlemen. We could go on and on, but the discussions keep going, and the key word that has come out today is we keep on discussing, but we need to actualize them and ensure that we actualize what we are discussing. So at this point, I'd like to appreciate all the panelists who came in today from morning, all the discussions we've had, all the lively discussions we've had. I'd also like to appreciate our online audience who have been engaging all through. Thank you for logging in and for dialing in. I hope to see you tomorrow as well. I'd also like to appreciate all the physical attendees who came here today and joined us in the discussions. Tomorrow we'll pick it a notch higher and look into purchasing, followed by payer provider engagement and another roundtable as well to discuss what we'll do. I'd like to also appreciate our sponsors for this particular event, that's Farmer Access Group, Illumina, ThinkWell Global, NHIF, and also to appreciate Strathmore University Business School and Kenya Healthcare Federation for convening this. So at this point, I'd like to wish you a good evening and see you tomorrow at 9 o'clock. Have a good evening.